So hi guys, welcome to today's stream. I'm Dr. Pawan, and today I'll be covering a few topics for you guys, which will be relevant for your INI-CET exam. Now, frankly speaking, in this next 4 to 5 hours, I'll be covering a few topics, and obviously, it's not like that. These are the topics which are high yield for the INI-CET or something. It's not something which is clickbait or something. But these particular topics are something which is important for any student who is appearing for a surgery exam, may be any, may be INI-CET, may be NEET PG, may be FMG. Obviously, the depth and the quality of the questions will vary from exam to exam. The pattern in which the questions are asked, they might also get varied from exam to exam, but more or less, the topics, the important topics, they remain the same. Okay, so what we'll be covering is we'll be covering the important topics in surgery, let's say in next 5 hours approximately, and we'll start with the basics and we'll try to talk about the important or the new things which are given in your 11 billy or what might come and which you might kind of get stuck or something like that. Okay, so that's the aim of this particular session. I hope you will kind of like this, and if at all, yeah, you can just get back to me. I hope that I am able to am I audible? Like, some people are saying that my voice is a bit lower. Please give the thumbs up if at all the voice has become better now. Yep. Just give me a thumbs up if at all my voice has become better. Once I get a thumbs up from you guys, I'll be starting. Yep. So no, it's still not okay. Okay. Okay, just give me a minute. We are trying to fix it. Just stay with me. We are trying to fix it. Is it okay now? Yeah, guys, please let me know. Is it okay now? Is my voice better, audible now? You guys are able to hear me? Okay, please try the headphones. Okay, so I think Swati is saying that no. Firoz, no. Okay, many people are saying no. Please check the audio, guys. I mean, I think there's. काफी लोग बोल रहे हैं कम है, एक बार प्लीज चेक करेंगे आप? Okay, is it better now, guys? Is it better now? I think it's quite up now. Is it better now? Okay. Okay, so you're saying it's better now. Okay. I think आप एक बार उसको ना थोड़ा सा कम कर दीजिए, वो रेड पे आ रहा है ना, डिस्टॉर्ट होगा थोड़ा सा वॉल्यूम का। रेड पे अभी आवाज आ रहा है, बट जब रेड पे जाएगा ना तो वो डिस्टॉर्ट होता है। रेड मतलब डिस्टॉर्शन वॉल्यूम वाला। Sorry for all this technical problem, guys. Life, right? Some or the other thing kind of goes here and there. So just pardon with me for 1 minute and we'll be starting in 1 minute. It's perfect. It's better. Okay, I think it's okay now. I think it's okay. It's okay. It's okay. People are saying it's okay. Let's start. Okay, so you might still feel a bit distorted sound because I think the volumes are set a bit high, but sorry for all these particular stuff. If at all there's some problem, just get back to me. I will try to kind of fix it up. But yeah, without wasting any further more time, let's kind of start. And thank you so much for patiently waiting for last couple of minutes. It's life. Life is not perfect. So is your preparation, so is the exams, so is life. Okay, so let's start by talking about this. Okay, so what I'll do is okay, no bro, I cannot tell in Telugu. I don't know Telugu. I can at the max tell you in English or Hindi. That's it. So Sachin is telling me, bro, can you tell me in Telugu? No, I can't not tell you in Telugu. I don't know the Telugu. Okay. So yeah, I'll be continuing in English. Let's start. Okay. Yeah. Okay. 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 Okay, Maharshi, people are working on the back end on the audio. Whatever the issue, they will sort it off. I'll just start. And if at all any issues, they will kind of sort it off. They are monitoring the comments as well, so they will do it. Okay, I understand it's not the perfect, but they will kind of sort it off. Don't worry about it. Okay, let's start. I'll start. Even after, let's say, 5 minutes or so, if you're still having some significant problem in the audio, please get back to me. I will kind of try to cover it up. Okay, okay, let's start. Okay, so 55-year-old man presents with the symptoms of dyspepsia and on upper GI endoscopy, an area of patchy erythematous tissue is identified extending proximally from the gastroesophageal junction. Biopsy is diagnostic of the Barrett's esophagus with low-grade dysplasia. Which of the following is most appropriate next step? Okay, now this kind of questions do come nowadays. Okay, so first of all, this particular question is trying to basically they are giving you history and they're trying to tell you that, you know what, when the investigations were done, we found out that, you know what, the patient is having what is called as a Barrett's esophagus. So patient is having so-called Barrett's esophagus, and what they're trying to ask is that if at all there is a low-grade dysplasia on the biopsy, what are you going to do the next? We are going to discuss in detail. Your leadless edition of Love and Bailey talks about the protocol. How do you manage such patients? So yeah, we are going to talk about it. But let's try to take it from the basics. So what are we going to take it from the basics? Okay, so answer over here is what? Distal esophagectomy, upper GI endoscopy with quadrantic biopsy from that particular region, and photodynamic therapy or endoscopic submucosal whatever resection of that area. Okay, so what do you think? What is going to be the answer over here? Okay, yeah, what is going to be the answer, guys? Can you please put the answers in the comment box? Yeah, what is going to be the answer in the comment box? I see. The point is that D. Okay, no, it's not the endoscopic submucosal resection. No, that's not the answer. Not C is not the answer. What else? The answer over here is B, guys. Okay, answer is B. Okay, so let me just explain to you what this particular question is trying to ask you. Okay, now let's start from the basics. Let's start from the basics. What do we have? We may have a patient who might be suffering from GERD. What do you understand by GERD? Gastroesophageal reflux disease. Now, this particular because of this GERD, what is going to happen? The acid reflux is going to happen into the lower part of the esophagus. Because of this, what can happen? The lower part of the esophagus, the epithelium of that, it is not what you call as conducive enough to kind of tolerate that particular stuff. Okay, the lower part of the esophagus is not the one which is going to like tolerate that particular acid. So what's going to happen? The squamous epithelium. Okay, so what happens is the squamous epithelium gets converted to your columnar epithelium. And what do you call it as? Oh, pretty simple stuff. We call it as a columnar metaplasia. Okay, so we call it as a columnar metaplasia, right? Now, what is so big thing about this particular stuff? So columnar metaplasia is important. Why? Because it can undergo dysplastic changes and ultimately it may undergo a malignancy. This is why we kind of want to monitor this columnar metaplasia. So how do you monitor it? So, okay, first of all, how do you diagnose it? How do you diagnose it? So for the diagnosis, what we do an upper GI endoscopy. Upper GI endoscopy. Along with that, we do biopsy. Okay. So in the GERD, the two things which you should remember, like which are a bit advanced, not advanced or advanced per se, but two things which you should remember. First is this Prague C and M classification. Okay. So what is this Prague C and M classification? Okay. So what on earth is this Prague C and M classification? So it's pretty simple, nothing major about this. So this is kind of given in Love and Bailey. Try to understand this. In the Prague classification, what they're trying to say is that, okay, I'll explain you. This is a patient who is having a Barrett's esophagus. So this is the lining of that particular Barrett's. Now in this, the circumferential esophagus is involved up to one particular length, up till here. And then after that, what is there? Circumferential esophagus is not involved. There is a patchy involvement of the esophagus. Are you understanding my point? So what we want is, we want to know how much amount of the esophagus is involved circumferentially and how much amount of the esophagus is involved, like the maximum involvement of that particular maximum length which is involved. So what you need to understand over here is that here we have this circumference. C basically stands for circumferential involvement. C basically stands for your circumferential involvement. Okay, so can you please calculate this particular circumferential involvement with me for this particular esophagus? So here what you have, here you have this. Okay, so it starts from 36, it goes till 33. So this is a 3 centimeters length. So in this particular question, what you need to understand, the circumferential involvement is 3 centimeters. Okay. Now, why I am so much stressing on this particular Prague classification? Because the understanding of this circumferential involvement and the maximum length is important if you want to understand what are you going to do next when the patients come to you with either metaplasia or a low-grade dysplasia or a high-grade dysplasia. So that's what we need to understand. So everybody understood the C? C stands for the circumferential involvement. What about the M? M basically stands for your maximum length. Okay, it stands for your maximum length. Okay, so can you please calculate what is the maximum length in this particular patient for us? So I hope you're able to understand that the maximum length is still 28. It starts from 36. So it is 8 centimeters. So in this, the circumferential involvement is 3 centimeters and the maximum length involvement is 8 centimeters. Am I making some sense to you guys? As per the Prague classification, the C is 3 and M is 8. Okay, if at all you have understood, please kind of give me a, what do you call as a thumbs up. Okay, give me a thumbs up. Okay, Maharshi, this particular session is at least of 5 hours. Let's kind of see how much we can kind of take it forward. Okay, so everybody have understood about the circumferential and the maximum length involvement. I hope you have done. Okay, right. Now what you need to do is, let's say you have done a biopsy. Okay, so what you need to understand, you have done a biopsy. So there was a patient in whom you suspected that, you know what, the patient might be having a Barrett's esophagus. So you did an upper GI endoscopy. You did an upper GI endoscopy. And based on the upper GI endoscopy, what did you found? You found out this C and M kind of thing. Okay, so you kind of classified it into C and M, that's fine. And along with that, what you did a biopsy. So let's say if at all you did a single biopsy, okay, if you did a single biopsy, what you need to understand is that if at all it shows dysplasia, okay, so after taking a biopsy, what you're going to do, you're going to send that particular sample to the pathologist. Okay, so you are going to send that particular sample to the pathologist, and pathologist is going to tell you that whether it is a metaplasia or if there is a dysplasia or not. If at all you send that particular sample to a pathologist and the pathologist tells you that you have a dysplasia, what you have to do? You have to perform a repeat biopsy, or not per se a repeat biopsy. What you need to perform is you have to kind of get it confirmed. You have to get it confirmed by, at least 2 pathologists. And what you need to understand, this biopsy has to be from all the quadrants. You have to take a multi-quadrant biopsy. From all the quadrants, you have to take up a biopsy. If at all you have taken a biopsy from a single quadrant, then you have to kind of repeat a biopsy and take it from all the quadrants, because maybe in one quadrant the dysplastic changes are not clear, or maybe in one quadrant there's a low-grade dysplasia, maybe in other quadrant there might be a high-grade dysplasia. So that is what you need to understand. So 2 points is that when you kind of have a patient with a biopsy report of a dysplasia, you have to get it independently evaluated by another pathologist. This is very, very important. Now, from where this particular thing is coming, this is basically coming from this particular chart. So please look at this at a very, very nicely. Now, I don't know how much it is visible to you, but I'll try to kind of make it visible to you in a good manner. So what do you have over here? So let's say you have a flat columnar mucosa, whatever, you take a systemic cold biopsy. What you need to understand? What do you understand by systemic? Systemic means from all the quadrants. Okay, systemic from all the quadrants. So in this particular question, what you need to understand is that the biopsy was not from all the quadrants, and that is why we have to repeat it with all the quadrants, because only then we will be able to take the things forward. Now here what they're trying to say is that if at all there is a confirmed dysplasia, by like you have to kind of confirm the dysplasia by 2 independent pathologists. If at all a single pathologist is trying to tell you that, you know what, this particular patient is having dysplasia, okay, you kind of value their kind of opinion, but you get it corrected or get it checked. You take a second opinion from an independent pathologist also. Please try to understand this particular point. Okay. Now, after this, I will talk to you about this particular entire protocol. What you need to understand, 3 things can happen. Either the patients are having metaplasia, or the patients are having a low-grade dysplasia, or the patients are having a high-grade dysplasia. So what about the metaplasia? What you need to understand about metaplasia? So let's say if at all there is a patient who is having metaplasia. So over here, as you can see, there is no dysplasia. If at all there is a no dysplasia, now what you need to understand, occasionally you would have heard these particular things in your MCQ, that the patient is having a gastric metaplasia or an intestinal metaplasia. Is there any difference of that? The answer is yes. Okay. So my point is that let's say if at all the patient is coming to you, real life scenario, the patient is coming to you, you did a biopsy, and biopsy basically showed metaplasia. What are you going to advise to this patient? Are you going to advise this patient to repeat the biopsy? And if yes, or let's say repeat an endoscopy. If yes, then when? How many years later? So that is what, these are the questions which are going to get answered by this particular protocol. So If at all there is no dysplasia at all, if at all there is no dysplasia at all, what you need to do, you need to look at the maximum length. Okay, so if at all the maximum length is less than 3 centimeters and you are dealing with a gastric metaplasia, the maximum length is less than 3 centimeters, you're dealing with a gastric metaplasia, you have to repeat the upper GI endoscopy. If at all the length is still less than 3 centimeters and gastric metaplasia, you consider discharging the patient. So gastric metaplasia is considered to be a bit less kind of invasive, less kind of aggressive and all those stuff. Then what we have a maximum length which is less than 3 centimeters, but we have an intestinal type of a metaplasia. If there is an intestinal type of metaplasia, you have to repeat an endoscopy, upper GI endoscopy every 3 to 5 years. Okay, so intestinal metaplasia, repeat an endoscopy after every 3 to 5 years. But if at all the maximum length is more than 3 centimeters, it doesn't matter whether it is a gastric metaplasia or intestinal metaplasia. In these particular scenarios, you have to repeat the endoscopy every 2 to 3. Am I making some sense to you guys? So gastric metaplasia, you have to repeat an endoscopy every 3 to 5 years. And if at all the maximum length is more than 3 centimeters, it doesn't matter whether it's a gastric or an intestinal metaplasia, you have to repeat an upper GI endoscopy every 2 to 3. Okay, I hope you have understood this particular point. This is about if at all there is no dysplasia. Now I'll walk you through this particular stuff, but it's irrelevant. Like from MCQ point of view, it is relevant. All they are trying to say is that if at all the dysplasia is indefinitive, you with the maximum acid separation, you repeat the kind of biopsy, and if at all there is a definitive dysplasia, you manage it according to a low grade or a high grade or something like that. That's what they are trying to tell you. Irrelevant for your MCQ point of view. Now coming to this, if at all you have a low grade dysplasia, if you have a low grade dysplasia which is confirmed by the 4-quadrant biopsy and individually evaluated by two pathologists, then what you're going to do, you are going to put the patients on an upper GI endoscopy with 6 monthly surveillance. 6 monthly surveillance, that is what you're going to do in these particular patients. Okay, and what about the high grade dysplasia? In the high grade dysplasia, you are going to have the multidisciplinary meeting and everything, and you can plan for some intervention, and you can also consider an endoscopic eradication therapy. Okay, so can you guys tell me what is this endoscopic eradication therapy over here? Anybody, can you please tell me what is this endoscopic eradication therapy which you are kind of considering over here? So radio frequency ablation. Okay, so what I'll do is I'll just break these things down for you guys. You had a patient with a GERD. Okay, you had a patient with a GERD. What you did a 4-quadrant biopsy, and I'm just drawing a simplified version of that. If at all there is a metaplasia, you see whether it is less than 3 centimeters is the maximum length, or it is more than 3 centimeters, the maximum length. Okay, and then if you have a dysplasia, the first thing what you need to understand in the dysplasia is you get it confirmed by two independent pathologists. You understand my point? So you get it confirmed by two independent pathologists. Okay, now if at all, okay, you divide this particular thing as further, like if at all there is a length which is maximum length is less than 3 centimeters, you divide it into gastric metaplasia or intestinal metaplasia. If at all there is a gastric metaplasia, what you do, it's okay, like if you repeat the endoscopy, and if at all it's the same, you can discharge the patient. If at all it's an intestinal metaplasia, what are you going to advise? You are going to perform a repeat endoscopy every 3 to 5 years. Okay, so repeat endoscopy after every 3 to 5 years. What about the maximum length more than 3 centimeters? It doesn't matter whether it is an intestinal or a gastric metaplasia. Here, it is a repeat endoscopy every 2 to 3 years. You understand my point? So here I have to repeat an endoscopy every 2 to 3. Okay, got it? Now, coming to the dysplasia. As I told you, in the dysplasia, what you can have either a low-grade dysplasia or you can have a high-grade dysplasia. So if at all there is a low-grade dysplasia, then endoscopy every 6 monthly endoscopy. If at all there is a high grade dysplasia, then what do you have to do? In high grade dysplasia, you have to perform, what do you have to perform? High grade dysplasia, you have to perform you can perform a radio frequency ablation. Okay, so that's what you can consider. Okay, it's not like that every like you basically discuss it in the MDT and then you decide for the intervention, but you can perform radio frequency ablation over here. Am I making some sense to you guys? Yeah. Have you understood this particular point? It's an important kind of a concept which is being tested nowadays. Okay, right? More so in the INI and maybe in a difficult question of a NEET PG or something like that. Now, this is just a simplified version of the protocol which you are just seeing. Now, let's move on to the next topic. Next question rather. Which of the following is false about the enhanced recovery protocol? Okay, so which of these is kind of false regarding the enhanced recovery protocol? IV antibiotics for 72 hours, pain relief by the multimodal kind of analgesics, early mobilization, or early nutrition. So what you need to understand over here, the answer is IV antibiotics for more than 72 hours. Now, what you need to understand is that what is ERAS? Okay, what is ERAS? ERAS basically stands for Enhanced Recovery After the Surgery. Okay, what does ERAS stands for? Enhanced Recovery After the Surgery. So what you need to understand that as a surgeon, okay, we can perform a big surgeries, like we can perform an esophagectomy, we can perform a colectomy and all those particular stuff. But what is our aim? Our aim is not to perform a big surgery. Yeah, that's one of the things. But the surgeon is more happy when the patient basically goes home early and the patient goes home without any comorbidity. Okay, so that is what is something which is more important. And what we have devised over a period of time is something which is called as the set of things which we can do in the pre-operative period, during the surgery, and post-operative period in order to enhance this recovery process. Okay, so this is what you call as a ERAS, that is enhanced recovery after surgery. Now, these particular things have been tested have been included in the latest edition of Love and Billy, and it has been talked about a lot in your latest edition of Love and Billy. I won't be surprised if at all you find a question on the ERAS in your upcoming exams. Okay, so let's kind of talk about this. Okay, so ERAS basically consists of the things which you perform in the pre-operative phase. Okay, this is a post-operative. So the things which you perform in the pre-operative phase, then you perform in the operative, and then on the post-operative phase. Okay, so what I'll do is I will first. Okay, so this is let's talk about it one by one. Okay, so what is this? Okay, so first thing is that what I'll do is I'll first quickly give my kind of talk over it, and then we will go through this particular actual table which is present in your Love and Billy, which is basically for your what you call as your this is what is a ERAS protocol which they have given for your esophagectomy. Okay, so that's what we are going to kind of go through. Okay, so what is included in the pre-operative period? So these are the set of things which we will do in the pre-operative period in order to improve the outcome after the surgery. So what about in the pre-operative period? First is pre-admission counseling. Okay, so what do you understand with the pre-admission counseling? That before the patient is admitted, what you are going to tell to the patient that you know what, this is how the surgery is there, and these are the complications, so this is how the post-operative recovery period which you expect or something like that. So all the queries, all the doubts, all the possible complications of the surgery have to be very well explained to the patient in this particular pre-operative period. Then fluid and carbohydrate loading. Okay, so what is this fluid and carbohydrate loading? So what you need to understand is this nutritional assessment. So what about this nutritional assessment? So when you have any patient, okay, when you have any patient, you want to kind of okay, so if at all the pre-operative nutritional status of the patient is good, obviously the recovery and everything is going to be good. Okay, now what usually happens is that maybe whatever the surgery is there, we tell the patient that you know what, have your last meal whatever time you have, and then you don't have to have anything after the 12 o'clock, and then next day you have to come for the surgery. Now the patients ask us, you know what, when is my surgery kind of scheduled? You might tell them that you come by 8 o'clock, by 8:39, whenever the OT is available, we will take you in the OT. And that's what is usually we do in the clinical practice, right? But what happens is that we don't have only a single case present on that particular day. We have multiple cases. So what happens is that a patient, let's say, ends up going to the operation theater at 12 o'clock or 1 p.m. or something like that. Then what is going to happen? The patient has been starving from let's say night 11 p.m. till let's say 1 p.m. approximately for around 14 hours or so, right? So that basically puts the patients into a state of a negative nitrogen balance. Very, very important. Okay, so the starving, basically puts the patients in a state of a negative nitrogen balance. Okay, now what you need to understand about this is that if at all you give carbohydrate loading to this particular patient, that is going to prevent this negative nitrogen balance, which is actually going to be beneficial for this particular patient. So how do we kind of counteract this? We ask the patient that, you know what, a day before the surgery, you should have a high carbohydrate diet, first thing, and 2 hours before the surgery, we give these particular patients like carbohydrate rich drinks. Okay, so that is what you give to these particular carbohydrate rich drinks. That is what you give to the patients 2 hours before, till 2 hours before the surgery. Are you understanding my point? This is what you need to understand over here. Nutrition assessment, like you put, okay, so here this particular table is specific for your esophagectomy. Okay, this is basically specific for your esophagectomy. This is given in your chapter of the esophagus. So few things will be tailor-made according to the esophagectomy. Okay, so ERAS protocol, is it different for every kind of a surgery? Slightly different, but the basic concepts remain the same. Okay, so just stay with me. When we walk through these particular things, there are many things about the surgery which you will understand, which you will recall, and which we will help you in connecting the dots. Okay, so the whole point is that why do you want to give carbohydrate loading, and why do you want to kind of give the patients carbohydrate rich drinks? Question which they can ask you is that to counteract this negative nitrogen balance, to prevent the patients into into the negative nitrogen balance. Okay, am I making some sense to you guys? I hope I'm making some sense to you guys. Okay, 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 okay. So that is what you need to understand. Then pre-operative exercise. Okay, so what about the pre-operative exercise? General or incentive spirometry. So what do you understand by incentive spirometry? Incentive spirometry means that, I hope that you might have seen this 3-ball spirometers, okay, inside the wards. So there are 3-ball spirometers. Here you have these particular balls which have different colors. You have different colors of these particular balls. Now what you do is you give this particular thing to the patient, and you ask the patient to kind of push these particular, all the 3 balls should kind of go up. You understand my point? This is an incentive for the patient, like taking all the balls up. And while doing this, what happens? The patient exercises the deep breathing, which is going to be helpful for the patient. Now, this is absolutely empirical to be done in the post-operative period, because we want to kind of prevent the atelectasis and everything. But this is also relevant in the pre-operative period, so that now the patient understands how the incentive spirometry has to be done. And now patient already knows, like in the post-operative period, you don't have to teach to the patient. Now patient will start doing this immediately after the post-operative period. Making some sense to you guys? So pre-operative exercise, what exact exercise we are trying to talk about? Okay, general is fine, but incentive spirometry. So what is this incentive spirometry? I hope you understood. This is what is an incentive spirometry. Okay, then we have stop smoking. Obviously, you have to kind of stop smoking, ideally 21 days before the surgery, but at least 48 hours before the surgery, you have to kind of stop the smoking. Chest physiotherapy, yes. Carbohydrate loading on the day of the surgery, as I just explained to you. Okay. Preoperatively, you will assess the nutrition by, let's say, pre-albumin, and if at all you find that the nutrition's kind of status is a bit lower, you might give the patient albumin, or you will build the nutritional kind of component of the patient. But on, like, just before the day of the surgery, you are going to give this carbohydrate loading, and this is basically done to prevent negative nitrogen balance. Okay, right? Now, no need for the bowel preparation unless colonic interposition is kind of planned. So what you need to understand, as a kind of medical fraternity, we are trying to go, or we are trying to move away from the bowel preparation. So you would have given PEG-LAC to the patients, you would have given enemas before the patient, you would have given the clarithromycin and everything for a kind of cleaning of the gut. So what you need to understand is that we are kind of moving away from these particular bowel preparation, because we feel that, you know what, they might actually increase the risk of infection. So again, as I told you, this particular table is specific for the esophagectomy. So until unless we are using colon, you should not follow the bowel preparation. If at all we are using the stomach, no need of the bowel preparation. I hope you have understood this particular point, right? Okay, so this is about the pre-operative. As I told you, no pre-medications, thromboprophylaxis, antibiotic prophylaxis, no selective bowel preparation, no or selective bowel preparation, no prolonged fasting. Okay, we have talked about all these particular concepts in a detailed manner. Now, what about during the surgery? During the surgery, we are going to give the prophylactic antibiotic, like just before the surgery. When do you give this particular prophylactic antibiotic? Anybody? It's an important MCQ. When do you give this prophylactic antibiotic before the surgery? Okay, can you please tell me, guys, anybody? When do you give this prophylactic antibiotic before the surgery? So prophylactic antibiotics are given what you call as 2 hours before the surgery. Okay, so 2 hours before the surgery, you give the prophylactic antibiotic to these particular patients. 2 hours before the surgery, you give the, 1 hour before the surgery, you give the prophylactic antibiotic. Okay, so they might ask you prophylactic antibiotics. When do you give? So 1 hour before the surgery or at the time of induction. At the time of induction of anesthesia. At the time of induction of anesthesia. Okay, please remember this. Now, DVT prophylaxis, yes, you have to give mechanical and pharmacological. Which is better? Mechanical is better. Okay, mechanical prophylaxis is better. That is what you need to understand over here. Now, judicious use of the intraoperative fluids. We as a medical fraternity are trying to move away from overhydrating these particular patients. So we have to use judiciously. Whatever is needed, we'll use obviously, but we will not use a excess of the IV fluids. Avoid hypothermia. Yes, if at all we avoid hypothermia, we end up reducing the risk of mortality and bleeding. So obviously during the surgery we have to avoid the hypothermia, minimally invasive surgery if possible, and epidural analgesics, because that will help you in prolonging the anesthetic effect even in the post-operative period. So that is what is the use of an epidural analgesia. And finally, in the post-operative period, what do we want? Nutrition. So please try to understand, contrary to the traditional thinking that you should not start the food early so that the anastomotic line might get time to heal and all those particular stuff, what we need to understand, we initiate the feeding early. So early initiation of feeding is a component of it. Okay, so POD1, carbohydrate drinks are started, and if at all everything is fine, but POD5 can start the patients on the soft diet. Please try to understand, on POD1 itself, drinks can be started, carbohydrate drinks can be started. Okay, then we have a nasogastric tube. We remove it on post-operative day 1. Okay, in the post-operative day 1 itself, you remove the nasogastric tube. Analgesics, yes, epidural analgesics and the patient-controlled analgesics and the multi-modality analgesics. Obviously, you have to keep the patients pain-free, otherwise the patient's recovery will get altered. Pain-free is very, very important. Chest drain, as I told you, this is specific for esophagectomy. So whenever you do an esophagectomy, you have to kind of put a chest drain. That's fine. Early mobilization, that is very, very important. It is going to prevent or reduce the risk of DVT. Okay, it's going to reduce the risk of DVT. Urinary catheter, you remove as early as possible, because if you don't remove, what is going to happen? There's going to be an increased risk of infection, nosocomial infection, because of the urinary tract infection, intravenous fluids, and DVT prophylaxis. Okay, so I understand, guys, that this might become a bit monotonous for you guys, but this is a newer concept which can definitely be asked to you in your exam. So please try to understand about this ERAS protocol. Very, 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 very important. So what is ERAS protocol? It is enhanced recovery after surgery. That is what we call as a ERAS protocol. Why this has kind of come into place? So that we can ensure early recovery and discharge of the patients from the hospital. That is what is called as a ERAS protocol. Okay, can we continue, guys? Yeah, I hope we have kind of understood, and let's try to continue now. Okay, so okay, now an obese 40-year-old male presents with an episodes of an anxiety. Okay, so there's an obese patient, 40 years old obese patient who is coming to you with an anxiety, confusion, and 1 convulsive episodes. CT brain is normal. An abdominal CT scan shows a small 1.5 centimeters lesion in the head of the pancreas. What is the most likely diagnosis? Okay, so KP Chaudhary is asking, is it useful for the FMG? Well, yes, it will be useful for FMG. I think you asked this particular question because the ERAS protocol, which I covered recently, which was, you felt that, you know what, this was completely kind of something which you might not have ever heard of, but try to understand. Even in the FMG, they can at least ask you, what is the full form of ERAS? Okay, you understand my point? So that topic I can completely understand. That was something which was very, very relatively new, because I think 90% of you guys might not have heard of it or might not have kind of thought about it. But I really anticipate that that question will definitely come in the NEET PG or INI-CET. But this particular question, okay, so let's try to look at this particular question. The answer over here is insulinoma. So don't you think insulinoma is an important topic for your FMG? It's very, very important topic for FMG as well. So are you understanding my point? It is irrelevant which exam you are preparing. there are few topics in surgery which are very, very important. That is what we are covering. I completely understand. ERAS in this step might not be asked your FMG. I completely understand that. I just wanted to cover it because this is a relatively newer topic, which will definitely come into questions at one point or the other. And that's why I just wanted to cover it up. This particular question is insulinoma. Everybody has to know it. Like the students of FMG, students of NEET PG, students of INI-CET, everybody wants to know it. Surgery is not going to change for FMG or NEET PG or INI-CET. Pattern of the questions, depth of the questions can definitely change. Okay, interpretation of that topic will definitely change. Okay, so coming back to you, yes, this particular session is useful for FMG as well. Okay, yep. Okay, moving on. So what is the answer over here? It is an insulinoma. So let's talk about insulinoma first. Okay, so if you talk about insulinoma, what do you think? What is this particular insulinoma? So insulinoma is a, okay, first of all, can you tell me guys, is it a benign or is it a malignant tumor? Okay, so anybody, can you please tell me, is it a benign or a malignant tumor? Insulinoma per se, is it a benign or a malignant kind of tumor of the pancreas? Okay, so insulinoma is basically a pancreatic neuroendocrine tumor. Okay, so let's talk about insulinoma. What is insulinoma? It is a pancreatic neuroendocrine tumor. It is a pancreatic neuroendocrine tumor. Okay, now what you need to understand about this, this is a benign tumor. Okay, what is this? This is a benign tumor of the pancreas. And if we talk about this, the characteristics of this particular insulinoma, this is the most common pancreatic neuroendocrine tumor. Okay, it is the most common pancreatic neuroendocrine tumor. Everybody understand this particular point? Right. Overall. Okay, now if you talk about the distribution of it, okay, if you talk about the distribution, how is it kind of distributed? Very important. The distribution is that it is equally present in the head, body, and tail. Okay, so it is equally distributed in the head, body, and the tail of pancreas. Very, very important. Okay, it is equally distributed in the head, body, and tail of the pancreas. Now, you only tell me, if at all there is a patient who is having a insulinoma. Okay, if at all there is a patient who is having insulinoma, what is this particular patient going to produce? This particular patient is going to produce insulin. Yes, obviously going to produce insulin. And if at all this particular patient is producing insulin, what is going to happen? The patients are going to land up into hypoglycemia. Okay, so patients are going to land up into hypoglycemia. Obviously, there's no rocket science in this, but based around this particular fact, they have created a triad. What is the name of the triad? Anybody? Can you please tell me what is the name of the triad which is associated with the insulinoma? Okay, it is called as a Whipple's triad. Okay, what is it called as a? It is called as a Whipple's triad. Now, what are the components of the Whipple's triad? The patients are having the features of hypoglycemia. What do you understand? Features of hypoglycemia? All these things which we just talked to you about. Okay, so patients are going to have, let's say, anxiety, sweating, Patients may also have what you have a convulsion. So all these are the features of what you call as your, these are the features of your hypoglycemia, right? Now, if at all you check the blood sugars, okay, if at all you check the blood sugars, what is going to be the blood sugar in this particular patient? Obviously, it's going to be low, so it is going to be less than 50 milligrams per deciliter. And rocket science, right? If at all the patient is having hypoglycemia, if you give glucose to this particular patient, patients are going to feel better. So the symptoms resolve on taking glucose. You understand my point? When you give glucose to this patient, the symptoms resolve, and this triad is called as the Whipple's triad. It actually has no kind of meaning. All the three things are kind of interrelated with each other, but you should remember this is what is your Whipple's triad. Okay, I hope you have understood this point. Now, the whole point is that you suspect that, you know what, the patient is having a hypoglycemia, like this particular insulinoma. With these particular stuff, obviously you suspect that. If I ask you, what is an investigation of choice? Anybody? What is an investigation of choice for this, guys? Anybody? I want you to answer. Please put your answers down in the comment box as well. Because see, guys, when I put things on the slide, obviously you'll remember it, right? But if at all you put your answers on the comment box, it's like you're actively recalling it from your mind. So as a student, as like this particular individual, the problem is not putting information in your mind. So once the information is in front of you, obviously you'll feel, yeah, that is what is the answer. But until unless it is not in front of you, you have to kind of retrieve it out of your mind, and that is what is very, very important. Okay, so what is investigation of choice over here? I hope you're answering it on the other end. 72-hour fasting glucose testing. Okay, so what is an investigation of choice? 72-hour fasting glucose. Okay, fasting, 72 hours fasting. What fasting glucose? 72 hours fasting. That and you keep the patients fasting for 72 hours, and then you check for the glucose and the signs and symptoms and everything. Am I making some serious sense? Okay, yeah. Glucose tolerance test. No, glucose tolerance test is to basically done in the pregnancy, right? To see whether the patient's ability, like body's ability to handle the glucose. Over here, it is not going to be the glucose tolerance test. Here, it is going to be the 72 hours fasting. So normally, what you need to understand, obviously you will feel hungry if at all you fast for 72 hours, but your body will mobilize your glycogen and other things from your body and will maintain the glucose levels. You're not going to be hypoglycemic, or you are not going to have convulsions if you kind of fast for 72 hours. You'll be intensely hungry, you'll be agitated or some, but you will not have these convulsions and all those particular stuff. Am I making some sense to you guys? Because your glucose level will be maintained at a reasonably normal level because of the homeostasis mechanism of your body. In these patients, that's not going to happen. In these patients, because they have an excess of insulin, what is going to happen is the patients are going to land up into hypoglycemia. So, okay, so if at all you are doing it for 72 hours, do you continue for 72 hours? No. You can stop the test in middle if your glucose levels if glucose levels fall below 50 milligrams per deciliter. Okay, and you still that you know what the patient is having insulinoma, and you are kind of stopping this particular test right now. Okay, that is one thing. But have you ever heard of factitious disorders? Okay, have you ever heard of factitious disorder? What is this factitious disorder? This is like Munchausen syndrome by proxy. So here what happens, the patients like it when they basically go to the doctor and get themselves evaluated with the big diseases and all. So some patients might do that, they might inject the insulin from outside and they will come to you saying that, you know what, we have insulinoma. So how do you kind of distinguish the factitious disorder from actual insulinoma? Can anybody help me with this? Okay, how do you kind of distinguish the factitious disorder from the actual insulinoma in these particular patients? Anybody, guys? Anybody? Okay, so how do you kind of distinguish? Okay, this is by C peptide. Very nice. Okay, by looking at the C peptide levels. So you distinguish by C peptide levels. If at all the C peptide levels are high, it means that whatever the insulin is there in the inside the body, it was endogenously produced. Okay, so this was an endogenously produced insulin. That is what is the C peptide levels are high. If at all the C peptide levels are low, means that insulin was injected from outside. Injected from outside. And now you're dealing with a factitious disorder. Are you understanding my point? So very, very important. How do you distinguish? That is by the C peptide levels. And then you can also look for the insulin to glucose ratios and all those particular stuff. Yeah, that's all fine. But the main thing which you need to understand is 72 of fasting. You have to check for the C peptide level. I'll kind of quickly go through this. So insulinoma, it can be sporadic 90%, minimum it's associated 10, that's fine. Diagnosis by the neurological symptoms and the sympathetic activation. So confusion, lethargy, seizures, tremors, sweating, all those particular stuff. Okay. Now, what about the localization? So if I ask you about the localization of this, okay. Now, what did you tell me, guys? That insulinoma is a benign. Okay, it is benign. So if I ask you, what is the management of it? Okay, if I ask you, what is the management of the patients with insulinoma? It is enucleation. It is enucleation. Okay, so they have asked you so many times that what is an investigation of choice to localize insulinoma. Okay, intraoperatively. In the intraoperative period, what is the investigation of choice to localize insulin? What is the answer? Answer over here is, what is the answer over here? Intraoperative period, what is the investigation of choice to localize the insulinoma? The answer is endoscopic or whatever, ultrasound. Okay, what is it? It is ultrasound. Okay, the answer over here is an ultrasound. Usually it is an endoscopic ultrasound. Okay, so investigation of choice is an endoscopic ultrasound or an ultrasound. That is what you need to understand over here. Now, if they talk about the pre-operative, if they talk about the pre-op period, what is an investigation of choice to localize this? It is an MRI. In the pre-operative period, if you want to diagnose the patients with an insulinoma, MRI is better to kind of localize it. But the intraoperatively, most of the times what they have asked you is the intraoperative only. If they ask you about the pre-operative, then the answer is MRI. Please try to understand. Intraoperative, it is ultrasound, no doubt about it. But pre-operative period, it is MRI. Please do remember. Okay, and treatment is enucleation. Okay, so this is all the things about the insulinoma which you need to understand. Let's kind of move on to the next topic over here. Okay, now a 73-year-old male is recovering from a stroke but is kind of deemed to have an unsafe swallow. Okay, so okay, apart from CVA, his past medical history includes that the blah blah blah. There's a previous history of esophagectomy. Esophagectomy was there. What is the best option for a long-term feeding in these particular patients? Okay, so what is this particular question? That there is a patient who suffered from CVS, stroke. After that, maybe the patients are not able to kind of have food in a proper manner. So what you need to do is you need to kind of give them nutrition. Obviously, if at all they're not going to have a food by their own, you have to give them nutrition. All they are trying to ask you is that what is the best method of feeding these patients? And in the medical history, what they are trying to give, that they have given you a couple of comorbidities and everything, but more importantly, what they have given you, that there is a previous history of esophagectomy. Which of the following is a long-term feeding for these particular patients? Endoscopic insertion PEG, surgically inserted PEG, surgically inserted feeding jejunostomy, TPN via the peripheral venous access. Okay, so what do you think? What is the answer? It is surgically inserted feeding jejunostomy. Okay, now what is this particular concept of the feeding? Or let's talk a bit about your surgical nutrition. Okay, so let's talk about the surgical nutrition. Okay, so what about this particular surgical nutrition? So let's say if at all there is a patient who is coming to the hospital and it is anticipated, okay, it is anticipated that the patient will not be able to feed for more than 7 days. Then you have to look for some alternative sources. So what is there? We have alternative enteral sources, enteral kind of methods. What are the alternative enteral methods? We have PEG, percutaneous endoscopic gastrostomy. We have feeding jejunostomy. Okay, then what do we have? We have total parenteral nutrition. Okay, and we also have a nasogastric tube, and okay, nasogastric as the nasovaginal tube over here. So here is the nasogastric or a nasovaginal tube, whatever. In the enteral feeding, what you have in the parenteral feeding, what you have? Obviously, you have only TPN over here. What do you have? You have a total parenteral nutrition over here. Making some sense to you guys here? So in the surgical nutrition category, what do you have? You have, okay, so what you need to understand, whenever you are dealing with any particular patient, for example, acute severe pancreatitis, or let's say a cerebral vascular accident or a severe head injury, okay, you have to anticipate whether the patients will be able to initiate their feeding within 7 days. If yes, then that's great. If not, then we have enteral feeding options like the PEG, feeding jejunostomy, nasogastrostomy, or you have nasogastric tube, or we have a TPN. Now, what is preferred? Enteral feeding is preferred or the TPN is preferred? Can you please help me with this, guys? What is preferred? Enteral feeding is preferred or the TPN is preferred? So obviously, enteral feeding is preferred. Why? Why enteral feeding is preferred? What you need to understand is that we have the intestine. Okay, inside the intestine, what do we have? We have a mucosa. Okay, so we have to maintain this particular mucosal barrier. If at all we don't use this gut, okay, if at all the gut is not used, if at all this particular gut is not used, what is going to happen? The mucosal barrier will be lost, and what can happen? The gut flora, there is a bacteria which is basically present in this gut. There can be translocation There can be translocation of the gut flora. You understand my point? There can be translocation of the gut flora. That what can happen. That is why we always prefer enteral feeding as compared to that of a parenteral feeding. Now, the crux in this particular question was esophagectomy. So if at all there is a previous history of esophagectomy, the stomach would have been used as a conduit. Okay, so stomach is not usually, it's not present inside the abdomen. It is basically present as a conduit in the in the chest, right? So what you need to understand here, the best feeding option is surgically inserted feeding jejunostomy tube, because we are talking about the long term. Okay, so long term, that is what is a surgically inserted feeding jejunostomy. Okay, I hope I have made some sense over here. Okay, now let's move on to the next question. Okay, so let's move on to the next question. A 63-year-old man undergoes a total gastrectomy for carcinoma of the stomach. Which of the sequelae would least likely occur? Okay, so after a total gastrectomy has been done, which of these particular complications will not occur after the gastrectomy? Can you please help me with this? What is the answer over here? Okay, guys, what is the answer over here? Is it like the metabolic bone disease, or bile reflux, dumping syndrome, or zinc deficiency? What is the answer over here? Okay, so the answer over here is a zinc deficiency. That is what is taught. Oh, dumping syndrome will definitely occur, right? Dumping syndrome is one of the very, very important complications, right? A or D? Okay, it's D. It's D, guys. Okay, it's a zinc deficiency. Metabolic bone disorders will also occur in these particular patients. Calcium absorption will get affected. That is why the bone disorders will occur. Okay, so now let's talk about this. The following may occur following gastrectomy. What all? Small capacity, that is early satiety, that's fine. Then dumping syndrome, obviously it's a very, very important thing. Bile gastritis, afferent loop syndrome, anemia, vitamin B12 deficiency. Why? Because the intrinsic factor which is produced by the stomach will not be able to be secreted, and that is why, because of the deficiency of this, what is going to happen? There's going to be the vitamin B12 deficiency. Metabolic bone disease, and because the acid will not convert the iron into the absorbable form, that is why the iron deficiency anemia can also happen. The two types of anemia can happen in the patients with a gastrectomy. One is iron deficiency anemia, because the iron is not getting absorbed properly. The second is vitamin B12 deficiency anemia. This is because of the deficiency of the intrinsic factor. Making some sense, you guys? So here definitely the answer is what? The answer is what? Zinc deficiency. Okay, so now what you are going to do, we are going to talk about the few of the complications of this particular gastrectomy. Okay, so first of all, can you please tell me what are the two types of the gastrectomy which you know of? So what is Billroth 1, what is Billroth 2? Okay, so let's say if at all there is a stomach, if at all there is a stomach, and if at all there is, let's say, a lesion over here. Okay, so there's a lesion over here. Once you excise it, what you can do is either you can perform a gastroduodenostomy. Okay, you can perform a gastroduodenostomy. So we have a gastroduodenostomy. What is it called as? This is what is called as a Billroth 1. Okay, what is it called? It's called the Billroth 1. Or what we can do is we can do a loop gastrojejunostomy. We can do a loop gastrojejunostomy. So this loop gastrojejunostomy is something which is called as a Billroth 2. Okay, Billroth 2. Okay, so now one of the most important complications of this, what you call as a gastrectomy, is what? It is a dumping syndrome. What I'll do is I'll spend some time with you in explaining you the dumping syndrome. It's very, 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 very important. Okay, so let me start by asking you that in you and me, what is going to happen? Okay, so in you and me, what is happening? That we have the stomach, and at the end of the stomach, what do we have? We have this pylorus. Okay, what do we have? This pylorus. Okay, so at the end of the stomach, we have the pylorus. So whatever the food we eat, it gets accumulated inside this particular stomach, and with every peristalsis, okay, with the peristalsis, what is happening? A small amount of hyperosmolar chyme. What is this hyperosmolar chyme? What do you understand by this hyperosmolar chyme? What do you understand by this? This, what is present over here? This is what is called as a hyperosmolar chyme. What is this? This is hyperosmolar chyme. What do you understand by hyperosmotic? It means that higher osmolarity is there, and whatever the food particles are, that is what is called the hyperosmolar time. Okay, so what happens is, because whenever we do the peristalsis, some small amount of the hyperosmolar chyme is entering into the intestine. Small amount is entering into the intestine. Okay, so small amount is entering into the intestine. That's what is happening in you and me. Now, after gastrectomy, okay, after gastrectomy, what is happening? After gastrectomy, what is happening? Is there anything which is between the stomach and the duodenum or stomach of the jejunum or something? No. So after gastrectomy, what happens? A large amount of hyperosmotic food is entering into the intestine. At once. Okay, at once, what is happening? A large amount of hyperosmotic substance is entering into the intestine at once. Okay, so because of this, there are a few things which are going to happen. Let's kind of talk about this. Okay, so what you need to understand is, let me just draw and explain to you. Okay, so here what you have this particular stomach, and let's say I'll just, for the simplicity sake, I'll just draw a jejunum or whatever the duodenum. It's a bit larger. Okay, so just for the sake of simplicity, what I'm doing is this particular, I'm drawing it a bit larger. That's fine. Okay, so what is happening? Whatever the food particle you have eaten, obviously this is hyperosmotic. This hyperosmotic substance is coming into the intestine. So what is this? This is hyperosmotic. Okay, this is hyperosmotic. Okay, so if at all there is a hyperosmotic, what is going to happen? It is going to sequestrate the fluid inside it. What do you understand by hyperosmolarity? That is having a hyper, like it is having a more, what do you call, as a capacity to sequestrate the water. So because of this, what is happening? It is sequestrating inside it a large amount of water. Okay, yeah, it is what is called as it is kind of taking in a large amount of water inside the intestine. So because of this, what is going to happen? There is going to be an increase in the peristalsis, and this increase in the peristalsis are ultimately going to lead to the osmotic diarrhea. Okay, the patients are going to land up into osmotic diarrhea, and because of this, what is going to happen? The patients are going to have the features of dehydration, like palpitation, and like patients are going to have the features of dehydration, palpitation, and all those particular stuff. Okay, so this is what is called as the dumping 1 syndrome. So let me just walk you through the dumping 1 syndrome. This is what is happening early. What do you understand when early? So within 30 to 40 minutes. Okay, so once the patient has kind of eaten food or anything, within 30 to 40 minutes, the patients land up into this early dumping syndrome. Okay, so in this, what is happening? There is an osmotic diarrhea because the large amount of hyperosmotic food is entering into the intestine. Because of this, the water is getting sequestrated into the intestine, and because of the increased peristalsis, there is going to be diarrhea. So there is going to be epigastric fullness, sweating, lightheadedness, tachycardia, colicky, and sometimes diarrhea because of the dehydration. Because of the dehydration, the patients are going to land up into all these particulars. Okay, so this is what is your dumping 1 syndrome or early dumping syndrome. Okay, then what we have is a late dumping syndrome. So what happens in the late dumping syndrome? You can just understand it in this particular manner. This high amount of the like hyperosmotic substance which is entering into the intestine, it is going to what you call as a stimulate certain receptors, which is going to go to the pancreas, and it will tell the pancreas that, you know what, secrete a large amount of insulin. So pancreas is going to secrete a large amount of insulin. Okay, so pancreas is going to secrete a large amount of insulin. Now the insulin has been secreted, but what about these particular substances? Were they absorbed? They were not absorbed. So there is relative excess of the insulin. Okay, what is there? There is a relative excess of the insulin, and because of this, the patients land up into hypoglycemia. Okay, so because of this, the patients land up into hypoglycemia. Okay, so this is what is called as a late dumping syndrome. In the late dumping syndrome, what is there? There is a relatively excess amount of insulin which is there. What is happening in the early dumping syndrome? In the early dumping syndrome, there is an osmotic diarrhea which is happening, which is leading to the dehydration, which is leading to the palpitation and other stuff. Okay, how can we treat it? Okay, so you can treat it in a way. Okay, how can we treat it? So there's something which is called as a relieving factors and an aggravating factor. What about the type 1? In type 1, if you like the early dumping syndrome, if you kind of lie down, it is going to relieve your symptom. Okay. And if at all you eat your food more, that is what is going to kind of increase your symptom. First, I'll talk to you about the relieving and the aggravating, and then I'll talk to you about the treatment. What about the late dumping syndrome? The late dumping syndrome is because of the hypoglycemia. So if at all you give food to the patient, it is going to relieve it. Okay. So if you give food, that is what is going to relieve the symptoms of late dumping syndrome. Now coming to the treatment, how exactly you kind of treat it. So what you need to advise to the patients is, first is the conservative management. What do you understand with the conservative management? In this, what you basically do is you ask the patients to kind of have frequent small meals. Okay, so you ask the patients to have a frequent amount of small meals. You ask the patients to have recurrent frequent meals. That is something which is important. Then you ask the patients to have food which is rich in fat and the proteins, because the food particles which delay the gastric emptying. Okay, so if at all the food particles are there which are going to delay the gastric emptying, they are basically going to relieve the, or they're going to reduce the severity of these dumping syndrome. Okay, the most important thing is frequent amount of small meals. Okay, so that is what you need to understand. And finally, if at all it is kind of not helping at all, or if at all it is kind of continuing to cause symptoms in these particular patients, finally there's a surgical intervention. So what you need to understand is that this dumping syndrome is more with the type 2 dumping syndrome. So in this, what you can do, we can convert the type 2 into the type 1, or the Roux-en-Y gastrojejunostomy can be done. These are the things in which you can treat this particular dumping syndrome. Okay, you can, if at all it is so much bothersome, then you can kind of treat it with the surgery. Otherwise, you can go ahead with the conservative management, like the frequent small meals and food which decreases the gastric emptying. Okay, and this is important. This has been asked, frequent small meals. Okay, okay. Now let's talk about the next question. Right, Ethan, I hope you got this right. Now I'll give you a clinical scenario. I'll give you a clinical scenario that, you know what, you did an upper GI endoscopy in one particular patient, and in the upper GI endoscopy you found a image like this. Okay, you found that there was a mass which was not ulcerative, which was not fungating, which was not bleeding, but there was a mucosa which was covering this particular mass. Okay, so you decided to do an endoscopic ultrasound in order to look about this particular mass in much more details. So you did an endoscopic ultrasound, and this is what is the image which you have. In order to help you, what I'll do is I would kind of ask you to focus on this particular part. Okay, so what is this? Can you please help me? What is the diagnosis of this? Anybody? Can you please help me? What is the diagnosis of this particular patient? Yeah, guys, what is the diagnosis of this particular patient? Can you please help me with that? Okay, so the diagnosis of this particular patient is esophageal leiomyoma. Okay, what is the diagnosis? It is esophageal leiomyoma. Okay, so what you need to understand over here, this is what is an esophageal leiomyoma. This black colored thing which you are able to appreciate in this particular ultrasound, this is what is showing you the muscle component. So this is what is an esophageal leiomyoma. Everybody have understood this particular point? Now, if I don't know, okay, that's fine. Okay, so how do you kind of recognize this? You all know that endoscopic ultrasound is something which is done for the esophagus and everything. Please understand, there are two things. If I ask you what is the investigation of choice to look for T and N stage of the esophageal cancer, investigation of choice to look for T and N stage of the esophageal cancer, the answer comes as endoscopic ultrasound. Because by doing an endoscopic ultrasound, we can understand about the depth, how much of the depth is involved of these particular wall. Okay, please try to understand over here. Okay, so on the endoscopic ultrasound, if at all you find that there is this black, like there's a hypoechoic kind of a thing, that is what is trying to tell you that, you know what, you have a muscle layer over there. So like a muscularis mucosa or a muscularis propria, that also appears black. On the other hand, the mucosa, the submucosa, all those particular things appear white. Okay, that is the basics about the endoscopic ultrasound. Now here, what you're able to appreciate is there's a black colored kind of a tumor over here. It's hypoechoic, right? So what you need to understand, this is what is your muscle component. So what it can be esophageal leiomyoma. Everybody have understood this point? Now, my question is, will you perform a FNAC in this particular patient? Okay, will you perform FNAC? So what you need to, FNAC, right? You might think that, you know what, let's kind of do an FNAC to, in order to diagnose this particular stuff. Or rather a biopsy, FNAC or a biopsy, will you perform that in these particular patients? Okay, so it's nothing like you cannot, you can do that. Yes, you will. Okay, so what you need to understand, why you will not? Anybody? Why will you not do this particular FNAC or biopsy? So you might say that, yeah, you can do that. I mean, if you want to do, you can definitely do that. Not an issue. You can, but it is not usually done. Why it is not usually done? Because of the management. So what is the management of this particular patients? Is enucleation. It is enucleation. So if at all you perform a biopsy or FNAC, what is going to happen? Let's say if at all this is the muscle component of it, it will get adhered to the mucosa. Okay, let's say if at all this black color is the mucosa, and if at all, let's say you have done the what you call as a FNAC or biopsy, what is going to happen? This particular layer is going to adhere to the muscle component of it. So now when you're trying to perform the what you call the enucleation over here, you are going to face a problem, because here at this particular point of time, the mucosa will be adhered to it. So that is why it is not preferred. It is not preferred to do a FNAC or biopsy, but you can do it. It's not like it's contraindicated. It's usually not done. Somebody asks you, will you do it? No, you will not do it. You understand my point? You will not do it. Okay, why? Because the treatment is enucleation. Now, why I am covering this? Is it like such an important topic or something like that? So please try to understand. When the newer technique comes, they basically try to ask you. Okay, so when the poem had come, so you were talking to me about the FMG, right? When the FMG, this particular question was asked, poem, POEM, is used for. Can anybody tell me where is this poem, POEM used for? Poem is used for what? Achalasia cardia. Very nice. Okay, so poem's procedure is used for the achalasia cardia. In the similar manner, what they have come up with this stir. What is the stir technique? It is a submucosal tunneling endoscopic resection. Okay, submucosally tunneling endoscopic procedure. So this is what is called as a stir. Okay, I don't know how much it's visible to you. I think some contrast issue, but what you need to understand over here, submucosal tunneling endoscopic procedure. So now they can ask you, the stir is used for what? So I hope you're able to appreciate what you're doing over here. You're entering into the mucosa over here. You are excising this particular leiomyoma. You are enucleating this leiomyoma and you're taking it out. Are you understand my point? So this is what is a stir procedure. This is what is for the excision of a leiomyoma. So all you need to understand is stir, S-T-E-R, is used for esophageal leiomyoma. Am I making some sense to you guys? I hope I am. Okay, please do remember this. It is important for you guys. Okay, now moving on to the next question. Okay, now I give you another scenario. I give you another scenario where what you need to understand is that there is a patient who was having a massive upper GI bleeding. Massive upper GI bleed. So because the patient was having a massive upper GI bleed, what you did an upper GI endoscopy. Okay, so you did an upper massive, like you did an upper GI endoscopy. Now, what would you expect? Like if you do a upper GI endoscopy, what are you going to expect? You're going to expect that, you know what, the patient might be having what you call as some major ulcer or some major cancer or something like that. But nothing of this sort is present in this particular patient. So what are the findings on the upper GI endoscopy? What you need to understand? On the upper GI endoscopy, what did you find? You found that the mucosa was normal and there was bleeding which was happening from a pinpoint source. Okay, so bleeding was a bit more, like this is how the bleeding was. The bleeding was a bit more, but it was happening from one single point. Okay, so this was the bleeding which was happening from one single point, and surrounding this particular point, the mucosa was absolutely flat. The mucosa was absolutely normal. Can you please tell me what is the diagnosis of this particular patient? It's important. Okay, can you please help me with the diagnosis of this particular patient? What is the diagnosis of this particular patient? So the surrounding mucosa was normal, but the bleeding was happening from one single point. So what is the diagnosis of this particular patient? Anybody? So the diagnosis of this particular patient is Dieulafoy's lesion. Have you ever heard of this Dieulafoy's lesion? No, it's not ulcer. See, if at all it would have been an ulcer, you would see that, right? You would see the ulcer. Obviously, ulcer will be visible. I'm telling you that the mucosa is absolutely normal, but the bleeding is happening from one particular pinpoint source. Answer over here is, I'm pretty sure, like I understand your problem. The image is not kind of coming in a very, very nice manner, but I'm giving you the history, right? I'm giving you the history that there was no ulcer, the mucosa was normal, and the bleeding was happening from a single point source. Answer over here is what you call as a Deulefoy's lesion. Okay, so please try to understand Deulefoy's lesion. So what is the Deulefoy's lesion? Deulefoy's lesion is a condition where the mucosa is more or less normal, but there is a submucosal dilated vessel. Submucosally, just below the mucosa, there is a dilated vessel, and from that particular vessel, from one point, the bleeding is basically happening. So this is what is called as a Deulefoy's lesion. Hope you have understood this particular point. Important is, how do you manage this? Okay, so how do you manage these particular patients with the Deulefoy's lesion? So the management is, to begin with, what you can do is you can go ahead with the clipping. Okay, so you can clip this or whatever is from the bleeding point. You can also use an electric cautery. You can use like a argon beam coagulation. Okay, so argon beam coagulation. Okay, you can use that. And finally, if nothing, then you can go ahead with a wedge resection. Okay, so finally you can go ahead with a wedge resection. Yeah, ablation and wedge resection. Okay, understood, guys? Yeah, I hope you have understood this point. Now, this is what is a Deulefoy's lesion. At least the case scenario, you should definitely try to understand what is wedge resection. So let's say you have a stomach, you kind of dissect that particular. That is what is a wedge resection. Okay, right. Which of the following statements relating to the biliary atresia is untrue? It is most commonly presented as a prolonged conjugated jaundice in a neonatal period. It may be confused with Algeli syndrome. The Kasai procedure is best performed in the first 8 weeks of the life. Survival following the successful Kasai procedure is approximately 45% at 5 years. What you need to understand over here is that the rest 3 are kind of true. Okay, the rest 3 are kind of true. So here, by ruling out, the answer becomes D. Okay, so let's kind of talk about the biliary atresia. So what is happening in the patients with the biliary atresia? What is the biliary atresia? What do you understand by the biliary atresia? Biliary atresia. So here what is happening that, okay, so in the patients with the biliary atresia, what is happening is that the patients are born at birth, there is atresia of your bile duct. Okay, that is what is your biliary atresia. That's what it's. Okay, so atresia of the bile duct. So if at all the bile ducts are not kind of patent, what is going to happen? The bile will get accumulated and the patients are going to land up into conjugated, like the patients are going to have whatever the jaundice, right? Patients are going to have a jaundice, right? So because the bile flow will be a problematic, what is going to happen because of that? The patients will be jaundiced. Okay, I hope you are able to understand this particular point. In the biliary atresia, the patient will be jaundiced, right? Now, what you need to understand is that what are the types of the biliary atresia? So we have the portal type. This type 3 is the one which is most common. Okay, what is the most common type of biliary atresia? Type 3. So here what is happening? In the type 1, it is just beyond this particular common bile duct. In type 2, it is involving the type 2A, it is involving the confluence. In the type 2B, it is basically kind of involving the common hepatic duct and the common bile duct. And in the type 3, it is going till the porta hepatis. Which is the most common one? Type 3 one. It is going till the porta hepatis. Okay, right. So this is what is about the biliary atresia. Now talking about the investigation. So how do you investigate these particular patients? So for the diagnosis aspect, what you need to understand is that you can perform an ultrasound. On the ultrasound, what are you going to find? On the ultrasound, you're going to find a triangular cord sign. Okay, so triangular cord sign is something which you basically find in the patients with biliary atresia on ultrasound. Now, what else you need to understand over here? That you can perform a biopsy. Okay, so why do you perform a biopsy? In the biopsy, what you're going to find? You're going to find the features of biliary cirrhosis. Biliary cirrhosis. That is what you're going to find. And on the biopsy, the another reason why you basically perform this particular biopsy is to rule out other possible diagnosis. Okay, to rule out other possible diagnosis, you are going to perform the biopsy. Okay, now what else you can do? You can perform a HIDA scan. You can perform a HIDA scan. In the HIDA scan, what is going to happen? The liver may take up this particular dye, but for the excretion from the liver, the dye will not get excreted. Okay, because the bile duct is basically completely atretic. Okay, so no excretion of the dye from the liver. Okay, so this is what you basically get on the HIDA scan in these particular patients. Okay, so ultrasound, biopsy, and the HIDA scan. These are the things which you need to understand over here. Okay, so I'll just walk you through it. Imaging studies on and biopsy. Fasting ultrasound is the gold standard. That's fine when the biliary atresia is suspected. Fasting ultrasound is the gold standard technique. A shrunken gallbladder and a hyperechogenic liver, that is triangular cord sign. So what is this triangular cord sign? Shrunken gallbladder with an hyperechogenic liver hilum. This is what is called as a kind of triangular cord sign, or a cyst at the liver hilum with the one bile duct dilatation are associated with the anomaly supporting the diagnosis. So triangular cord sign is basically supporting the diagnosis. Hepatobiliary scintigraphy may reveal the diagnosis, but MRCP is highly sensitive and specific in the diagnosis. So they are saying that, MRCP is also very, very highly sensitive and specific. But they say that a fasting ultrasound is the gold standard. Okay, now inflammatory cells, fibrotic liver parenchyma exhibiting signs of cholestasis and the biliary nodular structures establish the definitive diagnosis of the liver biopsy. So why I'm kind of putting this particular screenshot over here? Because they have asked you in the past, what is an investigation of choice for the biliary atresia? It is impossible to tell. Okay, so as you can see over here in one paragraph only, this is basically from 11 Bailey. Fasting ultrasound is a gold standard, and then inflammatory cells and all these particular things give you a definitive diagnosis on liver biopsy. Okay? They help you in establishing the definitive diagnosis on the liver biopsy. So what you need to understand is that one thing in isolation is not good. So ultrasound with the liver biopsy, this is what I would say is the best method to diagnose the patients with biliary atresia. Okay, so please try to understand, right? Everybody have understood? You would have come across these particular things, right? What is an investigation of choice for the biliary atresia? Depends. What is the framing of the question, or what are the options you will have to write down? But it basically goes beyond between the liver biopsy and the ultrasound. Fasting ultrasound is the gold standard. Okay. Now, cholangioscintigraphy is required to define the surgical anatomy. That's all. Now, what are the differential diagnosis? These include other cholestatic jaundice in the neonates. Okay, so cholestatic jaundice, that is the obstructive jaundice, that is like this, not going to happen only with this biliary atresia. Alpha-1 antitrypsin deficiency, cholestasis is associated with the intravenous feeding, choledochal cyst, and yeah. So, what is the differential diagnosis? First is what you call as your alpha-1 antitrypsin deficiency. Then we have cholestasis, which are associated with the intravenous feeding, that is your TPN, and then we have the choledochal cyst. Okay, we have the choledochal cyst. Then we have a choledochal cyst. Just 1 minute, guys. Yeah. Okay. So yeah, sorry guys, there was some technical issue. Okay, I'm back. So what I was trying to tell you that there is Okay, so they have asked you in the past that what is an investigation of choice for the biliary atresia? As I told you, it is a very unfair question to be asked because as you can see, your 11B is trying to say that fasting ultrasound is what you call as a gold standard. Then liver biopsy is also the one which is very, very definitive in taking the like diagnosis of the biliary atresia. So it is unfair question to be asked, but what I personally feel is ultrasound along with the liver biopsy is going to give you the diagnosis. Then I talked to you about the differential diagnosis. As I told you, that in the neonatal period, biliary atresia is not the only cause of this particular obstructive jaundice or the cholestatic jaundice. What you need to understand, what are the other causes? Sulfonyl antiseptin deficiency, cholestasis associated with the intravenous fluid, and choledochal cyst. Okay, so what do you understand by this? Cholestasis associated with the intravenous fluids. So what you need to have intravenous feeding. What you need to understand is why do you get the bladder contraction, the gallbladder contraction? Gallbladder contraction happens when the food basically reaches the intestine. It produces cholecystokinin. The cholecystokinin acts on the gallbladder, and the if at all, what you need to understand is that if you put the patients on the total parenteral nutrition, the intestine will not get stimulated, and because of this, the cholecystokinin will not get produced, and because of this, the bladders might not get contracted. Am I making some sense to you guys? So if you would have noticed, if you have managed the patients of patients who are on the chronic TPN, you would have noticed that if at all you put the patients on a prolonged TPN, if you put the patients on a prolonged TPN, what would you notice is, you would notice that there is a chance of a liver dysfunction in these particular patients. So you have to kind of monitor the LFT of these particular patients. There's a chance of liver dysfunction for the very simple reason that the gallbladder is not getting contracted and there's a biliary stasis over here. So in the neonates, obviously, if at all there is a cholestasis which is associated with the intravenous feeding. So we're just trying to correlate you that TPN can also lead. This is what is a TPN, right? So TPN can lead to the cholestasis. That was just I was trying to tell you over here, okay? And choledochal cyst, all these particular things are there. The most common differential diagnosis is Algeli syndrome. So yes, Algeli syndrome, you should remember, this is the most common differential diagnosis of the patients with biliary atresia. What is this Algeli syndrome? Biliary atresia, congenital kind of heart disease, skeletal and other abnormalities. Okay, then progressive blah blah blah, all these particular things are fine. Neonatal hepatitis is the most difficult to differentiate. Liver biopsy and radionuclear excretion scans are helpful. So as I told you, liver biopsy is going to help you in distinguishing the diagnosis of biliary atresia from the other diagnosis. So if you want to choose between ultrasound and this, fasting ultrasound, I would recommend is the gold standard investigation of choice for this biliary atresia. But again, it's a very, very unfair question to be. Okay, I hope you have understood this particular. Now, finally, about the treatment. So what is the treatment? The treatment is by the name of Kasai procedure. Kasai procedure. Okay, so what on earth is this particular Kasai procedure? What do you understand by this Kasai procedure? What do you understand by this Kasai procedure? What on earth is this particular Kasai procedure? So Kasai procedure basically means that portoenterostomy. Okay, portoenterostomy. Okay, so what you need to understand, what did I tell you? The most common type of a biliary atresia is type 3, where the obliteration is till the porta hepatis. So in the Kasai procedure, what you're doing, you are dissecting till the porta hepatis. You're cutting that and you're anastomosing that to the intestine. This is what is called as a portoenterostomy. You understand my point? So this is what is called as a portoenterostomy, where you're attaching the intestine to the porta hepatis. Please understand this particular point, okay? And what they say is that this Kasai procedure, the ideal time to do it is in less than 2 months, okay? So in less than 8 weeks rather, okay? So 2 months or 8 weeks are the same thing. You have to kind of do it. If at all you do it in less than 8 weeks, then it is going to have a good prognostic. Okay, it is going to have a good prognosis in the patients with biliary atresia. Okay? I hope you are able to understand this particular point. Okay, right. Now, the chance of achieving an effective biliary drainage after the portoenterostomy are maximum when operations are performed before the age of 8 weeks, and approximately 90% of the children whose bilirubin kind of falls to the normal can be expected to survive at 10 years. Early referral for the surgery is critical. So why this is important? Because if you operate within 2 months, what is going to happen? it is going to have a much better outcome. 90% of the patients are going to have they are going to be able to survive with this particular stuff. What about the others? If at all you kind of delay in this particular surgery, okay, or if at all, let's say the biliary atresia progresses, okay, if at all the biliary atresia progresses, then what you need to understand is that ultimate treatment for the biliary atresia is liver transplantation. So what I'll do is I'll just quickly summarize this particular biliary atresia for you guys. What is biliary atresia? Biliary atresia is a condition where there is a atresia of the bile ducts. That's fine, nothing major about this. Because of this, what happens? The patients come to you with a obstructive jaundice. Now, what you need to understand about this particular obstructive jaundice, okay, that's what you need to learn. Patients come to you with an obstructive jaundice. Okay, everybody understood this particular point? Now, what you need to understand is that how do you diagnose it? So for the diagnosis, what do we have? For the diagnosis, we have what you call as ultrasound. On the ultrasound, so this has to be specifically a fasting ultrasound. Okay, so on the fasting ultrasound, you get a triangular cord sign. Okay, on the fasting ultrasound, you get a triangular cord sign. On the biopsy, what you're going to get? On the biopsy, you will be able to get the biliary cirrhosis kind of a picture, and this will also help you rule out the other diagnosis. And HEDA scan, you can do, but it's kind of not that helpful. That's okay. Still okay. Okay, so Levin Bailey says that fasting ultrasound is the gold standard and biopsy helps you in attaining the definitive diagnosis. But if at all they ask you investigation of choice, I would recommend you to go ahead with the ultrasound. Why so? Because of the differential diagnosis. What are the differential diagnosis? So we talked about the alpha-1 antitrypsin deficiency. We talked about the cholestasis because of the TPN. We talked about the choledochal cyst. Then Algeli syndrome is the most common differential diagnosis, and the neonatal hepatitis can also be there, which is difficult to kind of distinguish. So from all these particular things, if you do a liver biopsy, chances of you distinguishing between them is much better. Finally, what you need to understand is that, okay, yeah. So explain the classification ones. I'll do that. Just give me a minute. Okay. Now, I told you about the prolonged, this one. What is the treatment? The treatment is Kasai procedure. What is this particular Kasai procedure? This is what is called as a portoenterostomy. What do you understand by the portoenterostomy? That is, you are connecting the porta hepatis to the intestine. This is what is called as a portoenterostomy. And the earlier you do this particular Kasai procedure, that is better. If at all you do this particular Kasai procedure in less than 2 months, that is what is going to give you the best outcome, which is 90% survival at 10 years. Okay, so within 2 months is something which you have to kind of operate on these particular patients. And what is this Kasai procedure? It is a portoenterostomy. So now somebody is asking me to, okay, Chetan is asking me to kind of explain this classification. So what you need to understand is simple. Okay, so we talk about the biliary atresia classification. Okay, biliary atresia classification. Okay, so what you need to understand is that, let's say this is the liver. I'll just simplify this for you guys. Okay, so what if we have? We have the liver, we have the right and the left hepatic duct, we have this common hepatic duct, we have the cystic duct, we have a bile duct, then we have a common bile duct. That is what we have, right? So if at all there is a atresia which is involving only this part between the cystic duct and like it is involving only the common bile duct. Okay, if at all it is involving only common bile duct, that is like type A, type 1. Okay, if at all it is involving common bile duct and the common hepatic duct, okay, it's involving common bile duct and the common hepatic duct, that is what is type 2. Okay, but if at all it is involving till your porta hepatis, if at all it is involving till your porta hepatis, okay, so I hope you're able to understand entirely till your porta hepatis, if at all the involvement is there, this is what is your type 3. You understand my point? So there is till the, like between the junction of the cystic duct to the common bile duct, then between the like on the common hepatic duct till the bifurcation, till the confluence of the two hepatic ducts, and then what we have, if at all it is involvement till the porta hepatis, if at all it is involving till the porta hepatis, that is type 3. Are you understanding my point? Type 1, type 2 and type 3. Did you understand this? Chaitanya? Yep. I hope you have understood this particular classification of the biliary atresia, type 1, type 2 and type 3. Okay, that's great. Okay, so which is the most common type? Yes, type 3 is the most common. This is the most common type. Okay, this is the most common type. Please do remember. Okay, right. So that's all about your biliary atresia. It's again one of the important topics which you need to understand. Okay, now this is, I hope though, this is obviously going to be a simpler topic. So a 4-week-old baby is kind of developing well, and kind of developed a profuse projectile vomiting after feeds. He has been losing weight and vomits is kind of described as being non-bilious. Okay, so we have a non-bilious vomiting. What is the most likely underlying pathology over here? Okay, so there's a non-bilious vomiting. What is the most likely pathology over here? Okay, it has been 4-week-old baby. What is the answer over here? It is a hypertrophic pyloric stenosis. Okay, what is it? It is a hypertrophic pyloric stenosis. Okay, so Etham, what did we say? It is a biliary atresia. So Etham is asking that are the patient has the obstructive jaundice signs and symptoms. So basically, Ethan is trying to ask that do we have the signs and symptoms of obstructive jaundice in these particular patients? Please try to understand in the biliary atresia that is going to present at birth. The patient is not going to have not be able to say anything. Okay, obviously when you kind of evaluate the bilirubin levels, it is going to be significantly high. We do have a physiological jaundice, but in these particular patients, what is going to be there? There's going to be a pathological jaundice. You understand my point? Increased congenital, like conjugated bilirubin, that is what is going to be in these particular pathological jaundice. So no particular signs and symptoms, but there's going to be obviously like if it is uncontrolled and if you don't manage it timely, then connectors and all those particular things are going to happen. Definitely, no doubt about it. Okay. Yes, ultimately the patients will also land up into biliary cirrhosis. So features of liver failure will also, if at all you don't treat it timely in a proper management, right? Okay, now what is the answer? Yes, everybody have answered it correctly. What is this? It's a congenital hypertrophic pyloric stenosis. So let me just quickly cover with you about the congenital hypertrophic pyloric stenosis. Okay, so what is congenital hypertrophic pyloric stenosis? What you need to understand, we have this particular esophagus, we have this, what you call as the stomach, and we have the pylorus. So if at all this particular pylorus becoming thickened, okay, if at all this particular pylorus is getting thickened, what is going to happen? The food part, like food will not be able to cross beyond this particular pylorus, and the patients are going to come to you with the recurrent episodes of non-bilious vomiting. Non-bilious vomiting. So when we talk about these particular patients, what will be the features? So in the history, they might give you first-born male child. First-born male child. Okay. So the presentation is usually at around 4 weeks. 4 weeks of life, the presentation, and the patients are going to have non-bilious vomiting. Okay, so the parents of this child are going to say that, you know what, as soon as the child basically drinks milk, the child is fine, but after that the child vomits, and after the child vomits, the child again cries because the child is very, very hungry. That is what the characteristic history will be there. When you examine these particular patients, what are you going to find? When you examine these particular patients, you are going to find peristalsis, which are going to be from left to right. Okay, so you are going to find peristalsis, which are basically from the left to the right. That's what you're going to find. And on abdominal palpation, you are going to find a olive shaped lump. You may find, not present in everybody, but if at all you try to palpate, you might find an olive shaped lump over here. Okay, that's all fine. Okay, now how do you manage these particular patients? If I just ask you, what is the surgery which you're going to do in these particular patients? The answer is Ramsted's pyloromyotomy. Okay, what is the surgery which you're going to do? You're going to do a Ramsted's pyloromyotomy. Okay, what are you going to do? You're going to perform a Ramsted's pyloromyotomy, but that's fine. My point is that the patient, okay, let me just give you an example. Okay, so let's say you are a treating doctor and the patient has come to you at, let's say, 9 a.m. in the morning. So in the morning hours, the patient has come to you in the hospital. Will you operate immediately? Okay, will you operate immediately? Okay, will you operate immediately? You understand my point? So if at all there is a patient who has come to the hospital, will you operate on this particular patient immediately? Yes or no? No, right? You're not going to operate patients immediately. Why? Because the patients are dehydrated. And the patients also have a metabolic normality. So which metabolic abnormality is kind of present in these particular patients? Can you please help me with this? The patients are having hypochloremic, hypokalemic, metabolic alkalosis. You understand my point? The patients are going to have a hypochloremic, hypokalemic, metabolic alkalosis with paradoxical acid urea. Okay, so yeah, the patients are going to have a hypokalemic metabolic alkalosis with paradoxical acid urea. Okay, with paradoxical acid urea. You understand my point? So this is what the patients are going to have. So what you're going to do before you operate on these particular patients, you have to correct the electrolyte abnormality. So before you operate, you have to correct the metabolic abnormality. You understand my point? So before you operate on this particular patient, you have to collect the metabolic abnormalities. Okay, so my question is, everybody understands this point? You have to correct the metabolic abnormality. My question is, which fluid will you give? Okay, which fluid you are going to give in these particular patients? Can you please help me with this? Which fluid are you planning to give to these particular patients? So you are going to give these particular patients what? What are you planning to give to these particular patients? You are going to give normal saline plus potassium supplement. Okay, yeah, you would have heard of this. Okay, and you might have even tried to memorize this. Okay, so what you're going to give? You're going to give normal saline along with that potassium supplement. How do you give a potassium supplement? KCl. Okay, KCl, you can kind of give this potassium chloride. That is what you can give to these particular patients. But why? Can't you give Ringer's lactate to this particular patient? Can you give Ringer's lactate? If I ask you, can you give Ringer's lactate? Can you give Ringer's lactate to this particular? Okay, so what you need to understand, the answer is no. It is not preferred. It is not preferred. Why? Why is it not preferred? So please try to understand. If you give Ringer's lactate, inside the Ringer's lactate, what is there? There is a lactate. And what happens to this particular lactate? In the liver. So we have a liver. In the liver, this particular lactate is converted to bicarbonate. Okay, it is converted to bicarbonate. It's converted to bicarbonate. So what you need to understand is this bicarbonate is going to exacerbate. It is going to exacerbate the alkalosis. Alkalosis. You understand my point? So Ringer's lactate is not given. Will you give normal saline alone? No, right? Because normal saline will take care of the chlorine. That's fine. But what about the potassium? Okay, so you also need potassium component. Normal saline also only has sodium and chloride. So it will not take care of the potassium. So you have to kind of give normal saline along with the potassium supplements. Very, 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 very important. Okay, I hope you have understood this particular point. What you give to these particular patients is normal saline along with potassium supplements. So quickly I'll summarize this. It's pretty simple, nothing major about this. Congenital hypertrophic pyloric stenosis, first born male child, 4 weeks of life, non-bilious vomiting. And what happens over here? Patient is vomiting. Yeah, that's fine. Non-bilious vomiting. Peristalsis is happening from the left to the right. Point of shape mass is palpable if you try to palpate. The treatment is Ramstead spileromyotomy. That's what you basically perform. That's okay. Will you operate immediately? No, you will not operate immediately. Why? Because of the metabolic abnormality. Which metabolic abnormality? And the dehydration. These are the three. Which metabolic abnormality? Please understand. Hypokalemic, hypochloremic metabolic alkalosis. It is like, if you don't remember this, that's obviously not at all going to be good, because that's like a, it's like a very, very basic question which can be asked to you in your any exam. Hypokalemic, hypochloremic metabolic alkalosis along with paradoxical aciduria. Okay, now before you operate, correct the metabolic abnormalities. Yes, obviously you have to do that. In order to do that, which fluid are you going to give to these patients? You're going to give normal saline. Along with that, you're going to give potassium supplementation to patients. That's all okay. But can you give Ringer's lactate? No, because in the Ringer's lactate, you have a lactate, and the lactate can convert into bicarbonate, which will going to be exacerbating your alkalosis. Okay, so that's what you need. You're very, 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 very. Okay. Okay, I hope you have understood this. Okay, now finally what you need to understand is that what is this paradoxical aciduria? Okay, what about this paradoxical aciduria? And one first point, let's try to understand why are you getting this hypokalemia in these particular patients. So for this, we will have to revisit our renal physiology. Not much, but a bit. So what we have, let's say if it all this is a discal convoluted tubule which I'm drawing, and I'm just drawing one cell of the distal convoluted tubule in a like an enlarged form. Okay, so this is what we need to understand. Okay, so we have this particular one cell of the distal convoluted tubule in the enlarged form. So inside the distal convoluted tubule, what do you have? Inside the distal convoluted tubule, you have sodium. You want to absorb this particular sodium, yes. So if you're absorbing one potassium, like one positive ion, you'll have to give some positive ion to the distal convoluted tubule as well, right? So what you end up giving? You can either end up giving potassium or you can either end up giving hydrogen. Now, in the patients with a congenital hypertrophic pyloric stenosis, in the patients with congenital hypertrophic pyloric stenosis, what do we have? We have metabolic alkalosis. So hydrogen ions are already low. So will you give hydrogen ions? No, you will not give hydrogen ions. What you're going to give? You're going to give potassium ions. So once you start giving potassium ions, only like, okay, hydrogen ions you preserve, potassium ions you give. Because of this, the patients land up into hypokalemia, right? But there's a point, right? There's a point to which you will be able to give this potassium ion. Beyond that particular point, you will not be able to give these potassium ions, right? So because now the patient is landed into hypokalemia and the body says enough is enough, I cannot give you any more potassium ions. So despite patient is having the alkalosis, despite of that, body now starts giving hydrogen. That is why there is a paradoxical aciduria. Am I making some sense? Idealistically, the body is having alkalosis, right? So why the hell hydrogen ions should come out into the urine? They should not. But because the body is not able to excrete potassium ions anymore, now the body has to excrete the hydrogen. That is what is called as a paradoxical aciduria. Okay, I don't understand it. Okay, I hope you have understood this particular point. Okay, great. Now, okay, great. So Etham is saying, thank you. I did not understand it before. That's great. Thank you. Yep, right. Now, let's talk about this. A 56-year-old man presents with his first attack of diverticulitis. Okay, so there's a man who is coming to you with an attack of a diverticulitis. Which of these complications is least likely to ensue? Okay, so which of these, what in short, okay, so let me just tell you one more thing, guys. Okay, so people keep on really getting obsessed about clinical based scenarios, one-liners, blah, 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 all those things. So in this particular question, they are trying to give you a very, very short kind of a statement and like they are saying which of this is least likely complication. In the one line, they will straight away ask you that, you know what is the least likely complication of diverticulitis? So don't kind of stress about this. Concepts remain the same, whether it is a one-liner, whether it is a clinical based question, or whether it's an INI, whether it's a NEET PG, whether it's any exam in this particular world, the concepts more or less remain the same. Obviously, every exam has its own pattern, so you have to kind of adopt to that particular whole pattern, like that particular different pattern. But if at all your basis of that particular subject is strong, the modification or the adoption will not take much of time. You understand my point? So focus on getting the knowledge of that particular subject irrespective of whatever the exam is there. That is just my 2 cents which I wanted to give you before talking about this particular question. Okay, so what I'm trying to talk to you about over here. Okay, so formation of a colic fistula, like colonic fistula, and malignant transformation. No, fistula will definitely form, right? So it is malignant transformation. B is the answer. Okay, so just Chaitanya, you're right. The answer is B. So let's talk about diverticulosis and the diverticulitis. Okay, so okay, I'm really sorry guys, today actually I'm taking it from some different studio, so the colors kind of combinations are not that great, but it's okay, no issues, it's all okay, it's life, it's not perfect always, I understand that. Okay, so let's talk about diverticulosis. Diverticulosis, what do you understand by diverticulosis? What do you understand by diverticulosis? Diverticulosis means that there's a diverticula which is forming, right? That's fine. That's what is a diverticulosis. A diverticula, what is a diverticula? It is like an outpouching. Okay, so there's an outpouching in the colon. Diverticulosis of colon, obviously. So it is basically in the colon. That's fine. Oh, yes or no, guys. Okay, yeah, obviously, right? So it is in the colon, right? Everybody understood? Now my question is why? Why this particular diverticula are forming in the first place? So what is the reason? Why are they forming? Because of constipation or altered bowel habits. That is what is kind of the things about this. Okay, so constipation or anything which is actually causing your increase in the intraluminal pressure. Okay, anything which is going to increase the intraluminal pressure is the cause of your diverticulosis, right? So what happens? There's an increase in the intraluminal pressure, which causes the outpouching of, and in order to decompress this particular pressure, what happens? The outpouching of the mucosa takes place. Now my question is, from where? From where is this particular okay, so let me just write it. Because of the increase in the intraluminal pressure, what is happening? The mucosa gets out pouch. You understand my point? So because of the increase in the internal pressure, the mucosa gets out pouching. My question is, from where? Like we have this particular whole intestine, right? So from where is this particular out pouching taking? So let me just explain you. Okay, so let's say this is the intestine, right? Let's say this is the intestine, and let's say this is my hand is a mesentery and this is an intestine. So what is going to happen? The blood vessels are going to come from here, and they are going to kind of go on the wall of this particular wall, bowel wall, and at one point or the other, these blood vessels are going to enter into this particular wall. Okay, they are going to enter into this particular wall. Yes or no? They're going to enter into this particular wall. So the points where the blood vessels are entering into these particular walls, they are the points of a potential weakness. Okay, so if at all there is an increase in the intraluminal pressure, the mucosa can pop out from these particular points. So this is what is called as a pulsion diverticulum. Okay, pulsion diverticulum or the false diverticulum. So this is a pulsion diverticulum, called as a pulsion diverticulum, and as all the layers of the intestine are not present over here, this is what is called as a false diverticulum. You understand my point? So this is what is a pulsion diverticulum or a false diverticulum. Why this is happening? I hope you have understood this point, and from where it is happening, from the points of these potential weaknesses. So I'll just explain you in this particular diagram as well. So as you can see, the blood vessels have come and they are basically supplying the blood vessel to the inner wall, right? Now, this is the point of an, what you call as a potential weakness. So when there was an increase in the intraluminal pressure, what happened? The mucosa got outpouched from this particular part. This is what is referred to as a diverticulosis. Okay, everybody have understood this particular point? That is what is called as a diverticulosis. Okay, so going further, what you need to understand, the diverticulosis is presence of diverticulum. Okay, it is called as the presence of the diverticulum. Now there can be complications of this particular diverticulum. So if I ask you, what are the complications which can happen in this particular diverticulosis? There can be either bleeding, obviously, right? So the diverticula are basically going just around these particular blood vessels. So bleeding can start from that particular blood vessels, yes. So bleeding can happen. That is one of the complications. What else? This other complication is diverticulitis. Okay, diverticulitis. Okay, diverticulitis is another complication which you get in the patients with diverticulitis. So there's bleeding, there's diverticulitis. These are the two important complications which you get in these particular patients. Right. Now let's talk about the diverticulitis. Okay. So what do you understand by the diverticulitis? Diverticulitis basically means that there is, okay, so let's say this is a diverticulum. Okay, so let's say this is a diverticulosis, diverticula is there. Now if at all the some rupture over here happens or something, in the peridiverticular space there can be infection or an inflammation. So there can be localized pus collection in this particular diverticula. Are you understanding my point? This is what is called as the diverticulitis, because what is present inside the intestine is fecal matter. So the fecal matter is kind of going there and it can kind of get ruptured and there can be infection, inflammation over there. That is what is called as a diverticulitis. Okay, that is what is called as a diverticulitis. Okay, now if I ask you, what is an investigation of choice? Okay, what is an investigation of choice for the diverticulosis? Can you help me with this? What is an investigation of choice for diverticulosis? And what is an investigation of choice for diverticulitis? Okay, what is the investigation of choice for the diverticulosis and diverticulitis? Okay, what is the investigation? Please tell me. Okay, so CET is for what? CET for both? Okay, so please try to understand. For the diverticulosis, the investigation of choice is barium enema. That is good enough. Okay, that is good enough to diagnose the patients of a whatever diverticulosis. What do you get over here? You get a sawtooth appearance. Okay, what do you get? You get a sawtooth appearance in these particular patients. Sawtooth appearance, this is what you basically get in the diverticulosis. What about in the diverticulitis? It is CEC, contrast enhanced CT. That is what is a investigation of choice for diverticulitis. Please understand, for the diverticulosis, barium enema, sawtooth appearance, and this image is again very, very important. Okay, I hope you're able to appreciate it. This is what is the diverticulars which are basically coming out. Okay, so please try to understand. This is a barium enema which is showing diverticulosis. For the if you perform barium enema in the diverticulitis, that is not going to be good, because already the peridiverticular infection, inflammation is kind of there, and that is going to get deteriorated even further, which you don't want, right? So what you need to understand is this okay, so what you need to understand is that you do not perform barium enema in the diverticulitis. For the diverticulitis, what we have is a contrast enhanced CT. I hope you have understood this particular point, right? Okay, now before we talk about the classification of the diverticulitis, what I would like to cover is the complications of a diverticulitis. Okay, so please understand one thing. Patient was normal. Patient developed diverticulosis, and this diverticulosis get converted into diverticulitis. What is the difference? There is an inflammation around this diverticulum. Now just imagine we have, okay, what is the most common site of this? What is the most common site of all these particular things which is happening? The most common site is sigmoid colon. Sigmoid colon. Okay, so let's say if there is a lot of inflammation in this particular sigmoid colon, can't it get adhered to the other structures? For example, let's say bladder, urinary bladder. Yes, it can get, right? So if at all it gets adhered to the urinary bladder, and after that you came in, you kind of gave the antibiotics and everything, and this diverticulitis got better. Okay, so this is going to happen only with the diverticulitis, because diverticulitis has an inflammation around it, right? So that particular inflamed diverticula got adhered to the surrounding structure. You gave the antibiotics and everything, and after that what happened? That the space between the diverticulitis and that particular organ, it got canalized. So this is how the patients can develop what you call as a fistula. Fistula. Okay, I understand my point. So what is a fistula? Fistula is basically an opening, like it is a, what do you call it? Fistula is basically a like a thing which has two openings. Okay, one to other. Okay, so if I ask you, what is the most common fistula which is happening over here? It is a colovesical fistula. It means that from the sigmoid colon, what you need to understand is that it is connecting the urinary bladder. Okay, so okay, now Sahana is saying that connecting two organs. Okay, no, not really. Okay, what you need to understand, the fistula can be, most probably the fistula is connecting the internal part of the body to the external atmosphere. So there are two openings to any particular tract. That is what is a fistula. So fistula can be an external fistula or it can be an internal fistula. For example, enterocutaneous fistula. It is connecting the intestine to the outside air. You understand my point? So this is what is a like an external fistula. For example, colovesical fistula. That is an internal fistula, which is basically connecting the colon to the urinary bladder. Fistula, if somebody asks you what is a fistula, fistula is a tract which has two openings, which is connecting two different kind of surfaces, okay, to two different kind of spaces. So either it can connect two internal organs, or it can connect an internal organ to the external atmosphere. Am I making some sense to you guys here? Yes. Then what's the sinus? What is the sinus? You tell me what is the sinus. Sinus is basically that if at all there is a blind end. Okay, for example, let's say a sinus has only one opening. Okay, sinus has only one opening and fistula has two openings. For example, let's say if at all there is an external opening and that particular tract is basically blind and it is not opening into some other organ. You understand? That is what is a sinus. Yes, fistula is basically it has two openings. If at all there is an opening outside and there is an opening inside, it is also what we call as a fistula, right? Enterocutaneous fistula. Have you ever heard of this, right? Got it? Yeah, right. So now let's talk about, yeah, so what were we talking about? The most common is a colovesical fistula, that's fine. Okay, now let me come back to the question. Which of the following is the least? Formation of a colonic fistula, it can happen, it can attach to the intestine as well. Development of a colovesical fistula, yes, definitely this is the most common formation of a pericolic abscess. Now let's talk about this pericolic abscess. Okay, now what you need to understand over here is that let's talk about the, what is this classification known as? What is the classification of a like this is known as, okay, this is called the Hinchey's classification. What is this Hinchey's classification? Let me just walk you through it. There's something which is called the Hinchey's classification. Hinchey's classification is a classification of the complications of a diverticulitis. Okay, so what can happen is pretty simple, nothing major about this. So let's say if at all you have a diverticulum, there can be inflammation which is just surrounding this particular diverticulum, localized kind of inflammation. That is what is type 1 Hinchey's classification. Okay, the pus is basically accumulating just around the diverticula. Localized collection, that is what is called as a pericolic or a mesenteric abscess. That is what is type 1. What about type 2? This can go into the pelvic cavity. Inside the pelvic cavity, it can go. This is what is called as a type 2. If at all there is a pelvic abscess, okay, if at all there is a well-defined walled off pelvic abscess, that is basically type 2. What about type 3? Type 3 is basically generalized purulent peritonitis. Okay, it is a purulent peritonitis, and you have a feculent peritonitis. And finally, what we have is a feculent peritonitis. Feculent peri. Okay, so feculent peritonitis is 4 and purulent peritonitis is 3. Making some sense? So this is very, very important. This is what is called as the Hinchey's classification for diverticulitis. Okay, so I hope you have understood this particular point, guys. Okay, right? Now, before we move on to the next kind of a topic, what we'll do is we'll just take a small break. We will come back at around 6:40. 6:40 we'll start again. 6:40, 6:42 we'll start again. So please come back. You also have, let's say, tea or something, and then we'll come. Okay, just speed So, hi guys, welcome back. Okay. Uh, let's start. Let's start by talking about the next question. Shall we start by talking about the next question? Okay. Okay. So, right now, what you're seeing in front of you is a 55-year-old male who develops an acute colonic pseudo-obstruction following a laminectomy. Okay. So the question is trying to tell you that the patient is suffering from an acute colonic pseudo-obstruction. Despite correction of his electrolytes and ongoing supportive care, he fails to settle. So they're saying that we tried the conservative management, but the patient has kind of failed to settle down. Which of the drugs listed below may improve this situation? So what can help in this particular patient? Can you please help me with this? Anybody, guys? What do you think? What is the answer? Okay. So yeah, what do you think? What is now going to be the answers over here? Okay. Okay. So the answer over here is what we call as neostigmine. Okay. What is the answer over here? It is neostigmine. Okay. Let's try to talk about the colonic pseudo-obstruction. Yep. I hope you have joined, guys. Yeah. So what is the okay? So colonic pseudo-obstruction is called as an Ogilvie's kind of syndrome. So what you need to understand, the colonic pseudo-obstruction can be the primary or it can be secondary. So this Ogilvie syndrome is what? This is basically your primary colonic pseudo-obstruction. Okay, so this is primary colonic pseudo-obstruction. Then what do we have? We have the secondary colonic pseudo-obstruction. What do you understand by the secondary colonic pseudo-obstruction? Secondary colonic pseudo-obstruction basically includes those patients who have some underlying cause. Okay, patients who are having some underlying cause. Like, what is the underlying cause? Like diabetes, or they are on some, let's say, psychiatric medications, or they're like, I understand my point. So patients are having chronic constipation. All these are basically included in your secondary colonic pseudo-obstruction. Okay, so primary colonic pseudo-obstruction is basically Ogilvie syndrome, and the secondary colonic pseudo-obstruction is something which is like they have underlying cause like diabetes, psychiatric medication. They are on the psychiatric medication, antipsychotics they're taking, or some kind of chronic constipation and all those. Okay, I hope you have understood. Okay, now what you need to understand is what is colonic pseudo-obstruction. What do you understand by pseudo-obstruction? It means that there is no physical obstruction. Why this is happening? Because of the peristalsis have become problematic. Okay, now before we talk about this, we need to understand. Okay, first let's try to appreciate the X-ray. Okay, so I hope you're able to appreciate that over here, what is there? That the colon and everything is kind of dilated over here, and that is what is going to give you a diagnosis of a colonic pseudo-obstruction. Okay, so this is what is an X-ray of a colonic pseudo-obstruction, right? Now, the whole point is why these particular things are happening. So what you need to understand is we need to what you call as an appreciate, and what we need to understand and what we need to appreciate is that we have a sympathetic and the parasympathetic supply in our gut, right? So we have a sympathetic and a parasympathetic supply in our gut. Now, normally what happens that there is a constant balance. Okay, there is a constant balance between the sympathetic and the parasympathetic supply. Okay, but if at all one particular supply basically over exceeds the other one, that will become predominant. So what is the function of your parasympathetic supply? Parasympathetic increases the peristalsis. What about the sympathetic tone? Sympathetic is actually reducing the peristalsis. So in the patients with colonic pseudo-obstruction, what do you think what is going to happen? In the patients with colonic pseudo-obstruction, what do you think? What is going to happen? In the patients with the colonic pseudo-obstruction, there is going to be a increase in the sympathetic activity or increase in the sympathetic tone. Are you understanding my point? So there's going to be an increase in the sympathetic activity and increase in the sympathetic tone. So like it's going to increase drastically as compared to that of a parasympathetic. That is what is the basic problem in these particular patients. Okay, so let's kind of go through this particular table. What are the risk factors? Frailty and kind of senility. For example, neurological, neurodegenerative disorders like Alzheimer's, the Parkinson's. We just talked about that. Stroke, spinal cord injury, retroperitoneal tumors or infiltration. Then it can be trauma or surgical, as in this particular question, this developed after the laminectomy. Okay, so some major orthopedic injuries such as the vertebral, pelvic, femoral, major gynecological surgeries, obstetric, including others. Then systemic inflammation. Systemic inflammation may be any cause, like the sepsis, trauma, especially multi-organ failure, localized infective conditions like respiratory urinary tract, myocardial infarction, metabolic and electrolyte abnormalities, and medication. Okay, so please try to understand, this is important. Opioid, anticholinergics, and calcium channel antibiotics. Okay, so what you need to understand is these are the various causes, but predominantly, if at all they give you a question, either they're going to give you the patients who are, let's say, having diabetes and like who are chronic in the age-old homes, who are having Parkinson's, Alzheimer's, all those particular things, having neuroleptic kind of on antipsychotic medications, all these particular things, or they will give you the trauma or some surgery like laminectomy. Okay, that is one thing. Then management. This is something which we want to focus on, right? So management, what you need to understand is if at all there is some underlying risk, you kind of reverse it. So for example, if at all there is a fluid and electrolyte abnormality, obviously you have to correct it. You stop or reduce the offending drug. For example, we do know that the opioids and anticholinergics and the calcium channel blockers, they can actually lead to the increase in this colonic fluid obstruction. So we can actually try to reduce their dose or maybe stop transiently or something like that. That is what we can do. Then empty the rectum by the enema or the flatus tube. So this is important. If at all there is a patient who is coming to with a kind of colonic fluid obstruction, we can pass a flatus tube. What do you understand by flatus tube? You can pass in a tube so that the flatus is basically let down. And if at all the flatus is let down, what you need to understand, maybe the peristalsis will start to increase. You understand my point? You can pass in a flatus. Then endoscopic decompression. What do you understand by endoscopic decompression? You can do a colonoscopy, and along with the colonoscopy also you can place a flatus tube. Then pharmacological decomposition. This is important. This is what the question is all about. Intravenous neostigmine unless contraindicated. Risk of arrhythmia and bronchospasm. So what do you understand by unless contraindicated? So before you kind of give this neostigmine, you should know that the patient is not having any kind of a physical obstruction. Please understand this pretty okay. So, but if at all there is a physical obstruction present, and if you give a neostigmine, there is a chance of rupture. So you have to kind of rule out any kind of a physical obstruction before you give this particular neostigmine. And as you can see over here, if you give a neostigmine, there is a risk of arrhythmia and the bronchospasm. So this is what you need to understand regarding the pharmacological management of acute kind of colonic pseudo obstruction. Then surgery, septal colectomy, and venting stoma. So all these particular things can be done. Okay. Now what about the cecostomy? Why they have specifically said as cecostomy? After all, there is a patient is unfit. Rather than colostomy, you can bring out the cecum. That's fine. Okay. So I'll talk to you about the cecum again in a couple of minutes. Okay. Now the decision whether to use the intravenous neostigmine is difficult and is usually reserved for the patients in whom supportive measures and the colonic decompression have failed. So that's not the primary treatment. Primary treatment is you give the fluids, you correct the electrolytes, you stop the medications which are actually causing this particular problem, you try your flatus tube, you try your sigmoidoscopy, and after all these things have kind of failed, now you can try this neostigmine. The treatment is associated with the profound autonomic effects, salivation, bradycardia, bronchospasm, and hypotension, as well as abdominal cramps, followed by often massive evacuation of the flatus and the feces. So it is not a very, very simple medication to be used. It is associated with a lot of autonomic effects, as I just told you, right? So all the secretions are going to increase in our body. Now, cardiac monitoring and a health professional competent, so basically you have to kind of undergo cardiac monitoring. Why? As I told you that there is a risk of arrhythmia formation. Because there's a risk of arrhythmia formation, so you have to kind of do the cardiac monitoring. Contraindications to use for the neostigmine include renal insufficiency, recent myocardial infarction, arrhythmia, and the asthma. So I told you that you have to rule out any kind of a physical obstruction, that's fine. And at the same time, what are the other contraindications to use the neostigmine? Renal insufficiency, recent myocardial infarct, arrhythmias, and the asthma. So they might give you a question where they might give you that, the patient is having renal insufficiency. Will you use a neostigmine? The answer is no. Okay. So what are the contraindications? Okay. Okay. How is renal insufficiency, recent myocardial infarction, arrhythmia, and the asthma? Okay, I hope you have understood this particular point. Okay, so let me just address this particular stuff. Chaitanya is asking how is it different from paralytic ALS? So, I mean, the problem is that again, both are adynamic obstruction. Okay, so paralytic ileus is also an adynamic obstruction. This is also an adynamic obstruction. The cause is different. Paralytic ileus is predominantly caused because of electrolyte abnormalities. This is predominantly caused because of a autonomic kind of abnormalities. Okay, you understand my point here? The predominant thing is that the sympathetic overactivity has taken place. How? For example, let's say the patient is having some kind of a neurological disorder, that is one way, or let's say some trauma, or let's say some severe surgery. All these things lead to the increased sympathetic activity. So that is what you need to understand. Here, the predominant kind of thing will be sympathetic overactivity and some drugs or some diseases which are basically manipulating with the sympathetic outflow. You understand my point? In the paralytic ileus, predominantly what you're going to find is that there is electrolyte abnormality, potassium deficiency. That is what is going to be predominantly present in the patient with paralytic ileus. Okay, I hope you have understood this particular point. Okay, right. Now moving on to the next question. Yeah, you are seeing one particular image on your screen. What do you think, guys? What is this? What is this particular sign, and what is the diagnosis? Okay, so tell me the sign and tell me the diagnosis. Can you please help me with this? Okay, what is the sign and what is the diagnosis? So what is the sign as? This is called as the Pemberton sign. Okay, what is this called? This is called as the Pemberton sign. And what is the diagnosis? It is a retrosternal goiter. Okay, so the sign over here is, okay, yeah, mediastinal or the retrosternal goiter, and this is what is called as a Pemberton sign. Pemberton's sign, and the diagnosis is retrosternal goiter. Okay, so now let's talk about this retrosternal goiter. When do you say that the patient is suffering from retrosternal goiter? How much amount of the goiter should be present in the retrosternum or in the like in the mediastinum? So retrosternal goiter. Okay, so retrosternal goiter basically means that more than 50%. Here, what is happening? More than 50% of the thyroid tissue is present in mediastinum. Okay, so more than 50% of the thyroid tissue is basically present in the mediastinum if we want to call it as a retrosternal goiter. Okay, now what you need to understand, the retrosternal goiter either can be what you call as a primary or it can be secondary. So let's talk about this. Either there can be primary retrosternal goiter or it can be a secondary retrosternal. What do you understand by primary and what do you understand by secondary? Primary retrosternal goiter is a condition where the growth of the goiter or whatever the thyroid tissue, it started in the mediastinum itself. So over here, primary basically means that the development started in mediastinum. What about the secondary retrosternal goiter? The development started in the neck, then it came to lie in the mediastinum. You understand my point? So primary means it started development in the mediastinum itself. Secondary means started development in the neck and then it came to lie in the mediastinum. You understand my point? Primary and the secondary retrosternal. Now, if I ask you about the blood supply, okay, in the primary retrosternal goiter, what do you think? What is going to be the blood supply? In the primary retrosternal goiter, the blood supply is predominantly from the mediastinal vessel. Mediastinal vessel. What about the secondary retrosternal goiter? Because it has started its development in the neck and then it's coming to lie in the mediastinum, it is basically getting the blood supply from the cervical vessel. So here it is getting the blood supply from predominantly from the cervical vessels. Predominantly from cervical Here, predominantly the blood supplies from the cervical vessel. Now you understand my point? It's very, very logical, right? Second, primary, what happens? Primary started its development in the thoracic cavity only. So if it is starting its development in the thoracic cavity, what do you think? Going to get the blood supply from the local mediastinal vessels only, right? But the secondary, it started its development in the neck and then it came to the mediastinum. Secondary retrosternal goiter, what we have is, we primarily have a cervical, like blood vessels from the cervical origin. But what do you think? What do you think? Like, can it receive the blood supply from the mediastinal vessels? Yes or no? Can it receive the blood supply from the mediastinal vessels? Answer is yes. These patients may have parasitic vessels from mediastinum. Listen my point. So these particular patients may have a parasitic vessels which arise from the mediastinum and they are now supplying this particular retrosternal goiter, but primarily majority blood supply of the secondary retrosternal goiter is basically from the cervix. Making some sense to you guys? I hope you have done that. Okay, now you've done this. Now if I talk about the management, if I talk about the management, obviously you want to okay, you will try to remove it, that's fine. But for the management, what you need to understand is that in the primary retrosternal goiter, what are you going to do? The primary retrosternal goiter, you have to give a thoracotomy. Thoracotomy is needed. Why? Because the blood vessels are from the mediastinum itself, right? Over here, what you need to understand, cervical neck and like incision is preferred. Okay, it is preferred to give a cervical incision because the blood supply primarily is from the cervical vessels. So if you give a cervical incision, if you control the blood vessels over here, that is what is going to help you. You understand my point? If at all the parasitic vessels are there, thoracotomy may be needed to tackle mediastinal vessels. Okay, so if they ask you what is the preferred approach, they ideally should specify that are you dealing with the primary retrosternal goiter or are you dealing with the secondary retrosternal? Okay, yeah, they should ideally specify, right? But if they don't specify, then what are you going to mark? Are you going to mark it as a cervical incision or are you going to mark it as a thoracotomy? What do you think? What are you going to mark? If at all they don't specify, if they just ask you what is the preferred approach, is it like the cervical approach or a thoracotomy? What are you going to say? Anybody guys? What are you going to say? Preferred approach. If they simply ask you this, if they simply ask you what is the preferred approach, please try to understand it is going to be your cervical approach. Why? Because the secondary retrosternal goiter is much more common than the primary retrosternal. Secondary retrosternal goiter, it is how much? Around 95%. About 95% of all the retrosternal goiters are the secondary retrosternal goiter. Okay, so that is what you need to understand over here. In the secondary retrosternal goiter, what is preferred is a cervical kind of approach. That is what is preferred. Now, is there any role of a pre-operative CT scan? Okay, is there any role of pre-operative CT scan in these particular patients? Yes. What is the role of a pre-operative CT scan in this particular patients? The role is to evaluate the vascular anatomy. Okay, anatomy. Okay, so what is the role? To evaluate the vascular anatomy. Okay, to evaluate the vascular anatomy, you have to kind of do a pre-operative CT scan. Why? Because if at all you want to do a thoracotomy in the secondary retrosternal goiter, thoracotomy may be needed. I told you, right? So it is not like a blink of a decision. Like intraoperatively, you will not decide, okay, let's kind of do a thoracotomy. No, right? You have to plan it. Anesthetists have to kind of know that beforehand. So if at all you do a pre-operative CT scan, that is going to give you a fair idea whether all the vessels are from the cervical region only or thoracotomy will be needed or not. I hope you have understood this particular point. Right. Now lastly, if at all there is a patient who is having a retrosternal goiter, it doesn't matter whether it's a primary or a secondary or something like that, what will be the clinical features of this particular patient? I'm pretty sure that you know it is going to be compressive symptoms. What do you understand by the compressive symptoms? Compressive symptoms. So whatever this retrosternal goiter is, that is basically compressing your trachea and the esophagus and everything. So patients are going to have dysphagia, patients are going to have respiratory distress. Okay, so all these particular things are going to be, okay. So yeah, that is what you need to understand over here. Okay, right. So the class is till what time? So class will be till around 9:30. Okay, around 9:15, 9:30, at the max 9:45. So yeah, we will end by 9:15, 9:30, 9:45. Have to kind of go. So yeah, around 9:15 or 9:30, probably the class will end. Right. So okay, got it. Right. Now that's all about the retrosternal goiter. So what is this? This is what is this Pemberton sign? Pemberton sign is one of the tests which you basically perform in order to diagnose the patients with the retrosternal goiter. This particular guy who had come to your clinic, he was absolutely fine, but he have had this particular thyroid, right? He had this particular thyroid swelling. Now you wanted to evaluate whether there is an intrathoracic extension of this particular thyroid swelling or not. What we did, now at this point of time, the patient was not having any respiratory distress. The face and everything was absolutely fine. Ask the patients to raise both the hands above this particular region. So what is happening? The space becomes narrower, and if at all there is a retrosternal goiter present, it will press on these blood vessels which are draining the upper face. Because of this, what happened? The patients developed facial plethora. Okay, the patients developed facial plethora. Okay, why so? Because there was a venous, because of the venous congestion, the patient basically developed a facial plethora. Am I making some sense to you guys? So this is what is your Pemberton sign. That's it. Okay. Right. Okay. Right. Now let's move on to the next question, guys. Next question. A 65-year-old man who is a banker came with an ultrasound review. That's fine for the medical insurance. In the right kidney, the cyst was found. And the picture of the CT scan has been shown to you. What is the most likely diagnosis? So what you need to understand, you're not able to see the pathology. I'll just zoom in a minute. So yeah, this is what is the pathology, what you need to understand over here. This is the cyst, okay? I'm really sorry for this because of the image. So what you need to understand, this is the cyst. If at all you're able to appreciate, this is a cyst, this is a cyst, and this is a kidney, obviously. I'll first draw the kidney. So this is the outline of the kidney, okay? And obviously, the cyst is also on the kidney only. So this is a cyst, which are you able to appreciate it? So this is what is a cyst. And please tell me what Bosniak stage is it? Is it like the Bosniak 1, Bosniak 2, Bosniak 3, or the Bosniak 4? What is the answer for you? Okay, I'm waiting for your answers, guys. Now the Bosnian classification is important. They had asked you once. Okay, so can you please tell me what is this particular Bosniak staging? Just zoom in on the image. What is the Bosniak staging? 1, 2, 3, or 4? So guys, this is Bosniak class 4. Okay, this is Bosniak class 4. Why this is a Bosniak class 4? Just understand, here is a nodule. There's a nodule inside, which nodule is also enhancing. Okay, so that is what is a Bosniak type 4. Okay, so more importantly, what you need to understand about the Bosniak staging. Okay, but before we talk about the Bosniak staging, let's talk about the renal cell cancers. Okay, so renal cell cancers. If at all, let's say there's a patient who is having a renal mass. Okay, so let's say there is any patient who is having a renal mass, right? Now this particular renal mass has two possibilities. Either it can be benign or can be malignant. Okay, so how do you say that, you know what, this particular renal mass is benign and this particular renal mass is malignant? How do you say that? Okay, so what you need to appreciate, what you need to say is, you have to know a contrast enhanced CT scan. Do you do a biopsy in these particular patients? You can do a biopsy, but biopsy is not usually done. Okay, so the diagnosis or distinguishing whether you are dealing with a benign renal condition or a malignant renal condition, it depends on the contrast enhanced CT scan. You do a contrast enhanced CT scan, and on contrast enhanced CT scan, if at all there is an increase in the enhancement by 15 Hounsfield unit. Okay, if at all there is an increase in the enhancement by 15 Hounsfield unit, this is what gives you the diagnosis of your what you call as a renal cell carcinoma. Okay, so when do you say that the patient is having a renal cell carcinoma? If at all there is an increase in the enhancement by 15 Hounsfield unit as compared to the non-contrast. I'll repeat it. I'll just explain it to you again. So let's say if at all this is a patient who is having a kidney, and inside this particular kidney, obviously everybody has a kidney. Inside the kidney there is this particular lesion, right? So what you do, you take a non-contrast. You take a non-contrast image. Okay, then you give the contrast to this particular patient. You're giving the contrast, and after that you are taking a post contrast. So as compared to the non-contrast image silica, if you compare this to your post-contrast image, this particular mask may enhance. Okay, so if at all the enhancement, okay, if at all this particular enhancement is more than 15 Hounsfield unit, then what you're dealing with the renal cell carcinoma. Making some sense to you? This is how you diagnose the patients with the renal cell carcinoma. You do not end up go and perform a biopsy of every renal mass. Have you seen that? No, you don't. Okay, so contrast enhanced CT scan is used. Okay, now there is a chance that there are other lesions in the kidney. Okay, so what about this benign lesions of the kidney? Okay, so what is this? What is this? What you call as a Bosniak staging? Bosniak staging is basically a staging which is done on the contrast enhanced CT. Okay, so let's say if at all there is, okay, what is Bosniak? Bosniak staging. So first of all, this is a staging which you basically perform on a contrast enhanced CT scan. On CCT, you basically perform this particular staging. What is in this particular staging? After you perform this particular staging, you can see whether you basically evaluate the renal cysts. Okay, you evaluate the renal cysts. Okay, what do? You evaluate the renal cysts. Now, these particular renal cysts, they can be the benign or they can be kind of suspicious or they can be malignant. Okay, so what you need to understand, with the help of the Bosniak staging, we can roughly tell, you know what, that this particular cyst is not having a mature problem. We can just kind of leave it like that, or you suspect something, right? So let's kind of put this particular patient on follow-up, or there's a very high risk of malignancy. Let's kind of get rid of this particular cyst or something like that. I understand my point. Bosniak staging is this. First point, where is this particular Bosniak staging then? Ultrasound, CT scan, contrast enhanced CT scan. There is this particular Bosniak staging. Now, second question is, what is this Bosniak staging? Okay. Now, if at all I tell you that you did an ultrasound and you had a, like you at this point of time, you who are listening to me, if at all you have a simple renal cyst, will you get panicked? No, not really, right? The simple renal cyst is absolutely normal. More or less everybody is going to get few of them, maybe some early, maybe later, but we might get this. Sorry, we might get this simple renal cyst. Okay, breathe out. For this, we might get a simple renal cyst. Okay, if at all you get this particular simple renal cyst, nothing has to be done. Okay, so what are the characteristics of this particular simple renal cyst? It is thin wall without septa or solid component. So it is a thin walled cyst which is not having any septa, it is not having any particular solid component, and no internal enhancement. Okay, so it is kind of a thin walled without septa, without any solid component, no enhancement. That's absolutely fine. That is what is a type 1 Bosniak cyst. Then we have a type 2 and type 2F. So there's a slight difference between. What is this? Let's try to see. In the type 2, it is kind of less than 3 cysts. It may show minimal enhancement. But what you need to understand, this is a perceived enhancement. In a type 2, what you're going to see is a perceived enhancement. If at all, they use the word as perceived enhancement. What they are talking to you about is a type 2 or type 2F. You understand my point? Please understand this. Okay, so what is the perceived enhancement? What is measurable enhancement? So what did I tell you in the diagnosis? That as compared to the non-contrast, when you compare it to a contrast film, there is an increase in the contrast enhancement by 15 Hounsfield unit, right? Increase in the contrast enhancement. This 15 Hounsfield units is an increase. We are able to measure it, right? So this is what is a measurable enhancement. But if I after looking at this kind of films, I say that, you know, it slightly looks hyper, but I don't know. Let's try to look at it in the software. And when you put it in the software, you're not able to find any significant difference in the Hounsfield unit between the two things. You understand my point? This is what is called as a perceived enhancement. But here, if you're clear-cut able to say that, you know what, more than 15 Hounsfield units is enhancement, this is what is called as a measurable enhancement. So we'll talk about that as well. But in the Bosniak type 2, what do you get? You get a perceived enhancement. You perceive that, you know what, maybe the enhancement is happening in this particular kind of septum, right? Now 2F may, the only difference is that the size has to be more than 3 cm. If at all the size is more than 3 centimeters, or we have more than 3 cysts. Okay, so exactly the same. Some few minute septas can be present, some flimsy septas can be present, but broadly what you need to understand is that there is a perceived enhancement, no measurable enhancement. If it is more than 3 centimeters, then it becomes 2F. And if at all there is a 2F, what you ask the patients to stay in the follow up, or let's say to perform the surveillance. So you ask these particular patients to stay in the follow up or to perform the surveillance. That is what you need to understand over here. Okay, then we have a type 3. What about the type 3 Bosniak cyst? In the type 3 Bosniak cyst, what you basically get is you get thick septas. Okay, thick walled septas with enhancement. Okay, so thick walled septas with enhancement, that is what you basically get in the type 3. And over the type 4, there is a like a nodule. Okay, so in the type 4, what is there? There is a nodule, and this nodule is enhancing. Okay, so in the type 3, the septal enhancement is there, and the type 4 nodular enhancement is there. So if at all there is a type 3 or the type 4 Bosniak staging, the risk of malignancy is 50% and 90%. So here definitively what we are going to do is a surgery. So here what we perform is a surgery. Okay, in the 2F, what we do? Sorry. Okay, in the 2F, what we do? Put the patients on follow up, and in the type 1 and 2, just nothing, like it's just observation. Okay, so it's just observation. Over here, it is follow up. Like you ask the patients to come back again after 6 months and get repeated the C. Hope you're able to understand. This is all about the Bosniak staging, which you need to understand. Very, very important, guys. Has been asked to you, already has asked to you. Please try to remember this particular stuff. Okay. Now, let us discuss about the renal cell cancer, because this is one of the very, very important topics. So I decided to kind of cover this particular stuff in detail. Now, before I move on to this particular slide, why I'm saying that this is very, very important. So now what I'm going to do, I'm going to tell you all the important questions, many of the important questions which have been asked to you. So simply putting, I'll just keep on kind of firing the questions. You can just put your answers in the comment box. So if I ask you what is the most common renal cell carcinoma, what is the answer? What is the most common renal cell carcinoma? Give the answer. If I ask you what is the most common gene which is associated with the clear cell RC? Okay, what is the most common genetic mutation which is associated with the clear cell carcinoma? If I say what is the most common renal cell carcinoma which is occurring in the patients who have suffered from, who have developed an acquired renal cyst in long-term dialysis. Okay, the patient was on the long-term dialysis, and now the patients have developed acquired cystic degeneration of kidney. So what is the most common kind of RCC over there? Okay, so if I ask you that what is the most common renal cell carcinoma which is associated with the sickle cell trait? Okay, sickle cell trait. What is the most common renal cell carcinoma? Okay, what is the most common RCC which is associated with sickle cell trait, not the that particular disease. Sickle cell trait. The answer is write it down. Okay, so these 4 questions I've asked you, many of you have answered it correctly. So KK is saying clear cell, and then they're saying VHL syndrome. That's great. And papillary. Very good, guys. Very good. Okay, so let's talk about these particular different histological subtypes. Okay, so what you need to understand over here, what are the 5 histological subtypes? We have the clear cell carcinoma, we have a papillary cell carcinoma, then we have a chromophobe cell carcinoma, we have a Bellini duct carcinoma, we have a medullary cell carcinoma. Okay, so please try to understand this particular point. This clear cell carcinoma is the one which is the most common type, which is associated with the VHL gene mutation, which is present on chromosome 3p. Okay, so the VHL gene mutation is something which is present on chromosome 3p. What about the papillary cell carcinoma? This is associated with the MET gene mutation, which is trisomy 7, which is familial. Okay, what is familial? If at all, this is again an MCQ. Familial papillary cell carcinoma of the kidney. That is what? Trisomy 7. Okay, what is the genetic mutation in the familial papillary cell carcinoma of the kidney? It is this trisomy 7. Then acquired renal cystic disease in the patients with dialysis. Very, very important. Has been asked to you. So what is an renal cell carcinoma which is common in the patients with acquired renal cystic disease in the patients on dialysis? The answer over here is papillary cell carcinoma. Okay, then Somoma bodies and all, that's fine. So here what you basically find is a Somoma bodies. Somoma bodies are basically features of your renal cell carcinoma. Okay, a papillary type of renal cell carcinoma. Chromophobe type is like plant-like appearance. That's all fine, not important. Medullary cell carcinoma is important. sickle cell trait. Okay, so sickle cell trait is associated with the middle age cell carcinoma. This has a poor prognosis. Okay, sickle cell trait, middle age cell carcinoma, poor prognosis. Okay, I hope you are able to understand and appreciate this. These are the different subtypes of the RCC, which are very, 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 very. Hope you understand this point. Now, this is a clinical scenario which is going to help you in understanding this. I don't think so it's very well visible. So what I'll do is I'll try to zoom, and obviously I'll try to narrate. Just listen to me what I tell you over here. Okay, so what you have, let's say there is a patient who is having a let's say 60-year-old male patient who is having a VHL gene mutation. Okay, the patient is having a VHL gene mutation. When you take the history of this particular patient, what you have, the patient is chronic smoker, and the patient takes analgesics, like all the painkillers are taken by the patients a lot. Then the patient is working in a asbestos or a cadmium factory. Okay, so asbestos and cadmium are the risk factors for it. Okay, so all these are the risk factors what you need to understand over here. Okay, now the patient is coming to you with the features of hematuria. What is the patient having? Patients are having the features of hematuria. Okay, so the most common symptom or the most common presentation of the patients with renal cell carcinoma is hematuria. Okay, so first question what you need to understand is this. You know what we have what I told you, that elderly male who was chronic smoker who had analgesic abuse, and let's say there is a cadmium and whatever asbestos exposure. These are the risk factors. The risk factors are hypertension, obesity, and tobacco exposure. We talk about this hot, that's all fine. Okay, now what is going to be the presentation? There are two things which you need to remember over here. What is the most common presentation? Most common presentation is the hematuria. That's great. But if I ask you what is the characteristic triad of this particular stuff? Okay, so please try to understand. If at all I ask you what is the characteristic triad of RCC, it is mass with hematuria with pain. Okay, so this is a characteristic triad of RCC. But this particular characteristic triad is also referred to as a too late triad. It is called as a too late triad. Why it is called as a too late triad? Because by the time this occurs, it is already too late. Already the metastasis has already taken place. I understand my point. That is why it is called as a too late triad. Okay, and this is present only in 15% of the patients. Only in 15% of the patients to actually get this particular triad. You understand my point? Mass with pain with whatever hematuria, it is called as a too late triad. It is present in only 15% of the patients. That is why it is not very rare. Most common symptom of the patients is hematuria. Okay, now you examine this particular patient, and what they told you, that the patient is having a non-reducible varicose. Okay, so can anybody explain to me why do you okay, so what you need to understand, why did the patient develop a non-reducible varicose? On examination, let's say if I give you that there is a patient, or let's say if you give you that there is an elderly patient, okay, 65-year-old male patient who is coming to you with a non-reducible varicocele. Okay, non-reducible varicocele. Patient is coming to you, let's say on the left side. What are you going to suspect? Okay, what are you going to suspect? What will you suspect? Okay, what are you going to suspect if at all there is a patient with a non-reducible varicocele on the left side? Okay, what are you going to suspect? Elderly male. Okay, so if I ask you about the varicocele, is it more common in adults or in elderly population? Varicocele is more common in adults or in elderly population? It is more common in like young adults, 30, 40 years or something like that. It is more common in young adults. Varicocele, is it reducible or non-reducible? Normally, like I'm not talking about like in this particular scenario, in general, if you come across a varicocele, is it reducible or is it non-reducible? So varicoceles are reducible. Okay, please try to understand. It is reducible. Okay, varicoceles are reducible swelling. You understand my point? Varicoceles are reducible swelling. But in this, what you have, first and foremost, there is a patient who is 65-year-old, very, very elderly, and the patient is having a non-reducible varicocele. Why will the patient have a non-reducible varicocele over here? Can you please help me with this? Why will the patient have a non-reducible varicocele? Because characteristic features of this renal cell carcinoma. What you need to understand is renal cell carcinoma can have a tumor thrombus. Tumor thrombus. Okay. So renal cell carcinomas can have a tumor thrombus, And because of this particular tumor thrombus, what you need to understand, because of this particular tumor thrombus, the patients may have obliteration of that particular area. Okay, so renal cell carcinoma patients, they can have a tumor thrombus. Okay, I hope you have understood this particular point. What do I mean by this? Okay, what do I mean by this? So I'll explain it to you. Just give me a minute. Okay, so let's say this is a kidney. Okay, so let's say this is a kidney, and inside the kidney, what you have this is let's say renal cell carcinoma. Okay, let's say there is a renal cell carcinoma over here. What you need to understand, this particular tumor can kind of grow like this. It can grow like this. Okay, now this is about the right side. Obviously, I draw about the right side. What you need to understand, okay, let's say if it will, let's say I draw about the left side. It will be easier for me to tell you. So it can happen on both sides, right and left and both. I'll just draw it from the left side. Okay, why? You will understand it. Okay, so we have this particular renal vein over here. So what is the characteristic is that, let's say if at all there is a renal tumor, the tumor thrombus can grow into this particular renal vein. Now if I ask you what is draining into the left renal vein, I hope you are able to tell me that the left testicular artery. The left testicular artery basically drains into the left renal vein. Now what you need to understand, if at all the tumor thrombus is growing, it can obliterate this particular ostium, it can obliterate this particular area, and because of this, what is going to happen, the varicocele might get developed. This particular vein can get tortuous and dilated. You understand my point? So this is what is called as a non-reducible varicocele. It can happen on the right as well. Okay, so ultimately what can happen, this tumor thrombus can enter into the IVC and it can actually reach to the heart as well. Okay, so if at all it goes in the IVC, and if at all it kind of obliterates the IVC, where is the testicular vein of the right side draining? Okay, so you have right testes, right? So where's the testicular vein of the right side draining? It is draining into the IVC. Okay, so if at all this particular tumor thrombus reaches the IVC and it causes complete obstruction of the IVC, patients can have a varicocele of the right side as well. Okay, so don't be under the impression that only the left side varicocele will be non-reducible in the RCC. No, not really. What you need to understand is why there is a non-reducible varicocele, because the tumor thrombus is obliterating the lumen of that. Okay, so the lumen of the testicular vein, and that is why what you need to understand is that there is varicocele. This is non-reducible. So the bottom line, the final thing of this particular thing is, if at all a elderly, let's say 65-year-old male patient walks to you with a non-reducible varicocele, always do a ultrasound KUB. So you have to rule out a malignancy in these particular patients. So for that you have to do an ultrasound KUB. Okay, got it? Right? So KK and Chaitanya, I hope you understood. It's not an atypical presentation. It is not because of the renal vein pressure. It is because of this tumor thrombus. This is what I was trying to talk to you about. Okay, I hope you have understood, right? So because of this, the patients may have a non-reducible varicocele. So in this particular patient, the scenario which I was trying to give you, that if at all there is a non-reducible varicocele on the left side, obviously you kind of say that, and then what you do, you tell the patient that, you know, do you have any particular other symptom? So you say that, yeah, I have cough. So the patient says that I have cough. So if at all the patient is having cough, then what you're going to do? Then obviously you can do an X-ray, and on the X-ray what you get is a characteristic cannonball appearance. Cannonball appearance you basically get on the X-ray. What on earth is this particular cannonball appearance? So this is it. Okay, so this is a kind of X-ray where the metastasis can happen and the multiple metastasis can be there, like in cannonball. Okay, cannonball means like the in the olden times, what happens when the kings used to kind of fight with each other and everything, they used to have these particular cannonballs which they used to fire on their forts, okay, on each other's forts and everything. That is what is called as a cannonball appearance or the lung metastasis. Okay, I hope you have understood what is this cannonball metastasis. Okay, so I'll just summarize it. What do we have? We have a patient who was an elderly patient, let's say 60, 65-year-old male patient, who was a chronic smoker, who had, let's say, hypertension as well, who was obese, who was kind of having VHL gene mutation, who was chronically taking analgesics, like, you know, painkillers a lot, who was working in a factory where there was asbestos and cadmium exposure. All these I'm trying to summarize the risk factors. The patient came to you with a hematuria. Hematuria is the most common presentation of RCC. Patients could have come to you with a classical triad as well. What is a classical triad? Pain with hematuria with swelling. Okay, pain with hematuria with swelling. But if at all the patient comes to you with a classical triad, it is already too late. That is why it is called as a too late triad. When you examine, what you have to rule out is a non-reducible varicocele. So in these patients might develop non-reducible varicocele. Okay, what do you understand by non-reducible varicocele? That is the tumor thrombus. Why this is there? I hope you have understood why there is a non-reducible varicocele, because of the tumor thrombus, RCC. This is a characteristic feature of this particular RCC, that it presents or it kind of spreads as a tumor thrombus. So if it is growing as a tumor thrombus, it will obliterate the lumen of this testicular vein, which will lead to a non-reducible varicocele in these particular patients, right? Now, if at all you get an X-ray, you might get this cannonball type of a metastasis. Okay, I hope you are able to understand this point. These are all the things. Okay. No, so why analgesic, sir? Is it because of pain or is it a risk factor? Analgesics because NSAIDs. Okay, so they, if at all they keep, if you take a long medication, so what happens? There are many people who are fond of taking painkillers. Anywhere in the body there is a pain, every day they kind of take painkillers like a chocolates or something like that. Okay, so if at all the patient is taking painkillers for some chronic pain for years together, these painkillers will lead to the damage of the kidney, and this may be a risk factor for your renal cell carcinoma. Okay, I understand my point. So it is not because of the pain per se, it is because of the drugs which the patients are using. You understanding? Phenacetin mainly, right? I hope you understood, Chaitanya. Got it? Okay, so we have talked till now. Now let's talking further. If I ask you guys, what is a paraneoplastic syndrome? I'm pretty sure many of you guys might be knowing it, but in general, what is a paraneoplastic syndrome? So paraneoplastic syndrome is basically a condition where there is a tumor and the tumor has not metastasis. There is not the metastasis. There's no metastasis rather, but what is there? There is systemic manifestation. There is systemic manifestation. Okay, so there is systemic manifestations, and these systemic manifestations are because of some substance which is kind of produced by this particular. You understand my point? So what you need to understand is that there is a tumor, there is no metastasis. The patients are having systemic manifestations because of some substance is secreted by the tumor. Okay, because of the substances secreted by the tumor, there is a systemic metastasis. This is a very basics of a paraneoplastic syndrome. I hope that all of you guys must be knowing that. Okay, now what are the paraneoplastic syndromes associated with the RCC? So raised ESR. This is the most common paraneoplastic syndrome. Okay, that is the most common paraneoplastic syndrome associated with the RCC. That is first thing. Then we have hypertension, anemia, polycythemia, hypercalcemia. Why does hypercalcemia occur? Please try to understand. It is not because of the parathyroid hormone. This is because of the parathyroid related peptide. Please understand this particular point. This has been asked as an MCQ. Why does hypercalcemia occur in the patients with renal cell carcinoma? Not because of the parathyroid hormone. It is because of the parathyroid related peptide. Okay, right? And how do you manage this? This is a medical management. So normally what happens, let's say if at all there is a paraneoplastic syndrome. What did I tell you about the paraneoplastic syndrome? That there is metastasis is not there, but the patient is having systemic manifestation, right? Now, if at all this is the condition, what you need to understand, once you remove the tumor, the paraneoplastic syndromes can be treated. But hypercalcemia is a paraneoplastic syndrome which can be treated with the help of bisphosphonate. Bisphosphonate is the medication. You can give this medication, and with this medication you can treat this paraneoplastic syndrome, right? That is what you need to understand over here. So 2 points in the hypercalcemia, parathyroid related peptide, and the treatment is medical. It means that you have to treat it with bisphosphonate. Okay, now what else do you need to understand over here is that there is something which is called as a Stoffer's syndrome. What is the Stoffer's syndrome? This is non-metastatic liver failure. Okay, so what I'll just explain it to you. Okay, so what do you have? You have this particular kidney which is basically producing, which has this particular tumor over here. Okay, so there's a tumor over here. RCC is there. Now, what is this particular RCC producing? RCC is basically producing interleukin 6. Okay, so it's producing interleukin 6. This interleukin 6 is going, it is acting on the liver, and because of this particular interleukin 6, what is happening? The liver is having deranged enzyme. Deranged liver enzyme. Okay, so what do we have? We have deranged liver enzymes, and this is what you refer to as a Stoffer's syndrome. What is this? This is a Stoffer's syndrome. So Stoffer's syndrome is condition when the renal cell carcinoma is producing interleukin 6, is acting on the liver, which is going to have a deranged liver enzyme. Okay, so how do you manage this particular Stauffer syndrome? You have to go ahead with the nephrectomy. So what is the treatment of a Stauffer syndrome? It is nephrectomy. Nephrectomy. Okay, please try to understand the management is nephrectomy. Okay, right. Now about the staging of the RCC. What is the staging of the RCC? What you need to understand over here. So we have stage 1, A, 1B, 2A, 2B, then 3A, 3B, 3C, and 4. So what is T1A? T1A is basically, okay, T1 and T2 are the tumors which are limited to the or confined to the kidney itself. Okay, so they are confined to the kidney itself. So what is T1? T1 is less than 4 centimeters, T1A is less than 4 centimeters, T1B is 4 to 7 centimeters. What is T2A? T2A is 7 to 10 centimeters. What is T2B? More than 10 centimeters. Understood over here? Very simple. Less than 4, 4 to 7, 7 to 10, and more than 10. Okay, that is what is T1 and T2. What is T3? I told you about the tumor thrombus, right? So, very, very logical. What you need to understand, let's say if at all there is a kidney, and if at all, let's say there is production of a tumor thrombus, that tumor thrombus can either stay inside the renal vein or it can go into the inferior vena cava, which can be either infradiaphragmatic or supradiaphragmatic. So, if at all this particular, what you call as a tumor thrombus is extending only till the renal vein, that is T3A. If at all it is going, like if it is going into the IVC, but is below the diaphragm, that is T3B, and if it is going above the diaphragm, that is what is the supradiaphragmatic, that is what is called as a T3C. Everybody have understood this particular point? Yeah, I hope you got this particular, right? Now, I give you a question. I give you a question that let's say if at all, this is the 2 kidneys with the renal cell cancer. Okay, so these are the 2 kidneys with the renal cell cancer. Now, and there is an adrenal gland also which is situated on the top of the kidney. So, there's an adrenal gland also which is secreted on the top of the kidney. Now, in this particular thing, what happened? That the tumor was present on the superior pole and it is involving the adrenal. And in this, what is there? That there is a tumor on the lower pole and there is an involvement of the adrenal as well. Okay, so can you please tell me the T stage of this, or what is the T or N or M, or what exactly is this? Please try to understand. Let's say if this is an example A. In the example A, what is there? There is a contiguous. Okay, it means that because of the direct extension. Okay, so here the adrenal is involved because of the direct extension into the adrenal. You understand my point? So in this, the adrenal gland has been involved because of the direct extension into the adrenal. So this is what is your T4. Okay, this is what is a T4. But if at all there is a tumor in the lower pole of the kidney, okay, so there is a tumor in the lower pole of the kidney, and along with this adrenal is also involved, it is because of the hematogenous spread. So this is what we consider as a metastasis. Okay, so please try to understand. This is what we consider as a metastasis. Okay, so this is what you consider as a metastasis. Am I making some sense to you guys? Okay, so if at all there is a direct extension in adrenal, that is what is T4. But if at all it is going through the blood vessels, this is what is considered as a metastasis. Okay, so please try to understand this particular thing. Very, very important. Okay, so this is about the T stage. As you can see over here in the T4, what is happening? The Girota's fascia is breached. Okay, so what is happening? Girota's fascia is breached, including the contiguous spread to the adrenal. That is T4. But if at all there is an kind of a tumor over here which is going to the adrenal, it is probably hematogenous, and that is why it is considered as a metastasis. Very, very important concept. I hope you have understood this point. Now, lastly, now this is something which is given in your love and Bailey, guys. Okay, so you should be knowing this. Okay, they might ask you all these particular stuff. So for the metastatic kind of RCC, you have a tyrosine kinase inhibitors, you have mTOR inhibitors, but the newest, if at all they will ask you, is this T cell immune checkpoint inhibitor. In this, you have 2. You have programmed cell death protein 1 ligand 1, PDL1. Okay, so what is this called as a programmed cell death PDL1, or this is PD1. What do you understand by PD1? It is programmed cell death protein 1. So what are PDL1 like medications which we use for this? It is avelumab and atezolizumab. Okay, avelumab and the atezolizumab, these are PDL1 inhibitors which you use in the metastatic RCC. What are PD1? So you have a nivolumab and pembrolizumab. Nivolumab and the pembrolizumab. These are the PD1. Okay, so please understand what are the PDL1. PDL1 are avelumab and atezolizumab, and PD1 are nivolumab and pembrolizumab. Okay, so please try to understand these are the medications which we use in the metastatic RCC. Okay, now let's move on to the next question. A 22-year-old male patient has come to the emergency with an acute severe pain in the scrotum. Okay, so there's an acute severe pain in the scrotum. The physical examination findings of the patient have been shown. What is the diagnosis of this particular patient? So I will just enlarge this particular image first. So the image is trying to show you something, right? The image is trying to show you something on this particular kind of image. I hope that you are able to see something, right? And if I ask you, what is the diagnosis of this patient? Is it like a testicular torsion of hydrated of Morgagni, epididymoorchitis, or whatever testicular necrosis? Okay, so what is the answer over here? Can you please help me with this? What is the diagnosis? Just waiting for your responses, guys. Please tell me. I'll just expand on the image. So what is the diagnosis over here? Is it like a testicular torsion, torsion of hydrated of Morgagni, epididymoorchitis, or the testicular necrosis? Okay, please tell me what is the answer over here. Yes, it is a torsion of hydrated of Morgagni. And what are you basically seeing over here is a characteristic blue dot sign. Okay, so very nice, very nice. Okay, so what I'll tell you, I'll just tell you about the painful scrotal swelling. What do you understand by a painful scrotal swelling? So let's say if there is a male patient who is coming to you in the emergency with a painful scrotal swelling. What are the differential diagnoses over here? What are the differential diagnoses which can be over here? The differential diagnoses are, one is the torsion of hydrated of Morgagni. Then what else do we have? We have testicular torsion. Then what do we have? We have epididymoorchitis. Okay, right? So yes, the answer is not epididymoorchitis. It is B only, torsion of hydrated of Morgagni. Okay, so please try to understand. The painful scrotal swelling, what are the differential diagnoses? Torsion of hydrated of Morgagni, testicular torsion, and epididymoorchitis. Okay, so please try to understand these things. What is the torsion of the hydrated of Morgagni? So we have this particular testes. Now we do have an appendix in our body, right? In the similar manner, there is an appendix of the testes also. So there is basically a vestigial kind of a pedunculated stalk. Like with a pedunculated stalk, one particular structure has been attached to the surface of the testes. This is what is called as an appendix of testes. Okay, what is this called as an? This is called as an appendix of the testes. Now, what we need to understand over here, that obviously this is getting some amount of blood supply and everything, right? Now, this can undergo torsion and this can rotate on its own axis. If it rotates on its own axis, what is going to happen? The blood supply to this particular thing will get lost. And if at all the blood supply to this particular thing gets lost, what is going to happen? It will undergo cyanosis. So here there is going to be cyanosis, and obviously it's going to have necrosis and all those particular things with necrosis. Okay, so what is going to happen? The patients are going to come to you with a very, very painful scrotal swelling. That's what they are going to come to you with. But when you kind of approach to this, and when you examine this particular patient, and when you kind of stretch the skin over this particular stuff, what you're able to see, you are going to see this characteristic blue dot sign. Okay, what are you going to see? You're going to see a characteristic blue dot sign over here. Okay, so the skin has been stretched, and just behind this, what you have is this like a torsion, like the stalk of this particular stuff. Are you able to understand this? Why blue? Because there is cyanos, there is necros, right? If at all you have this torsion of hydrated of Morgagni, how are you going to manage it? Okay, so this is what is a torsion of hydrated of Morgagni. How are you going to manage it? Management is pretty simple, nothing conservative. Okay, so you just give painkillers, conservative. So you just give painkillers, and that's it. Painkillers. That is what is the management of this. Okay, so that is how you manage the patients of this torsion of hydrated of Morgagni. Now coming to the important differential diagnosis, that is testicular torsion and epididymoorchitis. So if at all you want to distinguish between testicular torsion and epididymoorchitis, what do you have, guys? Can you please tell me what is the test which you have? Okay, so we have something which is called as a French sign. What is it called as a French sign? What is this French sign, guys? What is this French sign? Okay, so in this, what you do, you elevate the testes. If you elevate the testes, what is going to happen? What should happen rather? If at all, on elevation of the testes, if at all, the pain increases. all the pain increases or if at all the pain reduces. If at all the pain increases, then what is the diagnosis? If at all the pain increases, what we are dealing with is testicular torsion. Okay? If at all the pain increases, what we are dealing with is testicular torsion. If at all the pain reduces, then what are we dealing with? We are dealing with epididymo or dealing with epididymo orchitis. It is very, very important, guys. Okay, please try to understand this point. So, if at all we have this particular patients with a painful scrotal swelling, if we go and we elevate the testes, if on elevation of the testes the pain reduces, what is it? Epididymo orchitis. If on elevation of the testes the pain increases, what is this? That is what is a testicular torsion. Making some sense to you guys? This is what is called as a French sign. Okay. Now, you would have also heard of Doppler. So, what are your thoughts on Doppler? Can we do it or not? Okay. Will Doppler help or not? Okay. What about the Doppler studies? Are the Doppler studies going to help? Doppler, is it going to help? Okay, so what you need to understand is, yes, Doppler may help. Okay, so if at all you perform a Doppler and if at all you're dealing with, let's say, testicular torsion, what are going to be the findings on the Doppler study? On the Doppler study, in the testicular torsion, you're going to have a reduced flow of blood. You have a reduced flow. And let's say if we talk about epididymo orchitis, epididymo orchitis. Okay, so you talked about the epididymo orchitis. What you need to understand about the epididymo orchitis, what is there? So in the epididymo orchitis, what you need to understand is there's going to be an increase in the flow of blood. Okay, so there's going to be increase in the flow of the blood in epididymo orchitis, and there's going to be reduction in the flow of the blood in the testicular torsion. Yeah, everybody have understood this particular point, right? Yeah, got it. Now, but if I give you a clinical scenario, what they don't ask you this, obviously they are not going to ask you this. What they ask you is that, let's say there is a patient came with a painful scrotal swelling, painful scrotal swelling. You performed a French sign. French sign. Okay, but it is equivocal. It means that you're not able to tell whether the patient is having testicular torsion or epididymitis. Obviously, you're not able to tell. You have a suspicion of a testicular torsion though. And what about the Doppler? The Doppler is not available. Not available. So, will you refer the patient? Will you refer the patient to the higher center? Will you refer the patient to this particular higher center? What do you think? So I'll just give you a scenario that there's a patient who came to you, you examined the patient, you thought that, you know what, there can be a testicular torsion, but you're not sure. And now you tried to look for the Doppler that was not available, or maybe it was equivocal, or the radiologist was not available, or something like that. Then what you need to do, can you refer this patient to the higher center, yes or no? Can you please tell me, can you refer to this particular patient to the higher center, yes or no? The answer is no. Okay, so please don't need to understand over here, the answer is no. We will not refer this particular patient to the higher center. Why? Because it will waste time and maybe the patient will not reach to the higher center in timely manner, and ultimately the patients might lose their testing. So never ever refer to the patient. Okay, so please understand, never refer the patient with suspicious or as a suspicion of torsion. Okay, you never ever refer the patient with this as a suspicion of torsion, because it is a surgical emergency. Please understand this point. So in other words, if I just reframe it, Doppler study you can do, which can be supportive in your diagnosis, but your management will not change just because of the Doppler. You understand my point? Just because of the Doppler findings, you're not going to change your management. Okay, right. So that's what you need to understand. How are you going to manage it? So obviously you are going to go perform a scrotal exploration. Okay, so you performed a scrotal exploration. You did a scrotal exploration. After that, what do you find? After doing a scrotal exploration, what did you find? You found that okay, so you detoted the testes or something, and if you found that the testes is viable. Okay, if you found that the testes is viable, then what? If at all you found that the testes is viable, you are going to perform an orchidopexy. If at all you found that the testes is not viable, what are you going to perform? You are going to perform an orchidectomy. But in both these scenarios, okay, in both these conditions, it is mandatory for you to perform orchidopexy of contralateral testes. Understand my point? So contralateral testes orchidopexy is the must way. Okay, please understand this. Okay, so you explode the scrotum, you try to see whether the testes is viable or not. If at all the testes was viable, that's great. You fix that particular testes. If at all the testes was not viable, you cut and throw it off. But do not forget to kind of do the orchidopexy of the opposite, the contralateral kind of testes. Why? Because if you don't do that, then probably a probability is there that, let's say after a few months or so, the patient will come to you with a torsion of the opposite kidney, opposite testes, because there is some genetic kind of anatomical abnormality associated with, like the bell clappers anomaly, or let's say a inversion of the testes or something. Okay, so this is all about the testicular torsion, which you need to understand, guys. It's a very, very important topic. I hope you have understood. Okay, now let's move on to the next kind of question. A 45-year-old male presents with an episodes of an alcoholic pancreatitis. Okay, so patient was alcoholic, patient landed up into pancreatitis. Okay, right now what you have is that he makes a kind of a slow but steady progression. That's fine. He is reviewed clinically at 6 weeks following the admission. He has diffuse fullness of his upper abdomen, and on imaging, the collection fluid is found to be located behind the stomach. His serum amylase level is mildly elevated. Which of the following is most likely explanation? What we were trying to ask you is that, okay, so can you please tell me what is the answer over here, guys? What is the answer over here, guys? Yeah, what is the answer? Please tell me. Pretty simple question and very important one. What do you think? What is the answer over here? So there's a patient who is having this particular episodes of alcoholic pancreatitis. 6 weeks later from the admission, patient has it. Okay, pseudocyst. Okay, pseudocyst. Yeah, everybody agrees, pseudocyst. Now, if I ask you that I make this particular duration as 3 weeks, okay, so please, a modified question. Okay, so the answer to the first question is definitely pseudocyst of pancreas. Okay, I'm telling you the second question. The second question is, when you're making this particular kind of question, the modified question is that it is 3 weeks from the time of the onset of the pancreatitis. Now what's going to be? So Chaitanya and KK, what do you think? What is going to be the answer now? It's a very, very important concept which you're going to learn. If at all you stick around for around next 10 to 15 minutes, it's a very, very important concept which you're going to do. Okay, so now what's going to be the answer? Pancreatic abscess. Okay, really? Okay, what about you, KK? What do you think? What is the answer over here? If at all you are if at all I give you the duration of 3 weeks, then what's going to be the answer? Okay, guys, yes, acute necrotic collection. No, the answer is going to be early fluid collection. If at all it is 3 weeks. Okay, and over here it is going to be the acute peripancreatic collection. That's fine. And over here, definitely the answer is, with the 6 weeks, the answer is definitely pseudocyst. Okay, so let's try to talk about this. Okay, so what you need to understand is that if you talk about the pancreatitis, okay, if you talk about the pancreatitis, what you need to understand is pancreatitis can be broadly divided into what? It can be broadly divided into interstitial pancreatitis and necrotizing pancreatitis. Yes or no? Yeah. So pancreatitis can be broadly divided into interstitial pancreatitis and necrotizing pancreatitis. I'll just elaborate on this. So pancreatitis can be broadly divided into interstitial and necrotic. Yes or no? Yeah, interstitial or the necrotic pancreatitis. Okay, now let's talk about this interstitial and the necrotic. Okay, so there are 4 terminologies which you need to understand, which are very, very empirical for you to understand. One is basically called as a acute peripancreatic collection. So let me just walk you through it. What is this acute peripancreatic collection? Less than 4 weeks of a duration. In the patients with an interstitial pancreatitis, there is a homogeneous fluid density. What do you understand by homogeneous? there is a uniform fluid density is there. Okay, uniform. It means that only fluid is there, no solid component, no necrosis, nothing. That is what you need to understand over here. Fluid density, no fully defined wall. So this is kind of important. No fully defined wall. There is no wall around it. How it is bounded by? It is bounded by the facial planes. Okay, it is bounded by the facial planes. And yeah, that's I just in the pancreas. That's obviously given. Okay, so if I tell you that there is a patient who is coming to you after acute pancreatitis, the duration from the onset of the acute pancreatitis is how much? Is, let's say, 3 weeks. Okay, and what is the patient coming to you? Patient is going to coming to you with a homogeneous fluid density. Homogeneous fluid density means that there's only fluid. There's no necrotic component inside. Okay, there's no necrotic component inside it, and that particular fluid is not fully defined by wall. Okay, so there's no wall around that particular fluid. Okay, that particular fluid is bounded by the facial planes. There is no well-defined wall around it. Okay, and this is what you call as an acute peripancreatic collection. Am I making some sense to you guys? Very, very important. Very, 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 very. Please understand. Okay, right. Now coming down to the pseudocystic pancreas. What changes in the pseudocystic pancreas? Two things. If at all, the same findings are there. Exactly the same finding. Interstitial pancreatitis, homogeneous fluid kind of density, no solid component, but more than 4 weeks and with a well-defined wall around it. This is what is called as a pseudocystic pancreas. Okay, so let me just elaborate over here. More than 4 weeks, well-defined wall, interstitial pancreatitis, homogeneous fluid density. This is what is called as a pseudocystic pancreas. Am I making some sense to you guys? Yep, I hope I am making some sense to you guys. Okay, so now what you need to understand, this question was fine. Okay, 6 weeks, definitely the answer is pseudocystic pancreas. But in the same question, if I make the duration as 3 weeks, now what is going to be the answer? Acute peripancreatic collection. Okay, everybody have understood this particular point, guys? Yeah, just give me a thumbs up if all you have understood this particular thing, right? So I'll just repeat it. There's a patient with an interstitial pancreatitis. Interstitial pancreatitis, that the patient is there. The duration from the onset of the pancreatitis is given less than 4 weeks. And they say that there is a peripancreatic fluid collection. That's great. What are the characteristics of that particular fluid collection? It is homogeneous. It is not having any kind of component, physical component into it. Any solid component is not present inside that particular fluid density. Then what else is given? That, okay, there's no solid component present inside it. That's all okay. The fluid is not bound by a well-defined wall. There's no well-defined wall, but it is bounded by the facial planes. Okay, so no well-defined wall, but it is bounded by the facial planes. What is the diagnosis? The diagnosis is an acute peripancreatic collection. Okay, that is what is called as acute peripancreatic collection. Then what do we have? We have the, so this is one. If at all the same thing is given, all the other findings are the same, but the duration has been given more than 4 weeks, and there is a well-defined wall around it. That is what is a pseudocystic. Okay, I hope you have understood this. Okay, right. Now let's talk about the necrotizing pancreatitis. Okay, so now let's talk about the necrotizing pancreatitis. I told you that there's an interstitial and the necrotizing pancreatitis. Okay, in the necrotizing pancreatitis, if they give you that the duration from the onset of the pancreatitis is 4 weeks, okay, and the patient is having a necrotizing type of pancreatitis, yes, that's fine. There is a heterogeneous collection. Obviously, if at all there is a necrosis, it is going to have a heterogeneous collection, right? No doubt about it. And there is no fully defined wall. There is no fully defined wall around this particular stuff. It is bounded by the facial planes only. Okay, so this is what is a acute necrotic collection. Okay, so I hope you have understood, right? So I hope you have understood. Somebody had said in acute. Okay, so KK had said acute necrotic collection. It's not going to be acute necrotic collection because you were right on the thinking grounds. But what you need to understand is there was no necrosis. So it was an acute peripancreatic collection. If at all they give you heterogeneous density, then yes, that's going to be acute necrotic collection. And in the similar manner, if at all we are dealing with the patient more than 4 weeks and there is a well-defined wall around it, we have a patient with a necrotizing pancreatitis which is having a heterogeneous collection. What is the answer? It is a walled off necrosis. Yes or no, guys? So these are the 4 terminologies which you should know in and out: acute peripancreatic collection, pseudocystic pancreas, acute necrotic collection, and the walled off necrosis. If I ask you what is the management for an acute peripancreatic collection, what do you think? What is the answer over here? Okay, can you please tell me what is the management for an acute peripancreatic collection? What is the management for acute peripancreatic collection? I'm waiting for you guys. Okay, what do you think? What is the answer over here? Okay, so the management for the acute peripancreatic collection is conservative. Okay, what is the answer over here? How do you manage these particular patients of acute peripancreatic collection? It is conservative. conserve. You understand my point? It's a conservative management which you basically follow. Yeah, wait and watch. Absolutely right. Okay, conservative or wait and watch. Okay, got it. Right. So pretty simple. I'll just summarize things for you guys. In the interstitial pancreatitis, what do we have? We have an acute peripancreatic collection. If at all these particular things last for more than 4 weeks, it gets converted to pseudocyst of pancreas. So this of pancreas. What about the acute, like necrotic? So here what we have is an acute necrotic collection. And if at all this particular stuff is for more than 4 weeks, this is what is called as a walled off necrotic. What is this called as? This is what is called as a walled off. And my point, please try to understand this particular stuff. Very, very important. I hope you have understood. Okay. Now, lastly, let's talk about the pseudocyst of pancreas. What is this like? Okay, so if I ask you, if at all there is a patient who is having a pseudocyst of pancreas, what is going to be the clinical features of this particular patient? You would say that, you know what, there can be some fullness in the gastric region, on deep palpation. On deep palpation, you can have a mass which you're able to palpate. So if at all you palpate deeply, and if at all the patient is very, very thin or something, then you might be able to palpate a mass as well. But one of the important presentations of these particular patients is called as an early satiety. Early satiety. Why is this early satiety? Please try to understand over here. What do we have is, this is what is a pseudocyst of pancreas. We have this particular pseudocyst of pancreas, and this particular pseudocyst of pancreas, when it grows, basically compresses the stomach in front. So if at all it is going to compress the stomach in front, whenever the patient eats food, patient might feel a bit like full a bit early, because the size and the capacity of the stomach is not very big. Okay, so that is what you need to understand. We might kind of feel that the stomach is getting kind of full early. So that is what is called an early satiety. All these will be the presentations of the patients with pseudocyst of pancreas. So you also need to appreciate on the CT scan what is the pseudocyst of pancreas. I hope you're able to understand. This is what is a cyst, which is what is the thickness of the wall and everything, and this is what is a pseudocyst of pancreas. Okay, please try to understand this. This is what is a pseudocyst of pancreas. Okay, got it. Now, what about the management? Okay, so before management, there's something which is called as a DigiDio classification. What is this DigiDio classification, guys? This is a DigiDio classification which you basically get on which which modality? This DigiDio classification you basically get on ERCP. Okay, on ERCP you get this DigiDio classification. What is this DigiDio classification of ERCP? You see two things. See whether there is any peripancreatic collection there or not, and what about the duct? The duct kind of whether it is abnormal, whether it is normal, or whether it is communicating with the collection or the cyst. Or you understand my point? This is what is called as a DigiDio classification. So in the acute pancreatitis, what is there? There is a collection and there is a duct. The duct is normal and there is no communication between the collection and the duct. Okay, so that is what is a type 1 DigiDio classification. Okay, what about type 2? In the type 2, it is acute on chronic pancreatitis. Okay, it is called as an acute on chronic pancreatitis. In this, what is there? There is a kind of pancreas, there is a collection, there is a duct also, but the duct is abnormal. Okay, it means that there is what you call as multiple strictures and the dilatation. That is what is present inside the duct. That is what is called as an abnormal duct. Okay, abnormal duct, but like there's an abnormal duct. It's like the contour is kind of problematic, but per se the strictures are not there. No stricture is there. So that is what is a acute on chronic pancreatitis. What about the chronic pancreatitis? Over here, first of all, there is a communication as well, and the strictures are also present. So obviously the duct will be abnormal and everything. Obviously it's not going to be the normal duct. It is going to definitely be an abnormal duct. It's going to be dilated, it's going to be strictures, and they will also be communicating with that particular kind of cyst or whatever the collection. Okay, so please try to understand this is what is a DigiDio classification which you basically get on ERC. Okay, now let's talk about the management. So how do you manage this? Okay, so please try to understand this, that if at all, let's say you have a cyst, okay, if at all you have a cyst like the pseudocyst, if you have a pseudocyst, what you need to understand is that if at all the size of the cyst is less than 6 centimeters, okay, or the duration is less than 6 weeks, or the patient is asymptomatic, okay, if all the patient is asymptomatic, then what is the management? Management is conservative. Okay, so size less than 6 centimeters, duration less than 6 weeks, and if at all it's asymptomatic, then it is conservative management. But if at all you have a pseudocyst of pancreas which is more than 6 centimeters in size, which is more than 6 weeks in duration, and which is symptomatic, any of these, okay, symptomatic, then what is there? This, like more than 6 centimeters, more than 6 weeks in duration, and symptomatic. What is this? Here you have to kind of go ahead and operate. You have to do the surgery. Which surgery you have to do? Cystostomy or cystogectomy. Understand my point? You have a cystogastroctomy and a cystogectomy. Please try to understand. Okay, so this is how you manage the patients of a pseudocyst of pancreas. Very, very, very. Okay, I hope you have understood it. Okay, got it? Now let's move on and let's talk about the next question. Okay, so following an uncomplicated laparoscopic cholecystectomy, a patient is found to have a bile leak. Okay, that's fine. So after you have done a, we call as a cholecystectomy, the patient is having a bile leak. So how did you come to know that? So during the surgery, you would have put in a drain. You went in the wards on the next day, you evaluated the patient, and on evaluation, what you found? You found that the patient is having a bile leak. That's what you need to understand. Okay, that's fine. On ERCP is performed and the leakage is noted from the cystic duct. So you did an ERCP. What did you find? That the leak is there from the cystic duct. Okay, so we talk about the anatomy and everything. What is the most appropriate course of action? I want you to answer this thing, guys. So can you please tell me what is the answer over here? Undertake a sphincterotomy and place a stent in the common bile duct, undertake laparoscopy and place a T-tube into the bile duct, start the patients on the TPN and keep them nil by mouth, or transfer the patient to the biliary bypass procedure. Okay, what do you think? What is the answer? Okay, so KK is saying that we have to do a laparoscopy and place a T-tube in the bile duct. Okay, what do you think, guys? What is the answer? Anybody else wants to attempt? Please put your answers on the comment box. It's very, very important. Now, this is a very, very important topic which I'm going to cover now, which is like a bit dreadful for many of the students, right? So bile duct injury. So that's what we are going to cover. So stick around. You will learn quite a lot of things. Okay, the answer is not B. Okay, what is the answer? Answer is A. What is the answer over here is A. Now I understand your kind of dilemmas and your doubts and everything. Let's kind of talk about them. You will understand it. Don't worry. Okay, so let's try to talk about it. Okay, so what we need to understand is that okay, so let's talk about the cholecystectomy. Okay, so let's talk about the cholecystectomy. Okay, so we all know that if at all there are various indications of a cholecystectomy. Okay, right? You did a cholecystectomy. Nowadays, what you basically do is a laparoscopic approach. So laparoscopic cholecystectomy is usually what you do. Now, after this, what you basically do, you put in a drain. After this, you put in a drain, and this particular drain is monitored. How it's monitored? Okay, you kind of look at the output, like what is the content of that particular drain? Is bile coming out? Is zero hemolytic fluid out? What particular fluid is coming out? That is what you have to kind of monitor. And based on whatever the output of the drain is, then you understand, So usually what happens if at all there's an uncomplicated surgery, the drain output reduces. And once it goes, let's say around 30, 40 or something, patient is doing fine. In a couple of days, we remove the drain and the patient goes home. But let's say if at all next day morning you went to the rounds and you found that there is 300 ml of the bile which is present on the drain. Obviously, it is not right. That should not happen. What might be the cause of that? Bile duct injury, right? So what you need to understand, what might be the cause of that? That is a bile duct injury. Okay. So what about the bile duct injury? Okay. So what about the bile duct injury? So if at all in the drain, what you have is a bile, then you suspect bile duct injury. Okay. But then you might be scratching your head thinking that, where the hell is this bile duct injury? Is the bile duct injury in the common hepatic duct, common bile duct, right duct, cystic duct? Where exactly is this particular bile duct injury? So you don't know, right? You don't know that. So for that, what you need to understand, you have to do certain investigation. Which investigation is going to help you? ERCP. You do an ERCP, and that is what might help you. ERCP and also MRCP is also good in order to kind of tell you about the anatomy. So MRCP might miss a couple of them, and ERCP may type 2 will not be. In other words, okay, it's fine. ERCP and MRCP are going to help you in diagnosing this particular bile duct. Okay, that's fine. Yes, understood. Now, let's talk about the bile duct injury, and then we'll come back and we'll talk about this T-tube also. So don't worry, we'll talk about this particular T-tube, where do you put it and all this particular stuff. Before that, let's talk about the bile duct injury. So let's say you did an ERCP or MRCP or whatever you did. Based on that, you get a classification. Like based on this, based on the location where this particular injury is there, you have a Bismuth-Strasberg classification. Okay. Now this is a very, very important classification. Oh, I did not put that image. Really sorry. I don't have it at this point of time, but no issues. What I'll do, I'll try to explain. Okay. So what you need to understand is that in the type 1 Bismuth-Strasberg classification, what is saying? Okay, first of all, before talking about this, let's try to understand how do you perform a laparoscopic cholecystectomy. Okay, so let's say this is a liver. This is the liver. What is this? There's a right and the left hepatic duct, which is basically coming down, common hepatic duct. What is there? There's a cystic duct. I'm deliberately drawing cystic duct a bit big because I want to demonstrate something over here. Then we have a common bile duct, which is entering into the intestine. Okay, so it's basically entering into the intestine. When you're performing this particular laparoscopic cholecystectomy, what you do, you apply 2 clips. You apply 2 clips at the cystic duct. You apply 1 clip over here. So ultimately, you apply 3 clips. Okay, 1 near the gallbladder, 2 near the like the residual stump of the cystic duct. Then finally, what you do, you cut it. You cut this particular or whatever the cystic duct between these particular clips. Okay, you cut this particular stuff. And after cutting this, what you do, you basically remove this particular gallbladder out. Okay, remove this particular. Are you understanding my point? This is how you perform a laparoscopic cholecystectomy. But while doing this particular procedure, after this particular procedure, if at all, obviously inside the surgery, you can do other things as well, right? You might end up injuring this, or you might end up injuring this or something like that. Okay, so please try to understand, based on the different types of injuries, you should be able to appreciate what type of a Bismuth-Strasberg classification is this. Okay, so let me just kind of draw one by one for you guys. So what you need to understand is that in the type 1, what is happening, that the clip which you had applied on the cystic duct, it either slipped off or you failed to apply it. So here in the type 1, what is there? There is a bile which is leaking from the cystic duct. Okay, so here what is happening? There's a bile which is leaking from the cystic duct. So please try to understand over here. This is the liver, and what do you have? You have this particular right and the left hepatic duct, which is basically common hepatic duct. Then you have this cystic duct. Okay, you have this particular cystic duct, and over here what you have is a common bile duct. So here what is happening? The bile is basically leaking from this cystic duct. Are you understanding my point? So this is basically your type 1 Bismuth-Strasberg classification. Hope you have followed these. Okay. Now it is a very, very important topic, guys. Please stay with me for 10 to 15 minutes. You will understand this in a great detail. Okay. Now what about the type 2? The type 2, what is happening? In the type 2, what you did, you have this particular, okay, I'll just kind of copy this so that it saves our time a bit. Okay, so let's say, okay, so what you need to understand over here, okay, so in the type 2, what is there? In the type 2, you have applied the clips on the cystic duct in a good manner. That's great. But what you did was, there was an aberrant right hepatic duct, you ligated that aberrant right hepatic duct, and you also clipped this. Okay, so you ligated and you clipped that also. You understand my point? So this is okay. Like in the cystic duct, you had to apply the clips, you have applied to, that's fine. But what you did, there was an aberrant right hepatic duct. What is this? This is what is an aberrant. Aberrant means extra. You're like aberrant right hepatic duct. What you did to this particular aberrant right hepatic duct, you basically ligated it and you cut it in the between. In the type 2 Bismuth-Strasberg classification, what I'll just write down the description. What is happening over here? You have ligated aberrant right hepatic duct. If at all you have ligated this aberrant right hepatic duct, what do you need to understand is, okay, if I ask you, is there going to be any bile leak over here? Please understand, bile leak is not there. So there's no bile leak in this particular step. Okay, no bile leak in type 2 bismuth transfer classification. So if I say if you perform an ERCP in these particular patients, it is going to be normal. No bile leak ERCP is going to be normal. Am I able to understand? Like, I hope you are able to understand this particular point. ERCP is normal, no bile leak in the type 2 bismuth transfer class. Everybody understood this particular point? Now, coming to the type 3. The type 3, what you have done is, now, the type 3, what you have done is, you have cut this aberrant right hepatic duct. Okay, so in this, what you have done, you have cut this aberrant right hepatic duct, but you failed to apply the clip on the proximal aspect of it. Okay, so you failed to apply the clip on the proximal aspect of it. Okay, so I'll just draw it and I'll draw it to you. Okay, so here there is a bile leak from aberrant right hepatic duct. Okay, so there is a bile leak from the aberrant right hepatic. Okay, please try to understand what is there. There is a bile leak which is happening from this aberrant right. Okay, then what you have? You have 4, type 4. What is this type 4? It's actually called as A, B, C, D. Okay, so I'll just correct this. What is it called as? It is type A, B, C. Okay. What is this? A, C, and what we have is D. Okay. So what is this in the D? What happens? There is partial injury to common hepatic. Okay, so what is this? There's a partial injury to the common hepatic. So just telling you what is the thing is over here. So you just kind of understand this. What is there? This particular you have ligated. Oh, normally, like the cystic duct has been ligated normally, but there is a partial injury to this common hepatic duct. So there is a bile leak from this common hepatic duct. You understand my point? So okay, now let's summarize it. Let's summarize it. What we have talked till now, we have talked about the type A, B, C, and D type of a bismuth transfer classification. Okay, please focus. What is this? In the first, what is there? There's a bile leak from the cystic duct stump. Okay, why there's a bile leak from the cystic duct stump? I told you that the clips on the what you call as a cystic duct kind of either slipped off or you failed to apply them in totality at all. So here what is there? There's a bile leak which is happening from the cystic duct stump. That is what is the A. What about B? In the B, what did I tell you? That there is ligation of an aberrant right hepatic duct and ligation of the cystic duct. In other words, there is no bile leak. What you did was that cystic duct you clamped nicely. That's a good job. But what you did was there was an aberrant right hepatic duct. You failed to appreciate that it is a hepatic duct. If you ligated, the biliary drainage of this particular area will get hampered. So you fail to kind of appreciate it and you ligated it. When and ligated, you cut it, but there's no bile leak. So that is an MCQ point. No bile leak, and because there's no bile leak, ERCP is going to be normal in these. Okay, I hope you have understood this particular point. Now, finally, what do we have is that we have this type C. In the type C, what is there? That you failed to ligate, you cut the right aberrant hepatic duct, but you failed to ligate it. So what is going to happen? The bile is leaking from this aberrant right hepatic duct. Okay, so that is the type C. What about type D? In the type D, what you need to understand, there is an injury to the common hepatic duct. There is an injury to the common hepatic duct, and there is a bile leakage from this common hepatic. Please try to understand. This is what is the A, B, C. Everybody understood this point? Now, let's talk about E. Okay, so this is okay. Just give me a thumbs up, guys, if you have understood till now. It became a bit more tedious because I had to draw everything. Ideally, I show image. I failed to put this into the slide. I'm really sorry for that. Apology. I hope you have understood. I've drawn and I've tried to kind of make you understand. Okay, just give me a thumbs up if all you have understood it till now. Okay, now let's talk about this E. What is this E? E includes total injury. So E includes total injury. So what is present in the C? Now E also has E1 to E5. Okay, so I'll try to kind of explain it to you in one go itself. Now, what you need to understand is that okay, I'll explain you in one go itself. So here, what is there? There's a complete injury. Okay, what is there? There's a complete injury. You have ligated this, that's fine, but there's a complete injury. What complete injury is there? So let's say if at all there is a complete injury to the common bile duct, which is more than 2 centimeters. What is E1? E1 is there, that is a complete injury which is more than 2 centimeters from common hepatic duct. Okay, more, like from this confluence. Okay, this is what is a confluence from not the common hepatic duct, from the confluence. You understand my point? From this confluence. What is this confluence? Where the right and the left hepatic duct are coming and joining with each other. So if at all the injury, complete injury is there, more than 2 centimeters away from the confluence, that is what is the E1. What about E2? In the E2, what is there? There is injury which is less than 2 centimeters from the confluence. Okay, so here what you need to understand, there is an injury, but this is less than 2 centimeters from this particular confluence. What about E3? In the E3, what you have, in the E3, it is involving the confluence, but the continuity of the confluence is still maintained. Okay, are you able to appreciate it? So here, confluence is involved, but continuity is maintained. Okay, so confluence is involved, but the continuity is also maintained. What about E4? In the E4, the continuity is lost. Okay, in the E4, what is happening? The confluence is involved and the continuity is lost. What about E5? E5 is very weird. So here there is a complete injury to common hepatic duct along with right aberrant hepatic duct. Okay, this is what is E5. So please try to understand this particular point, guys. This is E1, E2, E3, E4, and E4. So common hepatic duct structure with the injury to the right aberrant hepatic. Okay, so this is what you call as a Bismuth-Strasberg classification. Now I understand it have become very, very monotonous for you guys, but guys, this is a very, very important topic. So please try to understand this particular point. What is there over here? So here what we have is that, okay, so type A is bile leak from the cystic duct sample. Okay, everybody understood this point? Then what do we have? We have like in the B, what do we have? Ligation of the aberrant right hepatic duct and the ligation of the cystic duct. No bile leak was there over here. In the type C, there is an injury to the aberrant hepatic duct, so the bile leak is from the right aberrant hepatic duct. In D, there is a partial injury to the common hepatic duct, so the bile leak is from the common hepatic duct. Then we have E1, where there is a common hepatic duct injury more than 2 centimeters from the confluence. In the E2, there is a common hepatic duct injury less than 2 centimeters from the confluence. E3 is injury to the confluence, but the continuity is kind of maintained. In the E4, the continuity is lost. And the E5, there is a complete injury to the common hepatic duct with the aberrant right hepatic. Okay, so this is what is a Bismuth-Strasberg classification. Okay, what is a partial? Incomplete transaction of the, okay. So partial basically means, so let's say if at all this is the common hepatic duct. Okay, let's say this is the common hepatic duct. If at all less than half of the circumference of the common hepatic duct is involved, that is what is a partial injury. Okay, anything more than the half is considered as kind of complete transaction. You understand my point? So just for the sake of simplicity, what you need to understand, around less than half is kind of partial, more than half is kind of complete. Okay, understood? But yes, got it? Right? Okay, guys. So this is what the Bismuth-Strasberg classification of the bile duct injury. So we have diagnosed it. Great, bravo. But how are you going to treat it? If at all there is a Bismuth-less particular injury, how are you going to treat it? So the treatment basically revolves around what is the kind of injury. Okay. Now, what you need to understand is that, let's say this is water. I'm drinking water. So this particular water is going to flow wherever there is a least resistance. Okay. Now, please try to understand, because this is a very, very important concept which you will understand at this point. Okay. So, what you need to understand is what we have. We have this. Okay, we have this particular. Okay, let's kind of keep that. Okay. So what you need to understand is that there is a bile duct injury with the cystic duct stump. So that was the question. That's what the question was asking you, right? Now what is there? This particular bile duct is entering into the intestine, right? It's entering into the intestine. Now at the intestine, obviously it is joining with the pancreatic duct. It is joining with the pancreatic duct, then both of them are kind of entering into the intestine, right? And over here, what is there? There's an ampulla. Okay, there's an ampulla. So whenever there is an ampulla and all those particular stuff, what you need to understand, don't you think there's going to be the pressure which is going to be there over here? There's going to be the pressure, right? There is a pressure. So the resistance is going to be there for the bile which is coming from the liver. This ampulla is providing some amount of the ampulla is providing some amount of what you call as the resistance, right? But what you need to understand, the resistance over here from the cystic duct is very less. I mean, it's practically zero. So what you need to understand is that the bile will not prefer to flow from the ampulla. It will prefer to flow from this particular cystic duct only. Okay, so the bile will prefer to flow from the cystic duct only. So what is going to happen in this particular scenario? If at all you go in, and if at all you perform an ERCP with sphincterotomy, okay, if at all you perform this ERCP with sphincterotomy, what is going to happen? This the sphincter will become weak. Sphincterotomy means you're cutting the sphincter, right? So the sphincter is going to become weak, and once the sphincter becomes weak, what is going to happen? The resistance to the bile flow will get reduced. The resistance to the bile flow will get reduced, and if at all the resistance to the bile flow gets reduced, what is going to happen? The bile is going to flow preferentially from this particular pathway. So this will get some rest, and probably this might get healed. You understand my point? So in your books, you would have seen that how do you manage a injury to the cystic duct stump? By ERCP. Now you will sit there scratching your head, how the hell will ERCP with sphincterotomy will help in curing the bile duct leak from the cystic duct stump? The reason is because now the bile is basically flowing what you call as in front, like that is flowing preferentially from this what you call as the ampulla, right? So the cystic duct stump will get slight kind of a reduced flow of the bile, and this is going to help in the healing of that particular cystic duct stump. Okay, so for all practical purposes, what you need to understand, if at all there is a minor bile leak, okay, if at all there is a minor bile leak, this is managed what you call by ERCP with sphincterotomy. Okay, but if at all there is a major bile leak, how are you going to manage this? If at all there is a major bile leak, this is going to get managed by what? By hepatico jejunotomy. So here you will need a surgery. You understand my point? So here you are going to need a hepatico jejunotomy or a surgery. Please understand this particular point. Now coming to the question. Okay, I'll just come back to the question, and I hope now you will be able to answer this particular thing. Okay, so what did I tell you? Following an uncomplicated laparoscopic cholecystectomy, the patient was found to have a bile leak. That's great. Okay, it happened. Now ERCP also was done, which showed that there was a leakage which was noted from the cystic duct. It means it makes a like the Bismuth-Strasberg classification. Now what they're trying to ask you, how are you going to manage this? So undertake a sphincterotomy and place a stent in the common bile duct. So what is this going to do? It is going to preferentially kind of release the resistance to the flow of the bile into the intestine. So the bile will go more from the intestine. The cystic duct stump will get a bit of rest. Probably this will get healed. Are you understanding my point? So this is how you manage the patients of laparoscopic, like type A Bismuth-Strasberg injury. Okay. Now all of you, many of you guys, this is the most common wrong answer which we get, right? So if at all, what you call as, if at all, like most of people tell me that, you know what, put a T-tube. Why do they say T-tube? Because I think that they don't understand what is a T-tube and how do you kind of use it and all those particular stuff. Okay, so what you need to understand about this. Okay, so what is this particular T-tube, right? So this is what is a T-tube. Okay, what is a T-tube? T-tube is a kind of a thing which has like three sides, right? So these are the two sides. These are the two smaller sides which are basically present. Like one basically goes towards the liver, one goes basically towards the common bile duct near the intestine. Now you understand my point of view. So this particular T-tube is there. One goes towards the liver, one goes towards this particular common bile duct, and there is a longer path. Okay, there is a longer path which is basically coming out of the body as a drain. But when are you going to place it? Okay, so I'll explain it to you when are you going to place it. Okay, this is what is a T-tube. So this longer path is going to come out of the body as a drain. This is going to go, let's say, towards the liver, and this is going to go towards the intestine. But how and when are you going to place it? So you understand that you might have a kind of a stone in the common bile duct. Okay, what is it called as? Choledocholithotomy, right? So it is like a choledocholithiasis. Okay, I understand my point. So let's say there is a CBD stone. There is a CBD stone. What is that CBD stone called as? It's called as a choledocholithiasis. Okay, choledocholithiasis. So if at all there is a CBD stone, what is the management? If at all you have diagnosed this preoperatively, okay, let's say if at all I get a pain, I get obstructive jaundice, I go to the doctor basically diagnosed me as a, what do you call, as a CBD stone, okay, choledocholithiasis. How are you going to manage this particular stuff? By ERCP. Yeah, I hope you understand this. Okay, you do an ERCP, endoscopic cholangio, retrograde cholangiopantorography, and you get rid of that particular stone. But if at all this particular thing is diagnosed intraoperatively, what do you understand by the intraoperatively? So let's say the patient was posted for a cholecystectomy, and during the cholecystectomy you found that there is a like the CBD stone is also present. Now what you're going to do? You are going to explore. Okay, you are going to explore the CBD. Okay, why you want to going to explore the CBD? Because you want to get rid of all these particular stones, right? So you're going to cut the CBD and you're going to explore the CBD and you will try to bring these particular stones out. You'll do that, right? But after you have done that, well, now you have to close the CBD also. You have to take the sutures on the CBD. When you are closing the CBD, okay, so you are going to explore the CBD, that's fine. But when you're going to repair it, okay, so you repair with T-tube. With T-tube means above the T-tube. Not likely. You're not going to take the sutures with the T-tube. You're going to place the T-tube inside and then you're going to repair the common bile duct over it. Okay, why? What is the reason for that? Okay, why? What is the reason for that? The reason for that is it is going to prevent the stricture formation. And there's another reason as well. There are two reasons for the T-tube. I will explain you that, but I hope you have understood when are you going to use a T-tube. So please, this is one of the most common wrong answers which I get. What you need to understand, this is the use of a T-tube. Everybody understood this particular point? So this is a T-tube. I got it. Just try to understand. Okay, so I hope you, now I'll explain you again. So what is a T-tube? It is a plastic silicone tube, whatever, and it is what you need to understand. These are two small things. One basically goes towards the liver, one goes basically towards the intestine, and the longer part is basically coming out of the body as a drain. Okay, so that is how you kind of place a T-tube. So yeah, this is what you need to understand. Okay, so simplified way mein, what you need to understand, this is obviously a liver, and what is that? There is the intestine. You're placing a T-tube like this. This is coming out as a drain. Okay, so this is after you have explored the common bile duct. Yeah, understood? Now, what is the purpose of this? I told you that. First is that you want to prevent the stricture formation. What is the another thing? We all are humans, right? So we all can screw up. If at all, let's say the surgeon left behind some stones inside the common bile duct. So we have to kind of diagnose that. So what we perform is we perform this. What is this? This is what is called as a, what you're seeing over here. This is what is a T-tube cholangiography. Okay, so we perform this particular T-tube cholangiography on day 7 or 8. Okay, after the surgery, after you have done the CBD exploration, on post-op day 7th or 8th, you perform this T-tube cholangiography. Okay, why do you want to perform this particular T-tube cholangiography? Because you want to see something. What do you want to see? You want to see whether there is any stone which is retained or not. Okay, so if at all, let's say you have left behind one stone. So now what is going to happen when you do this T-tube cholangiography, that particular stone will be detected or diagnosed, right? If at all there is a retained stone. Okay, so first let's talk about if at all there is no stone at all. You did a T-tube cholangiography and the surgeon had done a great job. Like they had removed all the stone. There's no stone detected inside it. Now what you're going to do? You're going to remove the T-tube on day 9th or 10th. On day 9th or 10th, you remove this particular T-tube. Are you understanding? So this is what you perform in the T-tube cholangiography. Remove the T-tube on day 9th or 10th. Okay, but if at all there is some retained stone. Okay, so you did a T-tube cholangiography and there was some retained stone inside these particular ducts. Now what you do? You will not remove the T-tube now, because if you remove the T-tube now, the tract is going to collapse. What you do? You keep the T-tube there itself. You keep the T-tube there for around 4 to 6 weeks, and after that you remove this particular T-tube. Okay, after you remove this particular T-tube, now the tract has matured. Okay, so now the tract has matured, so now you can remove the stone via the choledocoscopy. Okay, so by the choledocoscopy you can remove this particular stone. Okay, so this is what is the T-tube cholangiography. I've seen many students struggle with this T-tube cholangiography, so I hope you have understood this as. Okay, so this is about the T-tube, and we talked about the CBD injury also in detail. This is again one of the very, very important topics and one of the very dreadful topics for many of the students. So I hope you have understood this particular. Okay, got it? Now let's move on to the next question. So what is the next question which we have? Let's see. Yeah. So there's a 60-year-old female which presents with the history of a recurrent abdominal pain. Okay, so the 60-year-old female had a recurrent abdominal pain. Imaging showed that there's a multiple small cystic lesions like bunch of grapes in the head of the pancreas with grossly dilated main pancreatic duct. On ERCP, we say like we saw this particular finding which you're basically seeing over here. What is the diagnosis? Okay, so can you please help me guys? What is the diagnosis over here? Okay, so what is the diagnosis over here? Is it like the serous cystic neoplasia, mucinous cystic neoplasia, IPMN, or pancreatic pseudocyst? Okay, what is the diagnosis over here? Can you please help me with this? Yeah, so what is the diagnosis over here? Okay, so can you please help me guys? What is the diagnosis over here? Okay. Okay, Chaitanya, I'll get back to you. Let me just give the answer. And before explaining this particular topic, I'll go back and I'll talk to you about the management. Don't worry, just give me a minute. But can you please answer this particular question first? So is it like a serous cystic neoplasia? Okay, I'll just enlarge the image. So this is the kind of an image which you basically saw when you perform an ERCP. What is the diagnosis over here? Is it like a serous cystic neoplasia, mucinous cystic neoplasia, IPMN? What exactly? Okay, so you guys are not telling me, so I'll only tell you the answer is IPMN, intraductal papillary mucinous neoplasia. Okay, so that is what is the answer. Okay, so Chaitanya has requested something. So Chaitanya is asking me that, you know what, sir, can you please tell us the management of the other types of the CBD injury as well? So what did I tell you? That for the type A, when there is a like a bile leak from the cystic duct, what we do is we perform a ERCP with sphincterotomy. Okay, so Chaitanya, first thing what you need to understand is it is not like that every patient with the cystic duct stump leak is going to heal with the ERCP with sphincterotomy. No, not really. So I hope you understood that I told you one statement that minor bile duct leaks are managed by ERCP with sphincterotomy. Are you understanding my point? Now what you need to understand over here, that if at all there is a bile duct leak from the cystic duct stump, and if at all you perform bile leak from the cystic duct stump, if you perform a ERCP with sphincterotomy, there's a high chance that it's going to heal. But if it doesn't heal, it's not like that you're going to, I will not do anything. No, not really, right? You will perform a surgery. You will perform a hepatico-jejunostomy. You'll cut that particular stump or the hepatic duct or something, and you will bring a jejunum and you are going to attach it to the jejunum. Am I making some sense to you guys? So I'll elaborate right now. I'll tell you one by one what is the answer. But what you need to understand is, if at all there is a major bile duct leak, for example, there is, for E though, definitely doesn't make any sense, like there's no point of ERCP sphincterotomy. All these reconstruction, all the thing will be whatever the remaining hepatic duct is there, you bring an intestine and you attach it to the hepatic duct. That is what is a hepatico-jejunostomy. That's what you need to understand. In this also, let's say type D, there's a partial injury to the hepatic duct. The likeliness of this to heal with ERCP sphincterotomy is practically zero. So here you will not try that. You will not do this particular heroic attempt. Here what you will do, you will go ahead with the you may try that, but it's not going to help at all. So you will go ahead with the hepatico-jejunostomy. Right now, injury to the aberrant hepatic duct, here also you can try the ERCP sphincterotomy. That is might help. What about the type B? There's no leak only, so there's no point of ERCP sphincterotomy. In these patients, usually the patients are going to come to you with the pain, not immediately. Let's say after 5 days, 8 days, 10 days or something. Over a period of time, it will subside. If it doesn't subside, the patients may develop some hepatic abscess or something. In that particular scenario, you'll have to put in a drain. That's it. That is a management. But in type A, by luck, you can do a ERCP sphincterotomy. So to answer your question, A, ERCP sphincterotomy, you try it. If not, then surgery. B, conservative management. C, you again do an ERCP sphincterotomy. If it helps, that's great. Otherwise, surgery. In type D, usually the surgery is the option, hepatico-jejunostomy, and in ERCP sphincterotomy is not an option. Always go ahead with the surgery. Okay, I hope you have understood this particular stuff. Yep. Right. CBD stones after cholecystectomy management. It is ERCP only. Okay, CBD stones after cholecystectomy. So what KK is asking, that if at all there is a CBD stone which is occurring after cholecystectomy, after you have done the cholecystectomy, it is going to be ERCP only. So what was the management of a CBD stone? It doesn't have any role to play in the gallbladder, right? From the gallbladder, the stone came. That's a different story. But if it also is a CBD stone, the management is ERCP if you have diagnosed this pre-operative. Okay? Or after the cholecystectomy, also it is going to be ERCP only, obviously. Intraoperatively, you will do an CBD exploration. And if at all, let's say ERCP is not able to kind of remove the stone, then you might consider a CBD exploration, obviously. But you will first try with the ERCP only. Okay? I hope you have understood. Okay? Right. Now, let's move on to the next question. So, guys, none of you answered. What was the answer over here? It is an IPMN, intraductal papillary mucinous neoplasia. So, what is this? Okay, so what this particular question is focusing on the cystic lesions of the pancreas. Okay, so let me just quickly go to the cystic lesions of the pancreas. These are the cystic lesions of the pancreas. What I'll do, I'll just quickly tell you about the features of these. Okay, so we have the serous cystic neoplasia, mucinous cystic neoplasia, IPMN. So what you need to understand is the serous cystic neoplasia are supposed to be benign. Okay, they are the benign ones. The mucinous ones are the ones which are malignant ones. Okay, malignant ones. Now this is a table which you should know, which you should understand as well, because that is what is going to help you in answering the questions about the like the cystic disease of pancreas. So first of all, let's get familiar with the terminology. What is SCN? Serous cystic neoplasia. What is MCN? Mucinous cystic neoplasia. What is IPMN? Intraductal papillary mucinous neoplasia. You understand my point? So these are the terminologies which you should get first familiarized with. Now, let's talk about the SCN. In the SCN, what you need to understand is that it is more common in the females as compared to that of the males. That's one thing. Okay, it is more common in the females as compared to that of the males. It is the ratio of 4:1. What about the MCN? It is again more common in the females as compared to the males, but here the ratio is much more. It is 10:2. The mucinous cystic neoplasia, it is much more common in the females as compared to that of the males. What about the IPMN? It is equal, like male and females are the equal kind of equal occurrence. Okay. Now, what about this? Age group is more or less similar, 60 to 70 years. It's more or less similar, like 50, 60, 70. That's kind of fine. Now, what about the distribution? Like in the pancreas, what do we have? We have the head of the pancreas, we have the body of the pancreas, we have the tail of the pancreas. Where exactly are these cystic lesions predominantly present? What you need to understand, the serous cystic neoplasia are evenly distributed in the head, body, and the tail. So head equal to body equal to tail. Okay, that is what is the distribution of the serous cystic neoplasia. What about the mucinous cystic neoplasia? They are predominantly present in the body and the tail of the pancreas. So this is predominantly present in the body and the tail, and the IPMN, this is predominantly present in the head of the pancreas. I understand my point. So till now what we talked about, serous cystic neoplasia, mucinous, and IPMN, talked about the age, right? So the gender. So serous cystic neoplasia much more common in the females as compared to the males, 4:1 ratio. Mucinous cystic neoplasia, 10:1 ratio. IPMN, male female equal. Okay, then we talked about the distribution, head, body, tail, equal distribution. In the mucinous cystic neoplasia, body and the tail more common. In the IPMN, head more common. Okay, that's fine. Then what we have, the things over here. So what you need to understand is there's something which is called as a star burst classification. Star burst classification is basically seen in serous cystic neoplasia. Please understand this point. Star burst classification is seen where? It is seen in the serous cystic neoplasia. Then we have something which is called as an eggshell calcification. Eggshell calcification is basically seen in your mucinous cystic neoplasia. Okay, these all things have been asked to you guys. So please do remember serous cystic neoplasia and the starburst classification and the eggshell calcification. I hope you have understood this point. Okay, right. Now, last thing what you need to understand is communication with the bile duct. Okay, so we have a cyst and not the bile duct, with the pancreatic duct. So whether that particular cyst is communicating with the pancreatic duct or not. So please try to understand, in the serous cystic neoplasia, there is no communication with the pancreatic. In the mucinous cystic neoplasia, it is very rare, or rather it is no. So there is no communication with the pancreatic duct. On the IPMN, what you need to understand, there is the communication with the pancreatic duct. So these things you have to kind of remember. Okay, so if you want, you can repeat after me. What is the thing? Serous cystic neoplasia, mucinous cystic neoplasia, IPMN. Serous cystic neoplasia, females more common than the males. The ratio is 4:1. Mucinous cystic neoplasia, females more common than the males. Kind of ratio is 10:1. And in the IPMN, the what you call as the males and females are equally kind of present. That's fine. Now, distribution: serous cystic neoplasia, head, body, tail equally distributed. Mucinous cystic neoplasia more common in the body and the tail, and IPMN it is more common in the head. Okay, we talked about that. Then we talked about the starburst classification. and then we called about the axial calcification. Then we said about the communication. So serous cystic neoplasia, mucinous cystic neoplasia not communicated with the pancreatic duct. IPMN is communicating with it. Okay, so this information you have to remember, there is no way around it. Now, what you need to understand is that in real life, what we come across a patient, right? We come across a patient, and the patient is having some pancreatic cyst. Okay, patient is having a pancreatic cyst. Now the patient is asking you, sir, what kind of cystic lesion do I have? How will you tell me? So how will we tell? We read so much about the different kind of pancreatic cystic lesions, right? So what we can perform is we can perform an endoscopy. We can under the endoscopic ultrasound guidance, what we can do, we can aspirate the fluid, and we can send this particular fluid for analysis. Yes or no? We can send this particular fluid for the analysis. This is what we can do. Okay. Based on whatever the analysis report comes back, we can tell that, you know what kind of a cystic lesion the patient is having. Okay, so just to summarize, what you need to understand, what are the findings? Very, very important. This is what they will ask you. Okay, so we look for three things. What are the three things we look for? We look for mucin, we look for amylase, and we look for CEA. Okay, and what do we have over here? SCN. What is it called as? Serous cystic neoplasia. Then we have a MCN, which is called as the mucinous cystic neoplasia, and then we have IPMN, which is intraductal papillary mucinous neoplasia. So in the serous cystic neoplasia, what is going to happen in the mucin? Logic serous, na? The serous में mucin will be negative. So mucin staining will be negative over here. What about the mucinous cystic neoplasia? Logic, it is going to be present in the IPMN, intraductal papillary mucinous neoplasia. So again, it is going to be present. What about the amylase? So just try to understand. I told you about the communication with the pancreatic duct. If at all the cyst is communicating with the pancreatic duct, it means that the amylase level will be high. So in the serous cystic neoplasia, is the communication present? No. In the mucinous cystic neoplasia, is the communication present? Very rare. I told you, remember it as no. IPMN, what you need to understand, there is a communication present. So in the amylase, what is going to happen? In the serous cystic neoplasia, it is going to be low. In the mucinous cystic neoplasia, it is going to be low. In the IPMN, it is going to be high. What about the CEA levels? So the CEA levels, what you need to understand, in the serous cystic neoplasia is going to be low, because as I told you, serous cystic neoplasia is considered to be benign, and CEA level elevation is present in the malignant lesion. So mucinous cystic neoplasia, it is going to be high, and it is again going to be high in the IPM. You understand my point? If at all somebody asks you that, you know what, I have a cystic lesion in the pancreas which is positively staining on the mucin, it has amylase which is high, and it has CEA which is high. What I'm doing, dealing with? I'm dealing with IPMN, intraductal papillary mucinous neoplasia. I hope you have understood this particular point. It's a very, 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 very important topic. Cystic neoplasia of the pancreas. Okay? Yes or no, guys? I hope you have understood. Right? Now, this is a so please go through this particular table. Very, very important. I hope you have understood. So what I did was I just drew the last part of this particular table. This last part of the table, this is just what I drew on the opposite slide. So this is how the questions are going to be asked you. Just go through this. This is important. Okay. Now, as I told you that the serous cystic neoplasia are benign. So they are usually going to be managed conservatively. This IPMN and MCN, they are kind of malignant. So these are the indications of surgery in here. You can go through that. Okay. So please try to understand over here. These are going to be malignant. They are going to be operated. Serous cystic neoplasia, benign, just observation. Okay. Got it? And this is what is a fish mouth appearance. Okay. Please try to understand. I'll just write down IPMN. So what is this? Intraductal papillary mucinous neoplasia. Okay, so what you need to understand over here, that intraductal means the main pancreatic duct. So whatever the mucin is being produced, that is directly secreted into the main pancreatic duct. So mucin is secreted into the main pancreatic duct. So what you need to understand, when you cannulate it, so all this particular mucin is coming out. So what is this? This is all the mucus which is basically coming out, and this appears like a fish mouth appearance. This particular appearance is characteristically called as a fish mouth appearance. Okay, what is this? This is a fish mouth appearance. You understand my point? So this is a fish mouth appearance which you get in the patients with an IPMN. intraductal papillary mucinous neoplasia. Am I making some sense to you guys? I hope I am, right? Yeah, so very, very important image as well. Okay, right. Now let's talk about this. So we all know that for the INI, trauma is kind of important. So let's talk about the two very, very important case scenarios for the trauma. So we covered this. Okay, this is very coarse also. What else is remaining? Right. Okay, then okay. So let's talk about these particular questions, guys. So let's kind of focus on this particular question first. Okay, so there's a 38-year-old obese woman who is attacked by the thief with a 4-inch long Swiss blade. Okay, so basically, knife ke saath somebody has kind of attacked this particular woman. In addition to the severe, what is superficial laceration, she was stabbed in the abdomen as well. So basically, in other words, it's simple. You can just read through the question. There's a woman who has been stabbed into the abdomen. That's nothing major about it. She is hemodynamically stable. Okay, that's great. And does not have any signs of peritoneal irritation. That's also fine. That's good actually. What should be the next step in the management of this particular patient? What do you need to understand over here? Okay, okay. So like the first CT scan, exploratory laparotomy, local wound exploration. And I'll tell you one more thing. Okay, so yeah, the E option is discharge the patient. Okay, so can you please help me? What is the answer over here? So here, I'll just summarize the question. So there's a female who was stabbed into the anterior abdomen. Patient is hemodynamically stable. There are no signs of peritoneal irritation, everything. So what is going to be the management of this particular patient? Yep, I'm waiting for your answers. Can you please help me with this? What is the answer over here? Yep, what is the answer over here, guys? The local wound exploration. KK is saying local wound exploration. Yes. KK, your rock. Yes, the answer over here is a local wound exploration. That's great. Let's talk about this. Okay. Right. So very, very good. Okay. Okay. Now let's talk about this. Okay. What you need to understand, this is a what you call the management protocol of a penetrating abdominal trauma. What I'll do, I'll draw it. That will be better for you. Okay. So I'll draw it for you guys. Okay. So what you need to understand, whenever you have a patient who is coming to you after a penetrating abdominal trauma. Okay, so patient is coming to you after penetrating abdominal trauma. What is the first thing which you're going to do over here? The first thing which you're going to do over here is you're going to see whether the patient is hemodynamically stable or unstable. Okay, if at all the patient is hemodynamically stable. Okay, if at all the patient is hemodynamically unstable. If at all the patient is hemodynamically unstable, what are you going to do? You don't need any other investigation. Straight away take the patients for an exploratory laparoscopy. What you want to do? You want to take the patients for an exploratory laparoscopy. You understand my point? So straight away take the patients for an exploratory laparoscopy. Making some sense to you guys here? So here you directly take the patients for an exploratory laparoscopy. Okay. Now, if at all there is a patient who is hemodynamically stable, there can be two conditions, right? Either the patient has been suffering from GSW. What do you understand? What do you understand by the GSW? Gunshot wound, or the patient is basically suffering from your stab wound. Suffering from a stab wound. These are the two conditions which you can have. Okay, I hope you are able to understand this point. So patients may have either a gunshot wound or a stab wound. If at all there is a patient who is having gunshot wound, okay, patient is having a gunshot wound, what you need to understand is that if at all this particular gunshot wound is on the anterior abdomen, if at all it's on the anterior abdomen, then what you're going to do? If at all there is any gunshot wound in the anterior abdomen, what are you going to do? In the anterior abdomen, if there is a gunshot wound, you are going to straight away take the patients for an exploratory laparoscopy. Okay, so you're going to take the patients for an exploratory, no other investigation. But if at all this gunshot wound is basically to the back or the flank, in that particular scenario, what you're going to do, you are going to perform a contrast enhanced CT scan. Contrast enhanced CT scan, and if at all it is positive, then you are going to take the patients for it. Okay, right? So I'll get back to you, KK. Just give me a minute, right? Okay, so yeah, I hope you understood. Gunshot wound, back or the kind of flank. It is flank, right? It's flank. Any other part of the body rather, you do a CT, and based on the findings of your CT scan, then you decide whether you have to go ahead with the exploratory laparoscopy or not, like that. Now talking about the stab wound. The stab wound can also happen either in the, let's say, anterior. Okay, so let's talk about the back and the flank first. Okay, so here there is a back or the flank. Okay, so if at all there is a gunshot, like there's a stab wound to the back or the flank, again the same thing. You're going to perform a CECT, and if at all it is positive, then you can perform a exploratory laparoscopy. Understood, right? Nothing major about this. Okay. Now in the stab wound, what else you need to understand is that if at all, the question is saying bile staining of cloth or evisceration. What do you understand by the bile staining of the cloth or evisceration? It means that clothes are bile staining, or let's say the intestine or something is coming out of the abdomen or something like that. In that particular scenario, you do not need any other investigation. You do not need any other investigation. You straight away take the patient for an exploratory laparotomy. Okay, so these three things you need to remember for sure. Okay, so it's got behind my head. Okay, so I'll kind of do that. Okay, so what you need to understand is that three things. If at all the patient is hemodynamically unstable, or the patient is having a gunshot wound on the anterior abdomen, or there is a stab wound on the anterior abdomen, which has led to either the bile staining of the cloth, or there is an evisceration, some intestine is coming out, or some intra-abdominal structure is kind of coming out. That particular scenario, you have to perform an exploratory laparotomy. Are you understanding my point? Everybody understood this point? Now, coming to the question which was asked to you, okay, and the others are back in the flank, you have to perform a CCT based, if at all that is positive, then you go ahead with the exploratory laparotomy. So coming to the question which I had asked you, what question? That if at all there is a stab wound on the anterior abdomen. Okay, now what you're going to do? Okay, so for this, what you need to understand, I'll draw something else. Okay, so I'll draw something and then we'll come back to this. Let's say if at all there are two friends. Okay, let's say there are two friends. Okay, and both of them have gone to the, let's say, market to buy something. Okay, so they have gone to the market to buy something. Okay, this is the friend one, and what I've drawn is the black colored stuff which I've drawn. This is what is the, what we call as a peritoneum. Okay, so the black colored thing is a peritoneum, and the blue colored thing is your skin, right? It is a skin. So as you can see, the friend one is a bit obese. What about the friend two? The friend two is basically lean and thin. Okay, so the friend two is basically very lean and thin. Okay, so here what you need to understand is that seat. Okay, so the friend two is, oh, what did I do? Just give me a minute. Just give me a minute. Okay, so you'll understand it. Okay, so please try to understand. Just give me a minute. So here the friend two is very lean, and that's fine. So as you can see over here, peritoneum is not away from the surface of the skin. Okay, everybody understood this point? So these are the two people who have gone to the market. So this is person one, this is person two. Now that particular thief who had come, he basically stabbed both of them. Okay, he stabbed both of them with the same knife. With the same knife, both of these particular people were stabbed. Are you able to appreciate it? So both of these particular people were stabbed, and both of these particular people were brought to you in the emergency. You have had a good attention towards where's the knife going. Okay, so both of them were brought to the emergency room. Now if I ask you guys that what do you suspect? Okay, what do you want to know in order to make some understanding about what is going on with this? Okay, so what do you want to know? You want to know whether the peritoneum has been breached or not, because see, it's a logical thing. Only if at all the peritoneum has been breached, only after that, whatever the knife or anything, it would have caused some intra-abdominal injury. If at all, if that knife is not breaching the peritoneum, it wouldn't have caused any intra-abdominal injury, right? So what we want to know, we want to know what we basically do is we perform a local wound exploration. And whatever the local wound exploration we perform, what is the aim of performing this? Aim of performing this is that we want to know whether the peritoneum is breached or not. Are you understanding my point? So you basically perform a local wound exploration. Why? to see whether the peritoneum has been breached or not. Am I making some sense to you guys? Right? Yes or no, guys? Yeah. Because if at all the peritoneum has been breached, only if at all the peritoneum has been breached, only then the intra-abdominal organs could have got injured. You understand my point? So, what is going to happen in the patient A? In the patient A, the local wound explanation is going to be negative. It means that the peritoneum has not been breached. In the patient B, what is going to happen? It is going to be positive. It means that the peritoneum has been breached. So if at all the peritoneum has not been breached, can I safely take the sutures? Take the sutures, and can I safely discharge this particular patient? Yeah. Can I safely take the sutures and discharge this particular patient? Yes, I can do that. But if at all the peritoneum has been breached, now I'm not sure whether the intra-abdominal organs have been injured or not. I'm not sure about that. Okay. So what I'll have to do over here, I will have to, what do you call as, so I'm not sure, right? So I will have to admit the patient. I'll have to observe the patient. And if at all the patient deteriorates, then I will go ahead and do the surgery in these. Yes or no, guys? Yes, obviously, right? I hope you have understood this particular point. So I'll just quickly summarize this. Okay, so let me just complete over here. So in the anterior abdomen, what I'm going to do? I'm going to do a local wound exploration. Okay, so I hope that you have understood what is the purpose of doing a local wound exploration, to see whether the peritoneum has been breached or not. If at all it is positive, it means that the peritoneum has been breached. That in this particular scenario, what I'm going to do, I'm not going to directly take the patient for the surgery. No, I'm going to observe the patient, and I'll do the CT scan, I'll do the monitor the vitals, I'll do all those particular stuff. If at all the patient deteriorates, then we have to kind of do a surgery. Then we have to kind of explore the abdomen of this. Yes or no, guys? This is a management protocol for your penetrating abdominal trauma. Okay, so I'll just again summarize it. It's a very, very important stuff. What is the first thing which you have to look? Please repeat after me. It will help you, right? So what is the first thing which you have to do? You have to see whether the patient is hemodynamically stable or not. So what we saw, that the patient is hemodynamically unstable or stable. All the patient is hemodynamically unstable, we did no other investigation. We straight away took the patient for an exploratory laparotomy. That's a great thing. But if at all the patient is hemodynamically stable, then what we saw that, what are we dealing with a gunshot wound, or are we dealing with a stab wound? If at all we are dealing with a gunshot wound, then what we did, we looked at if at all the gunshot wound is to the anterior abdomen, we don't need any other investigation. We straight away take the patient for an exploratory laparotomy. But if at all there is a gunshot wound to the back or the flank, then we perform the CT scan. If at all it is positive, then we consider that if at all we feel like, then we go ahead with the exploratory laparotomy. In the stab wound, and in the stable wound, if at all it was a stab wound, if at all it is again the back and flank, again the same thing, CCT positive, then exploration. But if at all there is a bile staining of the cloth or evisceration, let's say intestine is out or something like that, we definitely suspect something is wrong inside. We at least have to check it. So we have to go perform an exploratory laparotomy. Finally, stab injury to the anterior abdomen, what we perform is a local wound exploration, because what we want to know is whether the peritoneum has been breached or not. If at all the peritoneum has been breached, then we admit the patient, we observe, and if at all the patient deteriorates, we can go ahead and do the surgery. Okay, so I hope you have understood this about, this is what is a very, very important management protocol of your penetrating abdominal trauma. This is the management protocol of your penetrating abdomen. Okay, now gunshot wound and the blast trauma, both are same? No, not really. Gunshot wound and the blast injury are not the same. Gunshot wound is a gunshot wound. The gun blast is like a bomb blast. Okay, so that's completely a different entity. Okay, I hope you understood, Kate. Right? Yes. Now let me just cover this particular scenario, which is absolutely, absolutely important for all of you guys. So please pay attention whether you are kind of preparing for whatever exam. This is absolutely, absolutely important. Very, very important. Okay, so a man is brought to the emergency after he fell from a man into a manhole and injured the perineum. Okay, that's fine. He feels the urge to pass the micturition, but he's unable to pass the urine, and there is blood at the tip of the meatus with an extensive swelling in the penis and the scrotum. What is the location of the injury? Okay, so can you please help me, guys? What is the diagnosis over here? Okay, yeah. Bulbourethra, prostatic urethra, bladder, or the membranous urethra? What are you dealing with? A. Bulbourethra. Okay. Chetan is saying bulbourethra. Anybody else, guys? So all of you feel that it's a urethral injury. Nobody feels that it's a bladder injury. Okay. So guys, the answer over here is definitely A. Absolutely right, Chaitanya. Okay. So what are we dealing with? We are basically dealing with a urethral injury. And what type of urethral injury is a bulbar urethral injury? So that's great. Let's kind of understand, let's kind of decode the urological trauma in a good detail. Okay, so let's talk about this. So this is what is first of all the manhole injury, but that's fine. That's irrelevant at this point of time. So guys, whenever you have a patient with a road traffic accident and you want to distinguish whether are we dealing with a bladder injury or are we dealing with a urethral injury, what is the first thing which you're going to see? So in the clinical scenario, you see whether the patient has passed the urine or not and whether the patient is having the urge to pass the urine or not. You understand my point? If the question is trying to tell you in the grounds of that, you know what, the patient has not passed urine for long time. For long time, the patient has not passed urine. What is a long time? 12 hours, 18 hours, 16 hours, 24 hours, something like that. And there is no urge to pass the urine. If at all the question says something like that, what are we dealing with? We are dealing with a bladder rupture. What are we dealing with? We are dealing with a bladder rupture. We will talk about the other stuff. Okay, we will talk about the extraperitoneal, intraperitoneal, all those particular stuff. But this is broadly we are dealing with a bladder rupture. Okay, but if the question says in the grounds of that the patient has urge to pass urine, but patient is unable to pass the urine. Okay, so patient has urge to pass the urine, but the patient is unable to pass the urine. If at all the question says something like that, then what is the answer? Like then we are dealing with the urethral injury. I'm making some sense to you guys. So this is the first and foremost thing which you need to understand, because many times I asked question to these many students and many people are not able to distinguish even the urethral injury from the bladder injury. You understand my point? So how do you kind of distinguish between them? If at all the patient is having the urge to pass urine, the patient is not able to pass urine, we are dealing with a urethral injury. If at all the patient is not having the urge to pass urine and patient has not passed urine for quite a lot of time, we are dealing with a bladder rupture. Okay, so please understand this particular point, right? Now, let's talk about the urethral injury. So I give you a scenario. I give you a scenario that there's a patient came to you after the road traffic accident. I told you that there is a intense desire to pass the urine, but patient is not able to pass the urine. If at all I tell you like this, okay, so there's an intense desire to pass urine, but the patient is not able to pass urine. What are you dealing with? You are dealing with a urethral injury, right? That's fine. You think that you are kind of dealing with a urethral injury. And along with that, what I tell you, that on the abdominal palpation, the bladder is palpable. Okay, so I want you guys to answer what is the next step in the management of this particular patient. Can you please help me? What is the next step in the management of this particular patient? Are you going to catheterize this patient? Are you going to place a suprapubic catheter in this particular patient? Are you going to do something else? So can you please help me, guys? What are you going to do in these particular? Okay, so if at all there is a patient who is having a road traffic accident, the patient is having an intense desire to pass urine, but the patient is not able to pass urine. And on abdominal palpation, what you need to understand is that there is a palpable bladder. The abdominal palpation, what is there? There is a palpable bladder. So what are you going to do next in this particular patient? Can you please help me with? What are you going to do in this particular? Okay, so the next step in the management of this particular patient is not the suprapubic catheter, because that is the most commonly answered wrong answer. Okay, it is not the suprapubic catheter. What you're going to do is retrograde urethrogram. Very good. RGU, retrograde urethrogram. Please understand it is retrograde urethrogram. Okay, so you perform this retrograde urethrogram. Yes, you perform this. Then after performing this urethrogram, what you will see whether there is any injury present or not. If at all the injury is present, then it's fine. You will place a suprapubic catheter. But if at all the injury means, if at all there is an dye which is basically coming out of the lumen of the urethra. So if at all the dye is coming out of the lumen of the urethra, then that basically means that the urethral injury is there. And if at all there is a urethral injury, you perform an SPC. If at all the urethral injury is not there, okay, if at all the urethral injury is absent, that particular scenario, what you basically do is, if at all the urethral injury is absent, then what to do? You place a Foley's catheter. Okay, so you place a Foley's here. You keep it there for let's say a couple of days, and then you can remove it. Okay, you understand my point? So very good. Okay, it is a RGU. That is what you're going to do. Chaitanya, KK, you both answered it correctly. That's great. Okay, now coming to the how do you distinguish between anterior urethral injury and the posterior urethral injury? Okay, so let's talk about the posterior urethral injury. Urethral injury. So posterior urethral injuries are the ones which are associated with what you call as your pelvic fracture. Okay, they will be associated with the pelvic fracture. Posterior urethral injuries are the ones which are associated with the pelvic fracture. Over here, what are you going to find? Superficial perineal hematoma or a deep perineal hematoma? I hope that you are answering that here what we are going to find is a deep perineal hematoma. Okay, why so? I will explain. So let's say there is a bladder. Okay, then what do you have? The prostatic urethra is there. Then we have a membranous urethra. Then we have a bulbar urethra, and we have a penile urethra. Right now, here what is there? There is a urogenital diaphragm. And here what is there? There is a prostate. Okay, so here there is a prostate as well. Surrounding the prostatic urethra, what do we have is a prostate as well. If at all there is a posterior urethral injury, what is going to happen? There is going to be injury over here. So urine is going to get excavated in this pouch. What is this pouch? So this is an area above the urogenital diaphragm. This is what is called as a deep perineal pouch or a deep perineal space. Yeah, you understand my point. In these patients, what we have is a deep perineal hematoma. I hope you have understood this particular. Okay, right? Now, there on the digital rectal examination, so sometimes they say that on the digital rectal examination, what you might find? You might find that there is an elevation of the prostate. In other words, the prostate is high, like prostate is like higher. That's fine. Or what you need to understand is prostate is not palpable. Okay, so either there is a high riding prostate or prostate is not palpable. What is this called as? This is what is called as a Vermuten sign. What is this called? This is called as a Vermuten sign. So what is Vermuten sign? The Vermuten sign, what you need to understand is in the Vermuten sign, what you need to understand in the Vermuten sign, there is high riding prostate or the prostate is not palpable. That is what is called as a Vermuten. I hope you are able to understand. Guys, okay? This is what is called as a Vermuten sign. Okay, right. Then what you need to understand over here. Okay, so if I say that there is a patient who is coming to after road traffic accident, there is a pelvic fracture, there is a deep perineal hematoma, and there is an elevation of the, like on the digital examination, there is a high riding prostate. So this is what I'm trying to talk to you about, the posterior urethral injury. Okay, these are the features of your posterior urethral injury. Okay, now what else? Okay, now let's talk about the anterior urethral injury. Anterior urethral injury. What about the anterior urethral injury, guys? What about the anterior urethral injury? What do you need to know about the anterior urethral injury? Anterior urethral injuries are the ones which are associated with the straddle fracture. Okay, so they are associated with the one straddle fracture. What do you understand by the straddle fracture? Straddle fracture basically means this. Okay, so this manhole type of an injury. I hope you are able to understand. The patient was walking, placed a kind of leg in this particular manhole. What happened? The manhole came and hit the patient in the crotch. This could have caused an injury to the urethra. What kind of an injury? Anterior urethral. Okay, or they might give you that there is a patient who was driving a bicycle with a kind of a rod over there, and then what happened? The patient slipped and the patient fell on that particular rod. So now the urethra is getting compressed between the rod and the pubic symphysis. These type of injuries are called as a straddle injury. These kind of injuries are called as a straddle injury. So here, anterior urethral injury, what you need to understand, they are associated with the straddle injury. That is first thing. Now, here what you're going to find. Here, are you going to find a superficial perineal hematoma or a deep perineal hematoma? So just go back to this particular image over here. If at all there is a injury in the anterior urethral injury, it is whatever the hematoma is going to be there, that is going to be superficial to the urogenital diaphragm. Obviously here there is going to be the hematoma in the superficial perineal pouch. There is going to be a superficial perineal hematoma, okay, which is also referred to as your butterfly. It is also called as a butterfly shaped hematoma. Okay, butterfly shaped hematoma or a called as a superficial perineal hematoma. Superficial perineal hematoma or a butterfly shaped hematoma. I hope you are able to understand. Okay, right. What else? On the digital examination, prostate will be normally palpable. That is what you need to understand. They might give you that. On the DRE, prostate is palpable. Okay, that's fine. So if at all they give you something like this, this is what is pointing towards anterior urethral. Hope you have understood, guys. Okay, so patient came after the road traffic accident, intense desire to pass urine, not able to pass urine, and on examination you have a superficial butterfly shaped hematoma. What are you dealing with? You are dealing with an anterior urethral. Okay, right. That is all about the urethral injury. So I'll just kind of summarize. Patient came, urethral injury, blah blah blah. Blood at meters, not able to pass urine, just desire to pass urine. Do not catheterize this patient. Do an RGU. If at all the urethral injury is absent, then pass catheter. If at all the urethral injury is present, then it may be anterior or the posterior urethral injury. So we talked about that. Okay. So what is this, guys? Can you please help me? Where is the stricture present in this particular patient? Okay. So I don't know whether again the image is kind of visible to you properly or not. Okay, but this is, let's say, A, B, C, and D. So can you please help me where if so this is C. Okay, this is C. So can you please help me where is the stricture present over here? A, B, or C, or D? Can you please help me with this, guys? Where is the stricture present in these? Okay, where is the stricture present in these? Okay, so guys, please understand the stricture is not present. This is what is a normal RGU. Okay, please understand this is a normal RGU. So what you're basically seeing over here, this bend, this is what is the where the bulbar urethra basically enters into the continues as the membranous urethra at the urogenital diaphragm. Please try to understand. This is a normal RGU. Do not mark this. This has also been asked to you. This is what is a normal RGU. Hope you have understood this, right? Now this is how the extravasation of the contrast out of the urethra will look and all those particular stuff. And yeah, over here, as you can see over here, what is happening over here? The prostate is high riding, prostate has kind of gone up, and there is a deep perineal hematoma present. This is what is going to be present in the posterior urethral injury. I'm very sorry for the image quality, guys, today, but I hope you are able to see. Okay, so this is what you need to understand over here. So images of the image are good. I think there's some problem with the software. So that's something which, okay, that's okay. It's okay. It happens, right? So here, what is there? There's a superficial perineal hematoma. Okay, this is what is a superficial perineal hematoma in the anterior urethral injury. Now, let's talk about the bladder. Okay, so this is what we have just covered. Okay, this is what we have just covered. That is what you need. Now, let's talk about the bladder rupture. Okay, so let's talk about the bladder rupture. So, what did I tell you about the bladder rupture? When are you going to say that, you know what, the patient is having a bladder rupture? If at all, the patient is coming to you and the patient is saying that, you know what, I have, like the patient has not passed urine for long time. Means that for, let's say, 15, 20, whatever hours or something like that. And what you need to understand is patient has not passed urine for a long time. And what you need to understand is patient has no desire, no urge to pass the urine. Okay, no urge to pass urine, and the patient has not passed urine for a long time. In this particular scenario, you will suspect a bladder rupture. Okay, now bladder rupture can be either an extraperitoneal bladder rupture or an intraperitoneal bladder rupture. So let's try to understand the difference between them. Okay, so how are you going to distinguish between them? Let's talk about the extraperitoneal bladder rupture. Bladder rupture. What are you going to get in the extraperitoneal bladder rupture? Here there is going to be associated with the pelvic fracture. Okay, it is associated with the pelvic fracture. What about else? So here, what are you going to get? Superficial perineal hematoma or deep perineal hematoma or something else? Okay, over here also we are going to get a deep perineal hematoma. Okay, so let's say if there is a patient who comes to you and patient is having a road traffic accident. After the road traffic accident, 18 hours has passed by. Patient has not passed urine. Patient has no urge to pass urine. You palpated the abdomen. There's no guarding, there's no rigidity. The bladder is not palpable, and you did an X-ray, and the patient is having a pelvic fracture. What do you suspect? You suspect an extraperitoneal bladder rupture. That's what you need to understand over here. This is how you kind of diagnose the patients of an extraperitoneal bladder rupture. How is the management of them? The management of an extraperitoneal bladder rupture is a Foley's catheterization. Okay, so what you need to understand is that if at all you pass a Foley's catheter, what is it going to do? It is going to go easily, right? Urethra is normal. So it is going to go into the bladder. And now what is going to happen? The bladder will get decompressed because the catheter is in place. Now the bladder will become decompressed. So what is going to happen? The edges of the bladder will come closer to each other, and now the healing process can take place. You understand my point? So this is what you need to understand about the extraperitoneal bladder rupture. Then let's talk about the intraperitoneal bladder rupture. Now what we are going to talk about? We are going to talk about intraperitoneal bladder rupture. Intraperitoneal bladder rupture. Okay, so what is the thing with the intraperitoneal bladder rupture? What is happening over here? Intraperitoneal bladder rupture is something which is associated with penetrating injury. If at all they say that there's a penetrating injury happened to the abdomen, and now the patient has not passed urine for like 20 years and there's no urge to pass urine and everything, then you will think in grounds of an intraperitoneal bladder rupture. What another mechanism they will give you? They will give you a scenario that, you know what, there's an over distended bladder, and now the patient is basically coming and kind of hitting on the suprapubic region. That might lead to the rupture of the bladder into the intraperitoneal. So a blunt trauma is a blunt trauma in over distended bladder. Okay, what is this? Blunt trauma in the over distended bladder. This is again one of the findings of your clinical scenarios of a intraperitoneal bladder rupture. Now, over here, what you need to understand, very, very important, on abdominal palpation. On abdomen palpation, what are you going to get? You're going to get guarding and rigidity. You're going to get a guarding and rigidity over here. Why? Because of the signs of peritonitis. Here there is going to be signs of peritonitis. That is why you're going to get the signs of guarding and rigidity. And because of the guarding and rigidity and peritonitis, the management is surgery. You have to kind of explore and you have to repair the bladder. You understand my point? Because intraperitoneally, the urine is going intraperitoneally. Obviously, it is going to cause irritation and is going to cause signs and features of peritonitis. Okay, so that's what you need to understand about this urological trauma, guys. So that's all I wanted to cover for you guys today. Now, somebody requested me for the sutures. Where did that comment go? Okay, Swati. Yes. So you want to learn about the sutures? Just give me some time. I will get back to you in a couple of days, and I will cover this particular sutures very, very soon. Okay. Today I have to leave. I have a flight to catch. I'll have to kind of. There's no way around it. But yeah, thank you so much for your patient listening. I hope this particular session helped you a bit, and I'm repeating it again, guys. These particular exams are different, but the surgery remains the same. So the basics of the understanding of the surgery is the same. What you need to understand about. Okay. So what you need to understand is it really doesn't matter which exam you're preparing for. What matters more is that what kind of questions are being asked. And if you have the understanding, the fundamental understanding of those particular topics are good with you, it doesn't matter if they ask you clinical based questions or one line questions or something like that, you will be able to answer it in a good manner. Are you understanding my point? For example, so you guys keep on kind of worrying about the FMG and the NEET PG or something like that. When you guys come to prepare for the FMG, you are taught similar kind of topics, right? When you kind of attend the sessions for the NEET PG as well. Forget about that. And even for the INI, if you talk about the most important topics of the INI, what you need to understand, the topics of the NEET PG and INI are 80-90% the same. Maybe 5 to 10% topics might be up and down or something like that. But broadly, if you have mastered the understanding of all the 19 subjects, it doesn't matter whether it's an INI or NEET or FMG or XYZ, you will kind of do. Okay, so with this, I'll just end, and all I'll try to say is a couple of things. Okay, so first of all the best for your exam. I hope that you are going to do very well. And yes, you have the INI exam. Obviously, you should go and give that with your full potential. And I'm pretty sure that many of you will kind of clear it very nicely. Let's say if at all you're not able to kind of, if your exam doesn't go that well or X, Y, Z reason happens, please do not lose your hope. Just continue your reading for your NEET PG exam. do at least one good revision before your NEET PG exam. That is definitely going to help you. One good revision. Good revision means 20-25 days you have to kind of give in order to revise all the subjects. And how are you going to revise? Please understand, whenever you start revising, always focus on your weaker subjects first. Like obviously all of us have some weaker points and stronger points or something. Start from the weaker subject, because at this point of time you are in a better pace of mind, you have a relatively more time in your hand or something like that. Start with the weaker subjects first, revise them, and then you move towards your stronger subjects or something like that. And do not kind of end up wasting a lot of time and now, because what you need to understand, your time is very, very precious. So sometimes it might happen that you sit with the books and your output is very, very less or something. So the good hack for this is self-introspect yourself. Okay, we all are humans, we all are going to screw up, you are going to waste some of the other time in your day, that's fine. But it should not be a majority part of your day. So the way to kind of handle this is that towards the end of the day, talk to yourself for around 5 to 10 minutes or something. Try to understand what you did right, what you did wrong, how you can improve and be a better version of yourself the next day. So just do this till your exam. All the best. I'm pretty sure that all of you will kind of do very, very nice. Thank you so much. This is Dr. Pawan signing off. And yeah, see you soon in some other session. Have a great time. Happy studying. Bye-bye. Take care.